if you had a positive urine analysis, you were not in the low risk group. If you had an ANC that was greater than 4,090, you're not in a low risk group. And if you had a PCT of greater than 1.71, you were not in a low risk group. If you had none of those factors, you were in a low risk group. All right, how did that rule do? So in the concurrent validation, I've highlighted the performance of the rule with the red box. So the rule had a high sensitivity of 97.7%, a modest specificity of 60%, but a high negative predictive value. SBIs were uncommon, and so the rule performed well in excluding those infants with serious bacterial infections. Subsequent to the derivation and validation of the rule, it's been modified slightly for clinical applicability. So urine analysis is still the best predictor. The ANC has been rounded to 4,000, and the PCT limit has been brought down a little bit to increase the sensitivity without much of a loss of specificity. So the three rules in the modified PCARN rule are listed here. This has been externally validated in those 1,300 subsequent infants that we talked about. And here's the performance for both SBI, so urinary tract infection, bacteremia, or bacterial meningitis. And again, the negative predictive value is very high. And then if you're really focused on IBI, invasive bacterial infection, again, the negative predictive value is 99.7%. That is to say, if you're in the low risk group, the chance that you actually have an invasive bacterial infection is about 3 in 1,000. So back to our case, we can't use our clinical judgment, but we can apply these clinical prediction rules. And currently, particularly if you have procalcitonin testing available in a rapid time frame, the PCARN rule is the best available rule to risk stratify these infants. So this infant is low risk by the PCARN rule that I just presented, so probably doesn't need a lumbar puncture and can be safely sent home without empiric antibiotics. So this infant went home, the cultures remained negative, they were rechecked by their primary pediatrician, and they did well. All right, we're gonna move on to the second case. This is again an infant 5 weeks of age with a febrile, temperature measured at 38.3, otherwise well appearing with no source on examination. This time the laboratory studies the white count slightly elevated at 12,000 with an ANC right on the cut point. The urine analysis is positive, but the procalcitonin is 0.3. So the issue again is lumbar puncture, and what's complicating the issue is the presence of the CSF pleocytosis. In a very nice study done by our colleague David Schadauer, who's now at Cincinnati Children's, he looked at a 20-center study of infants that were in the second month of life who had a urinary tract infection. And the main goal of the study was to look at how many of them had CSF pleocytosis or meningitis. So he identified 1,190 infants in that age group, and 18%, or 907, so 18% had CSF pleocytosis, although very few of them had bacterial meningitis. So the challenge is, if you know that infants with meningitis, young infants, are going to have meningitis, should you do a lumbar puncture or not? Although they have CSF pleocytosis or meningitis, they don't have bacterial infections very common. This is a recent meta-analysis of these infants where they look at the prevalence of bacterial meningitis. Each line represents a study. The point estimate is the prevalence of bacterial meningitis in the included population. And overall, the prevalence is 0.25%. So of all those infants with UTIs and CSF pleocytosis, only 0.25% had bacterial meningitis. So although we know there's a fairly high percent of having a CSF pleocytosis, it's a sterile pleocytosis. In the dreaded disease that we're looking for, bacterial meningitis is very uncommon. So what should we do? Back to our infant. It's probably very safe to not do a lumbar puncture, despite the fact that the infant has a positive urine analysis. You want to treat the urinary tract infection, and that can be done safely outpatient with an oral first-generation cephalosporin, and they can be sent home. In this case, the infant did grow E. coli, and as part of the follow-up, they had a renal ultrasound, which was normal. For our third case, we're going to talk about a younger infant, 11 days old, with an elevated temperature, who was otherwise well appearing. Maternal history was normal, birth history was normal. They were born vaginally, and the mom did not have any history of infections that she knew about. On the laboratory evaluation, the white count was 14,000 with an ANC of 7,000, a negative urine analysis. And because the infant was in the first month of life, most people routinely do a lumbar puncture. And so that was done as part of the initial evaluation. And the child had a mild pleocytosis with 50 cells, 40 red blood cells with a glucose and protein that were normal and a gram stain that was negative. So in this case, we would be thinking about bacterial infections and starting empiric antibiotics, but also need to pause and think about HSV infection. Should you send a test and should you start empiric treatment? So HSV frequency depends a little bit on your population, and I would be curious to hear about how frequently you see it in this population here in Saudi. But in the US, it is unusual. Most of the median age for presentation of neonatal HSV is about 14 days. So our infant at 11 days is clearly in the range where we're thinking about that, but it's uncommon. So when we look at all febrile infants, the frequency is only 0.42%. So it's even less than bacterial meningitis. So if we were to treat every febrile infant with empirically with acyclovir for HSV infection, we'd be treating a lot of infants who don't actually have HSV infection. In fact, you'd have to treat 142 infants in the first month of life and 556 infants in the second month of life to identify one patient with the actual infection. So when we look at the current management of HSV infection in US emergency departments, there's a lot of variability. And so this very colorful heat map looks at quartiles of people infants that were tested, infants that were empirically treated, and then actually cases. And as you can see, the colors vary. So there's a lot of variability in frequency of testing, empiric treatment, and actual prevalence of disease. And those are not necessarily statistically related. Can we do better? And I'm just going to mention this because I know this is part of Todd's talk coming up. But what factors are associated with HSV infection in the youngest infant? Youngest age, having a seizure, ill appearing, abnormal triage temperature, having a vesicular rash, thrombocytopenia, CSF pleocytosis, and prematurity. Our infant was less than 14 days of age, had an abnormal triage temperature, and had CSF pleocytosis, having 3 factors that are associated with HSV infection in this study. And so I think empiric acyclovir is likely warranted. So this patient was treated empirically with ampicillin and gentamicin for bacterial infections and received acyclovir. They were admitted. Their quick HSV test was negative, allowing the acyclovir to be stopped, and the blood and CSF, as well as urine cultures, remained negative as well.
5 minutes.
Perfect. So our last case is a more recent case and perhaps something that you've seen in your own emergency department practice. So we have a 7-week-old with a fever to 38.5. The parents come in and they know they have COVID infection. The infant looks healthy. I think you've seen that baby before, we all have. And so the laboratory studies are reassuring. Urine analysis is negative, the procalcitonin is low, below our cut point, and this infant's test, if you can get it rapidly, is positive. Although we would have presumed it was positive based on the exposure history and the parents' testing. So what should we do? Should we do a lumbar puncture? Should we keep the child? This is a challenge because we were forced to make these decisions real time and quickly, but we don't have all the available evidence. And so we had to do the old risk stratification strategies. Are they appropriate in this clinical setting? So I'm going to highlight one really nice study. The author of this study is our presenter here today, Manoj's wife, who's a general pediatrician at Children's Hospital of Philadelphia. And she did a really nice study to inform this decision-making that I'm going to highlight here. So what they were looking at is at 6 community hospitals associated with the Children's Hospital. They looked at infants presenting with fever. And they had a pre-pandemic period, which was the year before the pandemic, the first year of the pandemic, and then the second year after the pandemic. And so in the first year, there were 231 infants that presented with a fever. In the second year, there were 217. And then in the third year, there were 95. Within those groups, we had a dramatic decline in the number of patients that were, so I'm so sorry. So the 2 higher numbers were the 2 pre-pandemic years, and then the 95 were the post-pandemic year. So we had a dramatic decrease in the total number of infants presenting. But what we see here is the rate of bacterial infections in the post-pandemic years compared to the pre-pandemic years actually went up. So although we had fewer cases presenting, they were more likely to have a bacterial infection. That's likely multifactorial, partly because the sicker kids were coming, the healthier kids were staying at home, And we all were practicing, good masking. And so there was a lot less other viral illnesses, even for the youngest infants. So a nice study that informs our decision-making that the prevalence of infection of the infants that actually show up appeared to be higher, but the number of infants we were seeing was dramatically declining. So what should we do? There's a little uncertainty, but I think the clinical prediction rules that we derive from looking at other viral infections likely apply. So avoiding a lumbar puncture is probably safe. If the child has any respiratory symptoms in the setting of COVID infection, it's a good idea to get a chest radiograph. But in this case, the child was not treated with antibiotics and they were sent home with close follow-up and fortunately did very well. Okay, in summary, how you manage fever does vary by age. In this small limited age range, we think about infants in the first month of life differently than in the second month of life. And we have good available prediction rules that help us risk stratify and identify low-risk infants who can safely avoid lumbar puncture, can be treated at home, potentially without parenteral antibiotics. The P-card febrile infant is a very good rule, which has now been derived and validated. The impact of COVID-19, which hopefully we won't have to be thinking about so much going forward as we have in the past, is a little unclear, but we have some good data that's helping us to inform the decision. If you're thinking about the youngest infants, you have to think about HSV infection, and we have some good risk factors, although it's a very unusual infection. So thank you very much. We'll stay on schedule.
Session of the investigation would be about the 2021.
Thank you very much. Good morning. It's a pleasure and an honor to be here. As these slides get loaded, my talk this morning, the first talk, is going to be a literature review of literature from 2021. Let's see if we can get loaded up. Fantastic. This is great. This is perfect, actually. So I have nothing to disclose. I have funding from the National Institutes of Health in the United States and the Gerber Foundation. So it's a daunting task to be asked to present about sort of the best studies in a year in our field. There's absolutely no way that we can include every outstanding study that was published in 2021. It's not meant to be a systematic review or comprehensive review of every study that was done in pediatric emergency medicine. But I do want to tell you a little bit about my methodology. I went on to PubMed, which is our national, national library search engine, and I performed a comprehensive literature search. I polled my colleagues in pediatric emergency medicine, and then I reviewed all studies that were listed on pemdatabase.org from 2021. And I selected studies for this talk based on their methodological rigor, based on their clinical applicability, and based on their variety of topics. We could easily have filled this talk with studies of pediatric COVID-19, but I chose not to do that and included one study that I think is critical to our initial treatment of COVID-19, but for the rest of the studies included a variety of topics. Important to consider that very few of these studies, as is the case with most studies, are definitive practice-changing studies. But I think that each of these studies individually gives us food for thought about how we continue to practice in the pediatric emergency department. So the first study that I'm going to present is entitled Association of Oral Corticosteroid Bursts with Severe Adverse Events in Children, and this was published in JAMA Pediatrics. This study sought to identify the association of corticosteroid bursts with severe adverse events, including GI bleeding, sepsis, pneumonia, and glaucoma, known complications of immunomodulatory agents such as corticosteroids. This was an administrative database study. So this occurred in Taiwan. They used their National Health Insurance Research Database over 4 years, from January 2013 through December 2017. The exposure was an oral corticosteroid burst, and it's important to understand how this is defined. In this study, this was defined as a burst of corticosteroids over a 14-day period. So longer than our typical treatment of, let's say, an acute asthma exacerbation, as Dr. Shah talked about yesterday, but still typical within sort of a typical burst of steroids for other conditions. They studied 4,550,000 children. And of those children, 1 in 4 received an oral corticosteroid burst. So about 1 million kids. And what they found was that among these children, the incident rate ratios, or IRR, within 5 to 30 days after initiating a corticosteroid burst was 1.14 for GI bleeding, 2 times increase for sepsis, 2 times increase for pneumonia, and no change for glaucoma. And what's important, you can see that increased risk. Oh, let's see. It's not quite showing, but I can, if you look at the dots that are towards the right side of the screen, the squares, you can see the increased risk in the 5 to 30 day. But what you can also appreciate is that by days 31 to 90, that this risk was attenuated and there was less risk in that period of time. And so the conclusion from this study is that corticosteroid bursts in the immediate period, the immediate month after receiving the burst, was associated with a 1.5 to 2.5-fold increase risk of GI bleeding, sepsis, and pneumonia, but that risk is then attenuated for the subsequent 31 to 90 days after. The next study was actually published by my colleague at Lurie Children's Hospital of Chicago, Mary Clyde Pierce, who's really an internationally known expert in the field of child abuse. And this is a really important study. And this, I do consider this to be a practice-changing study. This was a validation of a clinical decision rule to predict abuse in young children based on bruising characteristics. This is a common presentation. Kids present with bruises all the time. And the clinical challenge for us in emergency is to be able to differentiate accidental bruising from non-accidental bruising. And so the objective of this study was to refine and validate a previously derived bruising clinical decision rule. This was done as a prospective cross-sectional study over 5 years at 5 urban children's hospitals in the United States. This was the rule that was validated. And you can remember the rule by an easy mnemonic, 10-4 faces P. And so the 10 stands for torso, ears, neck. These are places where children should not be routinely bruising. So if you see bruises on the torso, the ears, or the neck, and then faces stands for frenulum, the angle of the jaw, the fleshy part of the cheek, eyelids, or subconjunctiva, or whites of the eyes. Those are regions that should not be bruised accidentally. Similarly, the 4 is 4 months or younger. Any bruise anywhere on a 4-month-old baby or younger should be considered suspicious. And then patterned bruises is the P, bruises in specific patterns, hand marks, belt loops, that sort of thing, plugs. And so 10-4 faces P was the rule. And what you can see here is that the BCDR, the bruising clinical decision rule, was highly sensitive, 95.6% sensitive and 87.1% specific for distinguishing abuse from non-abuse based on these body regions. And so in this study, the conclusion is that an affirmative finding of any of 10-4 faces P should be considered as potential risk for abuse. The next study, entitled Serum Sodium Concentration and Mental Status in Children with Diabetic Ketoacidosis, or DKA, was published by our colleagues in the Pediatric Emergency Care Applied Research Network, or PECARN, as part of a randomized trial of fluid speed and fluid concentration in resuscitating children with DKA. And in retrospective studies, the background for this is that researchers have found associations between serum sodium declines during DKA resuscitation and cerebral injury. And so the goal of this study was to prospectively investigate the determinants of sodium concentration changes and the association with mental status changes during DKA. And so they used data from this PECARN trial, and they looked at a host of outcomes, which you can see here, including GCS score, Glasgow Coma score, and then other things that are indicative of cerebral injury, digit span, other sort of memory tests. And what this study found was that declines in glucose-corrected serum sodium concentrations were associated with higher sodium and chloride concentrations at presentation, and also with a prior diagnosis of diabetes before presenting with DKA. Generally, treatment with half normal saline compared to normal saline was also associated with declines in serum sodium. However, what this table shows is that there were no differences in neurological outcomes at 4, 8, or 12 hours after presentation in those children whose glucose corrected sodium remained stable or increased versus those that decreased. So changes in glucose corrected sodium during DKA treatment are influenced by the balance of free water versus sodium loss and the sodium content of the intravenous fluids that's used to resuscitate. And declines in glucose, this is a bit of a myth buster because this study did find prospectively that declines in glucose corrected sodium concentrations are not associated with mental status changes during resuscitation for diabetic ketoacidosis. So this next study, very important study, Dr. Gaucher-Hill is on this study as a co-author. And this study looked at the evaluation of emergency department pediatric readiness and outcomes among US trauma centers. This is a critically important study because we know that 85% of children who seek emergency care in the United States seek emergency care at general emergency departments or community emergency departments that are not pediatric specific emergency departments. And so the work of Dr. Newgard, Dr. Gaucher-Hill, and others, many others, has looked at developing a pediatric readiness score to ensure that community emergency departments, general emergency departments are fully prepared to care for children across the age spectrum and across the severity spectrum. And what this study found, importantly, was that children in the highest quartile of pediatric readiness EDs, so those EDs that are most well prepared to take care of children, labeled as the fourth quartile here, were significantly less likely to have mortality, high injury severity scores, high abbreviated injury scores, and higher resource needs to have decreases in mortality the more ready they were in terms of pediatric readiness. And that showed for mortality, but not for complications, which you see on the right side of this screen. And so in this cohort study, the conclusion was that injured children that were treated in high readiness EDs had lower mortality compared with similar children in low readiness EDs. And that if children cared for in these lower readiness EDs were cared for in highest readiness EDs, that an additional 126 lives might be saved every year by increasing pediatric readiness at these general EDs, critically important. Oh, sorry. So this is the one COVID study that I promised you. This was published in the New England Journal of Medicine about multisystem inflammatory syndrome in children, initial therapy and outcomes. And this study looked at surveillance data on inpatients younger than 21 years of age who had MIS-C and were admitted to one of 58 US hospitals in 2020. And this study evaluated the effectiveness of IVIG plus glucocorticoids versus IVIG alone. And what you can appreciate in the propensity score matched analysis and in the inverse probability weighted analysis was that IVIG plus glucocorticoids were better in outcomes of cardiovascular dysfunction and secondary outcomes of left ventricular dysfunction, shock requiring vasopressors, adjunctive immunomodulatory therapies, and persistent or recurrent fever. So that this study concluded that among children and adolescents with MIS-C, that initial treatment with IVIG plus glucocorticoids was superior over IVIG alone. And in fact, this has informed practice, and certainly in our center, this is the initial standard treatment, this combined therapy for children with MIS-C. This study was published by the NEAR investigators, or the National Emergency Airway Registry, which is an observational 25-center registry of ED intubations. This is an adult study, but went down to 14 years of age and has weight-based dosing of rocuronium. So I thought it was relevant to our pediatric population. And what this study looked at was 8,034 rapid sequence intubations. And they looked at the doses. The standard dosing of 1 milligram per kilogram, 1 to 1.1, 1.2 to 1.3, and 1.4 milligrams per kilogram of rocuronium. And what this found was that first attempt success rate was higher in those that received 1.4 milligrams per kilogram of rocuronium or greater compared to the standard dosing of 1 milligram per kilogram of rocuronium. And so this concluded that rocuronium dosed at greater than or equal to 1.4 milligrams per kilogram was associated with higher first attempt success when using direct laryngoscopy with no increase in adverse events. And what's interesting, if you look at the graph on the right, is that video laryngoscopy, indicated by the line in red, there was no difference across dosing, but this difference was seen with direct laryngoscopy. Again, this is a retrospective study, not meant to change our practice immediately, but things that make you go, So the next study was, I cheated a bit. This was published in early of this year, Videographic Assessment of Tracheal Intubation Technique in a Network of Pediatric Emergency Departments, a report of the Viper Collaborative. The Viper Collaborative is an outstanding multi-center collaborative in the United States of video review. So these institutions have continuous video recording in their resuscitation bay to be able to look at a whole host of outcomes in critically ill children that present to the emergency department. And this study looked at data from 494 intubations. The first attempt success rate was 67%. The median laryngoscopy duration was 35 seconds, and hypoxemia occurred in 15% of the patients. What this study found was that attempts in which video laryngoscopy was used for the entire procedure compared to direct laryngoscopy had a longer duration. So the difference in medians was 6 seconds longer with a 95% confidence interval of 1 to 12 seconds. And intubations longer than 45 seconds, so blade in the mouth for more than 45 seconds, had a greater incidence of hypoxemia versus shorter time of blade in the mouth. So 29% incidence versus 6%. However, what you can see here is that there were no differences otherwise in terms of success rates or the incidence of hypoxemia. So the conclusion was that video laryngoscopy use was associated with a longer laryngoscopy duration, however, was not associated with the success rate, first pass success rate, or with the incidence of hypoxemia. The next study, we talked about a little bit in our panel discussion yesterday on PCR testing and antimicrobial stewardship, was a randomized trial that looked at the effect of rapid respiratory viral testing on antibiotic prescribing among children presented to the emergency department with acute respiratory illness. This is a topic near and dear to my heart and my professional passion. This was a really great study. They randomized participants to either have the clinicians receive the results of a multiplex PCR testing or to use standard care without the results of multiplex PCR testing. And they found some really interesting results. They looked at 931 ED visits, 452 children in the group that received the results, and 452 in those that did not. And what they found was that after propensity score weighted analysis, that children with test results were more likely to receive antivirals, 2.5 times more likely to receive antivirals. And you can see that in that first column on the left in prescribing oseltamivir. You can see that after the results came back, that providers were more likely to provide oseltamivir, but that interestingly, there were no difference in antibiotic prescribing. So knowing the results of a rapid respiratory multiplex PCR panel did not change physician antibiotic prescribing behavior. This study, I think, is also a single center study. It has those limitations, but it's very important and relevant to our care. Dr. Vittal spoke about high flow nasal cannula yesterday during his talk on respiratory failure. This was a single center study at Cincinnati Children's Hospital Medical Center that looked at trends and outcomes in high flow nasal cannula use in a pediatric emergency department. This is a retrospective cohort study of children 2 to 24 months of age. Primary outcome was high flow nasal cannula initiation. The secondary outcomes were things like admission rate, ICU admission, transfer to the ICU after arriving on the general inpatient ward, and endotracheal intubation. And they performed an adjusted interrupted time series analysis to look at changes over time. And what they found was that in 11,149 children with bronchiolitis, 902 or 8% were initiated on high flow nasal cannula in the ED. And that the rate of high flow nasal cannula initiation increased from 1.3% in 2012 to 2013, all the way to 17% in 2018 to 2019. And importantly, less than 30% of children that were initiated on high flow nasal cannula were hypoxic. So 70% of children did not have hypoxia that were started on high flow nasal cannula in this cohort. And what they found in terms of outcomes was that there were no significant, despite this 17-fold increase in the use of, 13-fold increase in the use of high flow nasal cannula over this period, there were no significant changes over time in admission, PICU admission, transfer to PICU, or intubation. So they found a 13-fold increase with no evidence of improvement in clinically meaningful outcomes. And I think this suggests that we really need to look very closely at our use of high flow nasal cannula as a therapy for bronchiolitis in the emergency department. And really, we need better predictive tools to be able to assess which children are most likely to benefit from the initiation of high flow nasal cannula in terms of meaningful outcome change. This study is the SCOUT-CAP trial, or short course versus standard course outpatient antibiotic children for community-acquired pneumonia in children. I cheated on this too. This was published in early 2022, but there were two other studies, one out of Canada and one out of the UK, that were published in 2021. So I felt that I wasn't cheating that much by including this study in this summary. And what this study did was a randomized trial to compare 5 days versus 10 days of amoxicillin in children with outpatient mild community-acquired pneumonia. They randomized, how many children did they randomize? They randomized 380 children to short course versus long course. And what they found is they found no differences when you look at all of these individual outcomes. That vertical line down the center means no difference. You can see that all of the confidence intervals cross that vertical line. And so they looked at clinical response, persistent symptoms, antibiotic-associated adverse events. And when you looked at those individually, there were no differences between short course and long course. But importantly, they used a composite outcome that noted that for patients with the same clinical outcome, if you got more antibiotics, you got dinged. If you got more antibiotics, that was considered a negative thing in children with equivalent clinical outcomes. And when they looked at that outcome, they found that the children that received short course, 5 days, had a 69% probability of a more desirable outcome compared to standard course strategy. And so in this study, the conclusion was that among children responding to initial treatment for outpatient pneumonia, that a 5-day antibiotic strategy was superior to a 10-day strategy, and that the shortened course resulted in similar clinical response and antibiotic-associated adverse effects while reducing antibiotic exposure. And the super cool thing about this study is they did nasal swabs of all these children to look at resistance genes in the nasopharynx. And they found that actually there was decreased expression of resistance genes in those children that received 5 days versus 10 days. So this suggests that a shorter course has similar clinical outcomes, but has a meaningful ability to decrease antimicrobial resistance in the acute management of kids with pneumonia. And this is the last study that I will share. This is the study that Dr. Nigrovich had just presented, Predictors of Invasive Herpes Simplex Virus Infection in Young Children. Dr. Cruz from Dr. Shah's institution is first author. And this was a study of the Pediatric Emergency Medicine Collaborative Research Committee. This is actually the sort of research arm of the section of emergency medicine at the American Academy of Pediatrics. And this was a study of 23 centers, a nested case control study that was executed within the Pediatric Emergency Medicine Collaborative Research Committee. And this study found, as Dr. Nigrovich shared, that this study developed a risk for invasive HSV in young infants. And the odds ratios, or beta coefficients of the score that Dr. Nigrovich presented were then converted to a points-based system, which you can see here on the left. And if you had a score that included younger age, seizures at home, and ill appearance, abnormal triage temperature, which is defined as a temperature of 38 centigrade or greater, or less than 36.4 degrees centigrade as a definition for hypothermia. A vesicular rash, thrombocytopenia defined as a platelet count of less than 150,000, CSF pleocytosis defined as a CSF white blood cell count of greater than 15 cells per millimeter cubed if less than 28 days, or more than 10 cells per millimeter cubed if greater than 28 days, and then prematurity defined as birth before 37 weeks gestation. And if you had a score of 3 or more, that score had a sensitivity of 95.6% and a negative likelihood ratio of 0.11 with an area under the receiver operating characteristic curve of 0.854, suggesting that a score of less than 3 suggests that we can identify a group of infants at very low risk for invasive HSV infection using this score. So some takeaway points from this whirlwind tour of pediatric emergency medicine literature in 2021. Corticosteroid bursts were associated with a 2-fold increased risk of GI bleeding, sepsis, and pneumonia within the first month that was attenuated. 10-4 FACES P was, it can be used to identify non-accidental bruising based on body region, infant 4 months or younger, or pattern bruising. Declines in glucose-corrected sodium concentrations are not associated with mental status changes during DKA treatment. Injured treatment that are treated in high readiness EDs for children had lower mortality compared with similar children in low readiness EDs. Among children and adolescents with MIS-C, initial treatment with IVIG plus glucocorticoids was associated with a lower risk of new or persistent cardiovascular dysfunction than IVIG alone. A higher dose of rocuronium was associated with higher first attempt success using DL among patients with pre-intubation hypertension and no increase in adverse events. That video laryngoscopy was associated with longer duration of laryngoscopy, but showed no differences compared to DL in success or incidence of hypoxemia. Multiplexed respiratory PCR testing does not change antibiotic prescribing behaviors for respiratory infections, but does increase the rate of antiviral treatments. High flow nasal cannula use has increased more than 10-fold over time with limited changes in clinical outcomes. Among children responding to initial treatment for outpatient pneumonia, a 5-day antibiotic strategy was superior to a 10-day strategy. And finally, we now have an HSV risk score for invasive HSV infection in young infants that consists of younger age, seizures, ill appearance, abnormal temperature, vesicular rash, thrombocytopenia, CSF pleocytosis, and prematurity. And with that, I will hand it off to the next speaker. Thank you very much.
So thank you. From the infections, we're going to turn to minor head trauma with special considerations. Okay, so testing. Perfect. So the objectives of this next 30 minutes is to talk about the best available evidence to guide the management of a child with minor blunt head trauma. We're going to talk about different approaches to neuroimaging. We're going to talk about validated head trauma clinical prediction rules, and then to look for the role of observation in the management of children with isolated head injuries. So this figure here looks at the number of emergency departments to US centers for head injuries. This is not just for children, but also for adults. And on the x-axis, you have time, 2006 through 2010. And the filled in circles are all ED visits. And the open circles are visits for traumatic brain injury. And so what you see here is that over this time period, there was a slight increase in the total number of ED visits, but a dramatic increase in the number for head injuries. This does not reflect probably an increase in actual number of head injuries, but the level of concern of the parents and the patients around head injuries. And so what we're seeing is an increase in this complaint in our emergency departments, but we're seeing a lot of not very severely injured children. So the challenge for the clinician becomes, how do you find those with clinically significant traumatic brain injuries, but also at the same time limit unnecessary imaging tests? Significant injuries are rare. The diagnostic tests that we do, which is mainly CT scan, and we'll talk a little bit about that, have some risk of radiation. And so what we need are tools to stratify infants and children that help us and guide that decision making. So we'll look at the types of studies available to us in the emergency department, which are essentially skull films, CT, and MRI. So skull films are actually a series of 4 films. I've shown 2 candidate images here. They're easy to obtain, but their interpretation is challenging. So if you're not familiar with looking at skull films, it's hard to see, is that a fracture? Is that a suture? And importantly, there's no evaluation for intracranial injury. So if you see a fracture, which is what you're looking for on a skull film, you don't know if there's an underlying injury of the brain. And so they're not used very commonly for that very reason. CT is the gold standard and the most common approach to the evaluation of children, but there are some risks of CT scans, and those are risks of malignancy down the road. There's some debate of how high that risk is, but the best estimates are approximately 1 in 1,500 if you're 1 year old when you have a head CT scan. And there's some variability about how much radiation and how much dose adjusting the actual scan entails. But if you're older, it's probably 1 in 5,000, so a lower risk as you get older, which reflects both the cells in an older child are not dividing as rapidly, and you have fewer years of life ahead. But those numbers, although small, put in a different perspective. The lifetime risk of malignancy worldwide is about 24%. About a quarter of all deaths are from malignancy. And so having a single CT scan is going to increase that from 24% to 24.07%, which to a parent sounds very different than 1 in 1,500. So it's just sort of an illustration of how you frame risk it affects the interpretation. What about MRI? There's increasing interest. Typically for trauma, you're not doing a full brain MRI for a pediatric patient, but something called a rapid cranial MRI. They're vent check MRI, a rapid cranial, and they can be done quickly, so they would be possible for trauma, but there's a limited literature of how good they are at picking up significant injuries. The best study was published in 2019 by Dan Lindberg in Pediatrics, and he had a series of 223 children who had both a CT and an MRI performed. And of the 111, which had a positive CT, as was defined in the study, 103 had a positive MRI, 2 had an equivocal MRI, and 6 had a negative. And so that's a sensitivity of 90% and a specificity of 96%. So those that were not identified, those findings that were not identified on MRI were minor intracranial hemorrhage or other findings without needing surgical intervention. But there are findings that we see on CT that we don't see on MRI. And so we need to further delineate that before rapid cranial MRI becomes our gold standard. What about incidental findings? Whenever you do cross-sectional imaging or any type of imaging, you have to be prepared for things you weren't looking for. So these would be findings that are not related to the trauma, but need to be interpreted and followed up on. So if you don't include sinus disease, because if you did a CT on many of us in the room, we might see some mucosal thickening or swelling of our sinuses. This large study of 15,000 CT scans of the head done for trauma found that 4% had incidental findings. Very few of those incidental findings needed immediate management. A few of the children in the study actually had brain tumors identified at the time of their CT for head trauma. But most of them, or a quarter of them, needed some outpatient follow-up, some additional clinical evaluation, and 70% were incidental and no follow-up needed. But it is an important unintended consequences of the imaging studies that we do. Likely, if we do MRI, which is a more detailed architecture of the brain, we may have actually more incidental findings, and we'll have to be prepared for dealing with that. Okay, so if we don't want to do CTs on low-risk patients, how can we decide? We have a really high-quality study led by Nate Cooperman from UC Davis, or the PCARD TBI rules, and I'm interested to hear if they're used here in the Kingdom of Saudi. But this is a study which has changed practice in the US and many parts of the world. Involved 25 sites in the Pediatric Emergency Care Network, and they looked at kids less than 18 years of age with non-trivial blunt head trauma. So the outcome of interest was something called clinically important traumatic brain injury. They didn't want to identify necessarily all intracranial hemorrhage, but rather findings on the CT scan that would affect practice. So what were they looking for? They were looking for children that died from their head injury, who needed an emergent neurosurgical intervention, who were intubated for more than 24 hours for their head injury, or needed 2 or more nights in the hospital for management of their head injury. The study was quite large and enrolled 33,000 children in a derivation cohort and another 8,000 in a concurrent validation cohort. And they came up with 2 rules. They did a rule for children less than 2 years of age and one for children greater than 2 years of age. And the reason why it was dichotomized at 2 years of age is that's approximately when children become verbal or consistently verbal. And so in the youngest children, you can't use subjective symptoms like, do you have a headache or how are you feeling? And so they wanted to examine those groups differently. Also, the mechanisms of injury and the types of injuries are different. And so they felt it was clinically important to look at these groups separately. So the factors included, the 2 high-risk factors are GCS 14 or other signs of altered mental status or palpable skull fracture. And in that group, that was 13.9% of the population and a 4% risk of clinically important traumatic brain injury. The other 4 middle risk factors were a non-frontal hematoma, an LOC of 5 seconds or more, severe injury mechanism, or not acting right. If you had any of those factors, you were in a middle risk group, which was 1/3 of the patient population and a 1% risk of clinically important traumatic brain injury. If you had none of those factors, you were in a low risk group, and that was more than half of the study population, and the risk of clinically important traumatic brain injury was very low, less than 1 in 1,000. Again, there's 2 rules. The rule for kids greater than 2 is very similar. Again, GCS 14 or other signs of altered mental status or signs of basilar skull fracture. The middle risk factors in the older kids were any LOC, history of vomiting, severe headache, or a severe injury mechanism. Again, you have the middle risk group and the low risk group. How well did this rule do? It did very well. In the concurrent validation, so that's the 8,000 infants that were enrolled at the same time, the sensitivity was 100% in kids less than 2 and 96.8 in kids greater than 2. It did miss 2 children who had fallen downstairs, so they didn't have a severe injury mechanism, but they had fallen down multiple stairs. The severe injury mechanism was defined by the height of the fall, and each stair is a series of smaller falls. So indicating that clinical decision rules do not replace clinical judgment, they supplement it. And so as a clinician, you might take that into account as well. There's been additional external validation studies as well. And Franz Babel from Australia did a very nice external validation, included 15,000 children. He compared 3 available head trauma rules. The one that performed the best was the PCARN rule. And again, it had very high sensitivity and modest specificity in both age groups. So we have this really good rule. The next step is validating it, getting the evidence into practice. We've talked about the gap between evidence in the published literature and actual practice. In the area of head trauma, there's been some good work of implementing this high quality evidence into practice. So how can you do that? One approach would be just to make a guideline and publish that guideline to your practitioners. And that's a very effective strategy and low budget and easy to do. Secondly, you have the calculators, and then in a more advanced way, I saw at the Fuzzle Children's Hospital, you use a Cerner informatics system. You could build these rules right into your informatics system so that this evidence was available to you at the point of decision making. So we'll take you through this. An evidence-based guideline is just you get together with your clinicians in your local group or your region or your society, something like the American Academy of Pediatrics, and you say, this is how we should manage children with head trauma. It's best if it's based on high quality evidence like the PCARD decision rule, but implementing this type of practice can affect change. Here's an example at my local institution where we implemented an evidence-based guideline. And what we did, we tracked the CT rate over time. A statistical process control chart is a method of following practice change over time when you're doing quality improvement methods. And so we started with a 20% baseline, 21% baseline CT rate. We implemented a guideline. The rate went down to 15% of children with head injury visits. And then we did some individual performance review feedback, and that rate went down further. MD Calc is a widely available application and website which translates evidence-based guidelines at the point of care. I'm not sure if it's used here in the kingdom, but it's widely used in the US, where you are reminded of the clinical decision rule. You pull out your phone, you can type in the predictors, and it'll give you an estimate of the risk right at the time you're taking care of the patient. And then the gold standard is actually to embed these implementation tools in the electronic health record. And our colleague, Peter Dayan, did some really nice work in an Epic-based system. This is a BPA, or a computerized decision support tool that was built into the computerized system, where it asked for the factors that are included in the PCARN decision rule at triage. So the nurse that was first assessing the patient collected some information that was then validated by the clinician, and then you were given some decision support, which was really the estimate of risk in that individual patient right at the time you were caring for them. How well did that do? It actually did very well at decreasing the CT rate. So it was done as what's called a cluster randomized study. So there were 4 general EDs and 4 pediatric EDs that were included. 1 did not get the intervention, and that was called the control hospital. And what this is the dotted line is the time when the computerized intervention was turned on. It was turned on at slightly different times at each hospital, but they had the same period of time before and after. And at the intervention hospitals, the availability of the decision support was associated with a 9% decrease in the CT rate, where there was no change at the control hospital. We have great evidence. We are trying to get it into practice. Is it working? This is a national study looking at head trauma visits to all emergency departments, pediatric and general EDs. And unfortunately, despite all these efforts, it looks like in the US, the head CT rates are relatively constant. So if you look over this period from 2007 to 2015, of all head trauma visits, 30% of children are receiving a head CT, and that's been constant despite education about the risks of CT, the availability of the PCARN rules, and a specific education campaign done by the AAP called Choosing Wisely, meant to reduce CT rates. So although there's knowledge, there's tools for implementation, it's still hard to change practice. And so that's why we need to do better in that regard. So with the available time I have left, and I'll trust that I'll be reminded, we're going to go through a couple different cases. So this is where I work. This is the street view. And so these are all children that are presenting to the emergency department. So this is a 15-month-old who fell from the shopping cart. They were sitting in the front. They took a dive over the top. The parent describes there was a brief loss of consciousness. You see a little abrasion and a hematoma in the front, but they're otherwise acting normally. So you would see the child. This child is napping now, but they wake up and they're alert and they're oriented in front of you in the emergency department. So when you see this child, you're going to be calculating the height of the shopping cart, guessing how far they fell. But the definition of a severe injury mechanism is 3 feet or more in a young child. So you're guessing they fell probably around 3 feet from the shopping cart, and they had a brief LOC. So they have 2 of the middle risk factors for a traumatic brain injury based on the PCARN rules, but they look really good in front of you. So what should you do for this particular child? So the clinical decision rule is low risk versus not low risk, but there's really a lot more evidence that we have in terms of the actual risk in the individual patient. And so because the study was large and well designed, there have been a number of subsequent studies that look at the risk at each of the individual risk factors. And so this table, which is available in the individual studies as well as up to date, if that's a reference that you use, if you have one of the PCARN middle risk factors, the risk is still quite low that you have a significant injury. But when you start to have 2 or 3 factors, that risk goes up. So that is to say that if you have one of the middle risk factors, you probably don't need to go ahead and do a CT. But if you have, you start to have 2, 3, 4 factors, and your child doesn't look that well in front of you, the risk becomes higher. So what are our strategies? Observation can be a really effective strategy when you're not sure. The patient's not at low risk, but they have some factors. And that is a simple strategy where you're just going to watch the child and see how they do over time, over the matter of a few hours. And if the symptoms stay the same or worsen, you're going to go ahead and get a CT scan. And if the symptoms improve, then you feel good about sending them home. This can be challenging in a busy emergency room where you have a lot of patient turnover. They don't necessarily need to be in an acute care room. They can be in the waiting room and called back for reassessment. Does this strategy work? And I would say yes. We had done a secondary analysis of the initial PCARN study, and those patients who were observed, because we collected information about clinician practice, had a much lower CT rate. In fact, the adjusted CT rate for severity of injury was almost half in the group that was observed compared to the group that was not observed, but despite a similar rate of clinically important traumatic brain injury. So the strategy works for those that are symptomatic. If you're able to wait, many children with a dose of Motrin, a dose of Zofran look miraculously better in an hour or 2 hours, making the clinical decision-making much easier. Okay, so in this particular case of a child with 1 or 2 factors in the middle risk group, observation is a particularly great strategy. And if they looked good for several hours in the emergency department, they could be sent home without imaging. In our second child, here is a 5-year-old who fell out of a tree on her head. She didn't have any LOC. She did complain of a headache, which she said was mild. She had vomited. But importantly, this child has von Willebrand's disease, or a condition which might increase her risk of bleeding. And is that going to change your approach to the evaluation? So in terms of the PCARN rule, you'd have to get some information about the tree and the height of the fall, but a severe injury mechanism for an older child is a fall of 5 feet or more. And let's say this tree, she had fallen from more than 5 feet or more than 3, it actually is in feet, but is that about 3 meters or so of height from the tree? But should the coagulopathy that you have affect your decision making? So again, because this study was so large, they enrolled, and the PCARN study was so large, they enrolled 230 children who had underlying coagulopathies in the head trauma study. And they were able to look at whether the risk of clinically important traumatic brain injury was different in those with and without the coagulopathies. And so it was a variety of coagulopathies and other bleeding disorders. So hemophilia, von Willebrand's disease, thrombocytopenia, so ITP and other conditions, and then being on therapies that affected your bleeding and clotting time. And so interestingly, the kids that had these coagulopathies were much more likely to have a CT scan. Not surprising, right? That affects the rate of concern in the treating clinicians appropriately, but the rate of hemorrhage was actually lower in those that had coagulopathy versus those that not. That's hard to interpret because more kids are getting a scan, but less injury. But overall, having these bleeding disorders didn't seem to dramatically increase the risk of actually having intracranial hemorrhage after minor blunt head trauma. So how should we affect in this case? We have a child who fell 5 feet from a tree who had von Willebrand's disease. I think we can use our clinical judgment. If they're well appearing with no signs and symptoms of a significant head injury while they're in front of you in the emergency department, observation without a CT is probably a safe strategy. If they are more symptomatic, then a CT scan is the right way to go. Okay. Our next case is a 2-month-old who fell off a changing table. No loss of consciousness according to the parent. They say they're acting normally, they're not vomiting, they're eating well, but there is a temporal hematoma on your examination. So in this child, it is probably appropriate to go right to imaging. A swelling of the temporal area makes you suspicious for a skull fracture, which is what I've shown here on the CT scan. On the soft tissue windows, you have the swelling of the area, and on the bone windows, you have a non-displaced isolated skull fracture with no intracranial hemorrhage. So what do you do? So you have a child who fell off the changing table with an isolated skull fracture. Is this a serious injury or not? And what we know is that the risk of clinical deterioration is very low in those children that have a skull fracture. In fact, we did a meta-analysis looking at all published studies of children with an isolated skull fracture led by Silvia Bressman, who's a peds emergency physician in Padua, Italy. And that in that meta-analysis, we were able to include more than 6,000 children, and only one had clinically a deterioration or required neurosurgery. So the risk is really low. However, in the US, there's a lot of these children that are admitted, and there's a lot of variability of care. So this graph looks at hospital level admission rates for isolated skull fracture by region in the country. But basically 80% of children are admitted, but some hospitals admit very few and some admit very many. And in all cases, none of them needed intervention during their time in the hospital. So just to say that isolated skull fractures are relatively minor injuries and probably do not require hospital level of care, but at least in the US, many of them are hospitalized, and it's resource utilization we're working to reduce. Another thing to just emphasize the importance of thinking about non-accidental trauma. We're going back to our history. This is a 2-month-old who hasn't perhaps started to roll over, who's fallen off a changing table. So you're starting to think and assess, does that injury mechanism make sense for that child? It's an unexplained injury. The history doesn't make sense. Maybe you have one parent saying one thing, one parent saying another. Another red flag that I didn't highlight in this case, but if they're coming several days after injury, that's concerning as well. Or if they say that a pet or a sibling has been the cause of the injury, those are considered red flags for non-accidental trauma. And then Todd did a really nice job talking about the 10-4 facial score, which is really one of the best evidences we have around risk stratifying for child abuse. But in this case, we would want to examine that history and look for other injuries more carefully because that story is suspicious. And in my last case, we have a 6-year-old soccer player ran head-on into another player. There wasn't any loss of consciousness, but the child does have a moderate headache. They're complaining of photophobia and dizziness, and they maybe have some nausea, but they haven't vomited. Their examination is normal, although they may have some difficulty on balance. And this is a lot of what we're seeing in our emergency departments for head injuries. This is a sports-related injury, but kids fall downstairs and run into other kids at the playground at school. And of course, what this child has is a concussion. How you define a concussion, it's probably best to be broad, but the best definition that I've read is trauma-induced brain dysfunction. So this child would meet that definition. We don't need neuroimaging to diagnose a concussion. Neuroimaging is done to exclude other significant injuries, and concussion would be a diagnosis of exclusion when those concerns are mitigated. The treatment for concussion is actually relatively controversial. So the most important is symptomatic treatment, Tylenol for the initial, Motrin for the initial head injuries, nausea medicine if it's needed. There is good evidence that you want children who have concussions to avoid other trauma in the immediate period. So physical rest, avoidance of sports is fairly clearly recommended until they're cleared from their concussion. There's less good evidence and more controversy on whether patients should have also cognitive rest. And I'm interested to hear how you practice here in terms of how long you have them stay at home. Do you allow them to look at screens, the rest procedures? Because that evidence is a little bit more conflicted. But it is clear that before children return to sports, they need some clearance from a provider who can make sure that they have returned to baseline before they put themselves in other high-risk situations. I'll highlight one study that was done by a colleague, Ted Macknow, who works at the University of Massachusetts, and it's just a clever study around the cognitive rest. And so he did a randomized trial of patients diagnosed with concussion in a pediatric emergency department, and it was a relatively small study, only 125 children, but they were randomized to being allowed to have screen time, phones, computers, anything, yes versus no for the initial, I think 1 week after injury. And what you look here is a survival curve. We're used to looking at these for deadly diseases, but what they looked at was time to resolution of concussion symptoms. And the red group was the one that did not have any screen time, and the blue group was those that where screen time was permitted as wanted by the child. And at all time points from the injury, you see that the red group, the group that did not have any screen time, their symptoms were actually better. And so they showed a statistically significant increase or shorter time to resolution of concussion symptoms in those children that weren't allowed to use the screens, which does suggest some effect on concussion treatment, but a larger, more definitive study is needed, but a very clever idea that, that actually showed an impact. Okay, So wrapping up, we've talked a lot about head trauma. I think the PCARN head trauma rules are the largest and highest quality clinical decision tools that are available at this point in time. There's actually 2 rules, similar but different. One for kids less than 2 and one for kids that are greater than 2. Within those rules, those that have 1 or more symptoms, but who don't seem to be at high risk to you, observation can be a very important strategy. And so keeping a child, even just for a few hours in your emergency department, can really help you reduce the utilization of CT scans without missing important injuries. Non-accidental trauma should always be in the back of your head as an emergency provider. Does the story make sense? Is the mechanism consistent with what I'm seeing here? And the challenges that we face with all new evidence is how do we get it into practice? We know these rules, we talked about it in conferences. How do we remember it when the patient is in front of us, and how do we get it to impact our care? Because we see that translation takes time. So thank you, and we'll turn to questions.
Good morning. It is a pleasure to be here once again, and we are very much enjoying our time in the kingdom and appreciate the hospitality of our hosts here. This morning, I will be speaking to you about quality measures, and I have no conflicts of interest to disclose. However, I will be discussing several projects that were funded by the United States government through the Health Resources and Services Administration's Emergency Medical Services for Children program. So with quality improvement, I think it is always important to keep the patient at the focus. And so let's consider the case of this child. An ambulance is called for this child who is having an active seizure. And what we know about this condition is it is a common condition for which it accounts for one of the most common reasons why an ambulance is called for children in the United States, if not the world. We have an evidence-based guideline for pediatric pre-hospital seizure management. There are quality metrics that have been defined to improve care for seizures, and there's data that is collected every day in the United States, at least through our country's National Emergency Medical Services Information System database. Yet, despite all of these things, all of these facts, we find that guidelines are developed, metrics are developed, and data is collected, oftentimes in silos, such that there's no communication between each of these efforts. And really what's necessary is a coordinated effort, such that when an evidence-based guideline is created, that should drive the metrics that are defined in a clinically relevant manner, and then that should define what is the data that should be collected to assess outcomes. And so for this talk, my objectives for you are that by the end of this, I hope that you will be able to identify several emergency conditions that require quality improvement to enhance care, to list several quality improvement metrics that are based on evidence-based guidelines, and to name several strategies to improve the quality of pediatric emergency care. So I do pediatric pre-hospital research, and so I'm going to use examples from my own work to define quality improvement methods as examples. And so I mentioned earlier that seizures are one of the most common reasons, non-traumatic reasons why an ambulance is called for a child. And so in doing quality improvement work, it's important to focus on conditions where evidence-based knowledge exists, but is not being consistently translated into practice. And so that can be done with either very common situations, common conditions, such as respiratory distress, seizures, trauma in the pre-hospital setting, or in situations where you have very high-risk situations that may be even infrequent, such as cardiac arrest. Trauma by far, as I've shown here, is the most common reason why an ambulance is called for a child. And in many ways, prehospital trauma care is similar to that of adults, but there are opportunities for improvement. An example of that would be spinal motion restriction, how we handle that in the prehospital setting, and also pain management. We know that there are disparities in how pain is managed and assessed in children relative to adults in the prehospital setting. In addition, for seizures and respiratory distress due to asthma, bronchiolitis, or croup, these are very common reasons why an ambulance is called for a child. And then there are other things where we have an evidence base for what should be done prior to arrival to the hospital, such as in cardiac arrest, anaphylaxis, shock, and airway management. So several years ago, I led a project called the Pediatric Evidence-Based Guidelines Assessment of EMS System Utilization in States, where we took these 9 guidelines, implemented them in the Houston Fire Department EMS system, and then also subsequently implemented them in several New England states, specifically Maine, New Hampshire, Vermont, and Connecticut. There was intention to also implement them in some other states. What's unique about these states is they all use statewide guidelines, and so it's easy to implement a new protocol in these states as opposed to my own state of Texas. And so in this implementation, specifically, you'll see that I've mentioned seizures and anaphylaxis, and so I'm going to focus on seizures most heavily, but I'll make a brief mention to anaphylaxis as well. Because we did do some data collection with respect to the implementation of these guidelines, at least on the local level and in some multi-center studies that we did as well. So shown here is a summary of the main recommendations from the evidence-based guideline for seizure management in the pre-hospital setting that my colleagues and I published in 2014. And though this evidence-based guideline was developed with the best available evidence at the time, new evidence always emerges. And so, for example, there's a recommendation here to check a blood glucose. We know from some subsequent studies that we've done that in the actively seizing child, the prevalence of hypoglycemia in actively seizing children in the pre-hospital setting is actually less than 2%. So to have that be a first priority really is not the right thing to do. So if I were to rewrite this guideline, I would make that a secondary priority now. You know, there are other quality metrics that have been previously created for EMS. Checking a blood glucose is one of them. And so I highlight this as an example that with limited evidence, guidelines can be created, metrics can be created, but then when you have new evidence that shows that perhaps something should not be a priority, then you need to reevaluate the metrics that you're using to evaluate quality. Another recommendation in this that is still evidence-based, however, is the use of an intramuscular or intranasal benzodiazepine as first-line routes of administration and treatment for the actively seizing child in the pre-hospital setting. And so I'm going to go deeper on this quality metric as I go through my examples. Here is the anaphylaxis evidence-based guideline that we have developed and implemented as well. So in addition to the use of both a type 1 and type 2 antihistamine for urticaria, the main recommendation, however, for the treatment of anaphylaxis is the administration of intramuscular epinephrine. And so we observed that anaphylaxis was being undertreated in the pre-hospital setting. And so I'll also share some information about how we studied that in the pre-hospital setting as well. So in 2001, the United States Institute of Medicine, that's now known as the National Academy of Sciences, defined 6 domains of quality. And so I've shown them here. They are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equitability. And so these are all domains that one must consider when we're looking at quality. And since that initial publication of that report, 2 additional domains of quality have been defined, and that's access to care and coordination. And so as I go through some examples of showing you metrics that we have defined for both seizures and anaphylaxis, I'll do that with respect to where does it fall within these domains. So shown here are the metrics that we came up with for the seizure guideline. And so we categorized each metric with respect to a framework proposed by Donabedian, which are process measures, outcome measures, structural measures, and balance measures. And so an outcome measure is one that reflects the impact on the patient and demonstrates the end result of your improvement work and whether it's ultimately achieved the aims that you have set out to achieve. And so examples of that would be reduced mortality or reduced length of stay in the hospital, adverse events or harm that have been decreased, or reduced hospital admissions. So in the case of this guideline, the outcome measure that we chose was the percent of patients who are actively seizing upon arrival to the emergency department. Process measures are those that reflect the way that systems and processes of care work to deliver desired outcomes. So as an example in the seizure guideline, one of our process measures was the percent of patients who received either intranasal or intramuscular midazolam, since these routes of administration are preferred in the pre-hospital setting for the treatment of seizures. Structural measures are those that reflect attributes of the service or the provider, such as staff to patient ratios and operating times of the service. So we did not specify a structural measure specifically for the seizure guideline, but one that we could have chosen would have been the availability of a mucosal atomizer device, for example, to administer intranasal midazolam to patients. A balance measure is one that reflects unintended consequences of the guideline, which might be negative consequences. So it's about recognizing these and attempting to measure them and potentially mitigate their impact if necessary. So an example of a balance measure for the seizure guideline would be the percent of patients with respiratory failure, since midazolam is known to, with multiple doses, to cause respiratory failure, apnea. It's important to measure that impact on respiratory failure. So the percent of patients who receive bag mask ventilation, or BiPAP, or CPAP, or a supraglottic airway placement or intubation. And so we categorize these using the, as I mentioned, the quality domains as defined by the what was known as formerly as the Institute of Medicine. For anaphylaxis, the metrics we proposed are shown here as well. Our most important process measure was the percent of patients with anaphylaxis that received intramuscular epinephrine. And our outcome measure was the percent of patients that required airway management, either in the pre-hospital setting or the emergency department. So quality measures should also meet several criteria. And those criteria that we used have been defined by what's known as NQF, or the National Quality Forum. And this is important to ensure that the data that's collected will provide useful information. So there are 4 criteria in the NQF criteria. One is that it's feasible. So it's easy to collect using the existing data infrastructure. And so, for example, it is feasible with the way that we collect pre-hospital data to know the time of midazolam administration for seizures, since every medication that's delivered has a date and time stamp in the pre-hospital electronic record. However, time to seizure cessation is not feasible to collect. That is not something that is routinely documented. And so to try to assess that would not be a feasible metric. Usable. So usable means that it's providing meaningful information. So data that's obtained from the existing infrastructure is in a format that can be meaningful. And so, for example, the route of medications that are administered is also required to be documented, and it's done so with quite a bit of accuracy. However, the duration of seizures is not something that is documented well. And so in order to gather information on that would not be very meaningful to try to gather that from the patient narrative that's written by the paramedic or the emergency medical technician. Importance. So importance means that the data has clinical relevance. And so knowing if the patient is seizing upon arrival to the emergency department is clinically important. It's clinically relevant because it determines what resources will be utilized in the emergency department itself. But as I mentioned earlier, checking a blood glucose is something that we once thought was clinically relevant, but based on more recent data, it seems is not as clinically relevant as we once thought. And then the fourth criterion is scientifically acceptable. So data that has significance as a benchmark or measure in the scientific community. So for example, time to seizure cessation has been used in other emergency department-based studies as the primary outcome when comparing the effectiveness of different medications. However, the route by which the medication is given has not been typically emphasized in prior research studies. So in describing then, how did we use this framework to study pediatric seizures specifically and pediatric pre-hospital seizure management? I'll start first with just a local study that we did in my city of Houston, where we had paramedics that were pulled out of service to participate in full-day training that was simulation-based. And several of the modules that we did focused on the common condition of seizures. And so in this, despite the fact that we had paramedics who participated in this training, we compared paramedics who did and paramedics who did not, and looked at actual real-world patient treatment in the field. And what we found was that although there were paramedics who participated in this simulation course, their use of the preferred routes of medication administration for midazolam did not change. And so you'll see here that 68% of them were using the intravenous route back when we did this study. And so I think this is a good example of how just doing education alone is not enough to change practice. So with quality improvement in healthcare, it's important to assume that each and every one of us who comes to work is competent and wants to do what is best for our patients. So, we had taught these paramedics to do the right thing. They come to work to do the right thing, and yet the right thing was not happening. And so from a quality improvement perspective, the results that we observed showed us that doing education alone was not sufficient to change behavior. And this is well known in quality improvement. And Edward Deming, known as one of the initial pioneers in quality improvement in healthcare, stated that every system is perfectly designed to achieve exactly the results it gets. And so therefore, simply reminding people to do something is not enough to change behavior. You really need to change the system. And so in EMS, the system of how care is delivered is based on a protocol. And so how that protocol is written could positively influence behavior, or it could negatively influence behavior. And so, so that was an important reason why we were observing what we did. And so, so for a moment, focus on trying to improve the process measure of the route of midazolam administration using those preferred routes that I'd mentioned, intranasal and intramuscular. And so shown here is the model for improvement, which is a framework in quality improvement to help orient teams to focus on identifying and using data to plan for systems changes to improve outcomes. And so with the model for improvement, there are three important questions. So one is, what are we trying to accomplish? Two is, how do we know that a change is an improvement? And three is, what changes can we make that will result in the improvements that we seek? And so for this first question, it's necessary to have an aim statement, and an aim statement helps orient you to the work that you're doing. And it should be phrased in what we call in a SMART format. So SMART is an acronym that stands for specific, measurable, attainable, relevant, and time-bound. So what does that mean? So specific. Goals should be simplistically written and clearly define what you're going to do. Specific is the what, why, and how. Measurable. Goals should be measurable so that you have tangible evidence that you have accomplished your goal. Attainable. So the goals that you set should be attainable. They should stretch you slightly so that you feel challenged, but to be defined well enough so that you can achieve them. Relevant. Choose goals that matter. So does changing the route of administration impact the outcome? We have evidence that says that it does. And then time-bound. Goals should be linked to a time frame so that there's a target date by which that goal is achieved. And so shown here is an example aim statement for that process measure that I gave you. So So by 2021, 90% of actively seizing children will receive intranasal or intramuscular midazolam as first-line treatment in this EMS system. So for that second question of how do we know that a change is an improvement, it's necessary to have a way to show data. So earlier in Dr. Nigrovich's talk, she showed what was a statistical process control chart, which is also sometimes referred to as a run chart. And so, so what this does is, ideally, if you're looking at this on a continuous basis, you get real-time feedback of how your system is doing. And then in looking at the trends over time, you can see if those changes that you're observing are meaningful and significant. So with the third question, what changes can we make that will result in improvements that we seek? It's necessary to have a way to address the problem through changes that have potential to result in improvements. And so this is done with what's known as PDSA cycles, and where that stands for Plan, Do, Study, Act. So in that plan phase, you assess the situation by looking at data and trying to determine why you're observing what you are. In the Do phase, you develop and implement a potential solution on a small scale. With quality improvement, attempting small changes can have a big impact. And some small changes may be successful and others may not. Study. In the study phase, it's important to gather data to determine if that modification you made to the system actually worked. And then with Act, in the Act phase, if the data shows that the small change you made actually resulted in an improvement in an outcome, then it's important to standardize that change and plan for how to successfully do that. So I'm going to use the example of seizure management to explain how we went through some Plan, Do, Study, Act cycles to help improve care. So in that plan phase, we looked at various measures. The study that I mentioned previously also identified that seizure activity upon emergency department arrival was fairly common, occurring in 1/3 of patients. Dosing errors were occurring in half of the patients, 90% of whom were getting underdosed. And there were also delays in treatment such that the median time from paramedic arrival to the patient to actual administration of the midazolam was 14 minutes. So gathering some baseline information here related to quality metrics that we had selected and helped us quantify what is happening and identify opportunities for improvement. So in the Do phase, we decided to change the system by modifying the EMS seizure protocol. And in doing so, we utilized a multimodal training approach that involved mandatory in-person training for all the paramedics in our system. We have 475 paramedics in the Houston Fire Department, and they had to go through this training over a 2-week period immediately before we implemented the change in the seizure protocol. We distributed reference cards that they could put on their badge where they could see what the doses of medication were, since we know that paramedics infrequently encounter children in the pre-hospital setting, and that had dose, drug, route guidance for seizures. We also had a social media campaign where we had reminders that we sent out via Facebook and Twitter to reinforce some of the main points that we had in the training, and we did that over an 8-month period after the training. So not only did we educate, we changed the system by changing the protocol, and we removed non-preferred routes of administration. We took out the IV route, we took out the rectal route of administration, and we studied it. And so we observed a significant change in the use of the intranasal and the intramuscular routes. However, you'll see here that there were some things that did not change. We still did not see a significant change in the percentage of patients that received midazolam, and we still did not see a change in the receipt of a correct dose. And so though we made some structural changes by changing the protocol, it only affected one of our 3 process measures. And so it was unclear if what we observed was an issue with the protocol itself or with the system. So we decided to act by making these protocol changes in several EMS systems. So we actually did this in Milwaukee, Wisconsin, and in Charlotte, North Carolina, and we studied it in all 3 cities. And integrating many of the recommendations from the evidence-based guideline into protocols in 3 different systems, we found several improvements in several process measures. So for example, across all sites, there was a 27% absolute increase in the use of intramuscular and intranasal midazolam, and there was a 10% absolute increase in the administration of midazolam to the actively seizing child. Yet still, in this 3-site study, we did not see a change in the receipt of a correct dose. Approximately half of these kids were getting the wrong dose of medication. And so that really led us to ask the question of why. And we still also observed a third of these children were arriving at the emergency department actively seizing, half were getting the wrong dose, and there was still this 14-minute delay between paramedic arrival on scene to administration of the midazolam to the actively seizing child. So in quality improvement, one important technique to understand the why of why is this happening? Why am I observing the behavior that I'm observing in my system is to break down the process. So to do a process map. And so we did that with dose determination. And so we tried to figure out, well, what exactly happens when the paramedic gets to the scene that is contributing to this dosing error? And so we walked through the process. When the paramedic gets on scene, first they have to figure out the dose. They have to figure out, well, what is the patient's weight? So they use the length-based tape frequently to do that. And then I have observed in simulation that because paramedics don't frequently take care of children, it only accounts for about 10% of their patient population. Oftentimes they don't know how to use that length-based tape and they use it incorrectly. So there's an opportunity for error there in just the use of the estimation of the weight. And second, they have to figure out which route am I going to use. So if their protocol says that you can use intramuscular, intranasal, intravenous, intraosseous, rectal, and each of those routes has a different weight-based dose, then there's an opportunity for error there. Then imagine that you are on scene taking care of an actively seizing child and you have parents who are very concerned. They think their child's dying, they're yelling at you, and then you're telling people to do math. So then they have to calculate a dose. Okay, they have this estimated weight, assume it's correct. Then they have picked the right route for potentially intramuscular, intranasal, and then they have to calculate 0.2 milligrams per kilogram while parents are yelling at them. My child's dying, what are you doing? Then they get a number, it might be the right number, it might be the wrong number, and then they have to do one more mathematical calculation and convert that to milliliters. And we know that in the pre-hospital setting, you might have 5 milligram per milliliter concentration midazolam, you might have 1 milligram per milliliter concentration midazolam. You have to make sure that you're using the right conversion to come up with the milliliter dose and then have to administer that. That is a multi-step process that is prone to error at every step, right? So we actually interviewed paramedics to find out what do they think about their protocol and what makes it easy for them to follow their protocol, what makes it hard to follow their protocol, and what are their own solutions. And so this is an important process as well in quality improvement, is to actually talk to the end user. Right? We can make changes in the system, but if we're not actually discussing it with the end user who has to actually implement what you're designing, then you can miss things. And so we interviewed approximately 20 paramedics in each of these 3 cities, Houston, Charlotte, and Milwaukee, after they had taken care of an actively seizing child within a week or 2 of that call. And we asked them, what made it easier for you to follow your protocol? They told us having point of care references that told us exactly what dose to give, making sure that there was the adequate supplies and the right sizes to administer an intramuscular medication, to administer intranasal medication. Barriers that they noted were ambiguity in their protocol that said, okay, well, I'm supposed to treat a febrile seizure this way, but I'm supposed to treat a non-febrile seizure a different way. Or I'm supposed to treat a focal seizure one way, and I'm supposed to treat a generalized seizure a different way. Or I'm supposed to treat a pediatric seizure one way, or an adult seizure a different way. That causes a lot of confusion if you have all of these different variations and nuances in the protocol. And so one of their recommendations was simplify the protocol, make it consistent, make it easy to follow. And then the second thing they said was take out the calculations. So Dr. Auerbach likes to use the phrase math kills, And so I think, we can see from that process of doing the process mapping that that's an error-prone process. There's a high cognitive load there, and that can lead to errors. And so, so we then took that feedback from what the paramedics told us. And so I'm going to use this framework of PDSA cycles to put all of what I just described into context of how does this relate to actual PDSA cycles. So we planned by identifying some problems with variation in practice and creating an evidence-based guideline. We did the do by developing a data gathering plan by creating quality metrics. We studied by gathering some baseline data to determine the need, and then we acted by standardizing that evidence-based guideline into a protocol update. But then based on that data that we gathered, we observed variation in systems, and we asked why. And so based on that feedback, we are actually planning further modifications to patient protocols by taking out the need for calculations in a study that I just started and will eventually start patient enrollment in several months in 20 cities across the United States, where we are going to take out the calculations and use a standardized approach in using standardized dosing for intranasal and intramuscular midazolam for actively seizing children on the ambulance. And so we'll study that. And then based on what we gather, we will determine if we need to act by modifying the system even more by making this a more widespread change in EMS systems across the country. And then who knows what PDSA cycle 3 will be, but we could do various things. We could design another study to determine why protocol adherence is limited by observing workflows. Based on what we learned from workflow observations, we could design and simulate changes to determine why errors remain. We could then gather more data after changing things to study the issue. And then finally, we could act by making further modifications to optimize how we standardize dosing. So I give you these examples of tools, PDSA cycles, process mapping, as some examples of how to apply the concepts of quality improvement to a clinical condition where you have evidence, but it's not being implemented in the way that it should be optimally. And so in summary, efforts with guideline development, metric creation, and data collection should be coordinated to improve care. It's important in doing so that you use specific criteria for development of those metrics so that they're feasible, they're usable, they're important, and they're scientifically acceptable. Meanwhile, it's also important not to just study process outcomes. I think this is a big pitfall with quality improvement, is that oftentimes we tend to focus on process measures rather than striving to actually assess the true patient-centered outcome that is relevant in the real world. And then it's also essential to remember that every system is designed to get the result, achieve the results that it gets. And so it's important to map out the system, speak to end users to understand how to make changes in the system. And then finally, quality improvement involves trial and error with multiple plan, do, study, act cycles. But ultimately, real opportunities to improve the system can be implemented and lead to sustainable improvement in patient outcomes. Thank you.
Start questions. Good morning. Good morning. Starting the motivation. We face sometimes that we know the clinical decision rules, we know how to apply our PCAR rules, but sometimes the families are resistant to do a CT for the child. They just have this belief that the CT is the best thing that we can do. My question is, what's your strategies to overcome this?
Great. So you highlighted a great issue with evidence and parents, which I think is really important. I think that the tools allow us to risk stratify so you can have a conversation about the risk for the individual child. For me in my practice, when I started, I feel like I had a lot of conversations like that. Like, I want my child to have a CT scan. With increasing awareness of radiation risks, I feel like I have the opposite conversation now where I think a CT scan is recommended and the parents don't want a CT scan. So there's been a lot of evolution, and you may see that as well. But I think a informed risk management conversation with the family, saying why you think a study is indicated and not indicated, and engaging in real shared decision making is sort of the art of translating evidence into practice. But I understand where you're coming from.
Good morning. My name is Yusuf Nasser. I have a question about the quality improvement and regarding the cultural sensitivity when you plan your quality improvement project, because that's something important everywhere, but especially in our part of the world. And the second question is about what we learned from overuse of high flow and bronchitis. It seems that from every talk we go to about bronchitis is the best approach is just watch and wait. What is your comment on that?
So you were asking about cultural sensitivity and designing quality improvement. You know, I had mentioned earlier in my talk that it's important to talk to the end user as an example of what is an important factor to consider when designing what your intervention should be. Part of that concept of an end user is also the parent or the patient. And so I mentioned the study that we're about to start in 20 cities across the country. Part of our process of considering, well, what does the public think about this? What do parents think about this? Is we're actually surveying them and interviewing them to get their point of view about doing a study like the one that we're doing, to make sure that what we have designed accounts for their opinions and perspective. And if we find that there are changes that we need to make based on the feedback that we've received from them, then that's something that we'll need to address in modifying the design. And so that's absolutely important when developing a clinical practice guideline as well. Some of the guidelines that I mentioned that we have developed, we had a parent representative on the guideline development committee to provide their perspective as we were considering the evidence.
And I appreciate your question regarding high flow nasal cannula and bronchiolitis in general. And I could probably talk for 3 hours on this topic alone, but I will try to give you the abbreviated answer on this. I think the challenge with bronchiolitis, we actually, I had published a commentary last year in Pediatrics entitled, "Don't Just Do Something, Stand There." And this really sort of, the idea was embracing this concept of de-implementation in bronchiolitis. Bronchiolitis is this, it can be this very heterogeneous condition. And I think that it is a prime example of really understanding what the evidence is showing us before implementing into broad scale practice. And I think what we see with bronchiolitis is that everyone is so desperate to find that intervention or that series of interventions that the minute that there is some initial promise, it leads to this widespread implementation without the evidence being able to sort of catch up. And so we are playing this sort of cat and mouse game with bronchiolitis, where we take a little step and then something gets broadly implemented and then you have to stop doing it. Think about albuterol, salbutamol in bronchiolitis is a perfect example. where over time it was really determined that most children with infants with bronchiolitis don't respond. But the AAP guideline itself was recommending for a while a trial of albuterol until the most recent guideline, which took that trial out. And I think we're seeing the same thing with high flow nasal cannula, is the initial studies seemed to show some promise. And now we have more and more evidence coming out that most clinical outcomes are not changed. There's a short-term improvement in respiratory rate, a short-term improvement potentially in work of breathing, though there's variability in how that's measured across studies. But when you look at the most rigorous evidence for high flow nasal cannula, it's really those two randomized studies out of Australia, Capriotes, published in 2014 or 15, and then I forget the first author on the second. What both of those studies showed was that high flow nasal cannula was not associated with an improvement in most outcomes, except for potentially as a rescue therapy to prevent intubation in the sickest children. So in my practice, if I have a child in the resuscitation bay who's breathing 110 breaths per minute and severely retracting, that is the ideal child for whom the evidence suggests that high flow nasal cannula has an effect. Unfortunately, what has happened in reality is that now any child who is demonstrating any little bit of work of breathing or any little bit of tachypnea is thrown on a high flow nasal cannula system. And there's not the evidence that that works. And so there are now efforts underway, at least I know in the United States, to try to de-implement that and to take a pause, to question, does this child in front of me require high flow nasal cannula based off of the evidence in front of me? Just to help clinicians take a moment before they just start this therapy. Because once you start high flow nasal cannula, I don't know how it is in the kingdom, but I do know that in the States that there are many institutions that you have to go to an intensive care unit simply by starting high flow nasal cannula. And these are not critically ill children. So what happens? You start these kids on high flow nasal cannula, you fill up your intensive care unit with children who don't need to be in the intensive care unit. There are many downstream effects. So by just taking a pause before high flow cannula initiation, that is one strategy to be able to sort of, don't just do something, stand there. Step back for a second and think about, am I truly implementing the evidence before I take that step?
So now for the online audience questions.
Dr. Malki, please, if you allow me. We have one, and if you people and are running time.
Yes, okay. So the last question from the audience in the audience.
Just a comment about concussion management. I do always recommend for parent and for my to see parachute. Parachute concussion project, which is Canadian project. It comes with a very nice material to the parent, how to do the step wise approach to go back to play and to the school. So I recommend you to see this material.
This is not a question, it's a comment.
Thank you.
You can go ahead.
Okay, so the first question is for Dr. Elise by anonymous attendee. What is the best available score to be used for neonatal sepsis decision?
So thank you for the question. I think the best evidence right now is likely the PCARN febrile infant rule. However, I understand that readily available PCT is hard to come by. And one of the three factors includes PCT. So I'd be interested to know how long it takes and whether that study is available here.
Okay, so I have another three questions, all for you, Dr. Elise, for the head trauma. The first one is very interesting question by Dr. Ibrahim Algoz. He's working in a primary healthcare setting, and he's asking, when I have a patient with head trauma, what to do for this patient? Is it better to observe him in the primary healthcare or to send him to the hospital? And when do I need to make the decision?
Great. So I think the PCAR and head trauma rules can be, if they were done in emergency department, I think the results can apply also to a primary care setting. And for those children that are at intermediate risk, whether it's easier to observe in a waiting room or in close communication with the family at home or an emergency department, probably depends on the resources available. But I think the evidence can guide that decision.
Another question, also in the head trauma by, I'm not sure if I'm reading the name correctly, Relim. If the child is having ear bleeding, what to do with head trauma?
Sure. So, you know, the classic sign of a basilar skull fracture is hemotympanum, but I think if you have a punctured TM from trauma, I think neuroimaging should be strongly considered.
Okay.
Unless the trauma, of course, is just a penetrating trauma to the eardrum. But in a blunt head trauma with ear bleeding, I think imaging is probably indicated. It's not included in the rule, so you do want to assess the child overall, but that's an unusual finding.
Okay. The last question is another interesting question by Dr. Imad Al-Karam. If the patient present after 24 hours after the head trauma, what to do for this patient, especially if there is any symptoms?
Sure. So these are all great questions. I'm trying to go quickly. So the initial decision rules, one of the exclusion criteria were trauma more than 24 hours ago. So it can't be directly applied. And I think when you're talking about observation, if it's already been 24 hours since the injury, further observation in your emergency department is unlikely to change the symptoms substantially. So someone who's very symptomatic 24 hours after injury, you may want to consider imaging, although concussion is also a very likely diagnosis.
Second session. Okay. I have a last question here by Dr. Taghreed. What is the relation between the vaccinations, and I think this is regarding the seizures, and seizures in pediatric age group, especially the vaccination of DTB? It's more of a medical, rather than quality question.
Sure. So to my knowledge, there is not a relationship. And if the other panelists have other knowledge on that, I welcome that. I don't believe there's any association between vaccination and seizures.
Thank you very much. I think we are done with the questions. We have one question from the audience. Yes.
For Dr. Late, Dr. is the minor injury. If the patient came, the children with a seizure after the trauma, PCAR, we cannot apply it for such patient. Are there any other guidelines on them, or we can use it also for them?
I think that's an excellent question. So seizure in itself is not included as one of the predictors in the PCAR rule. Many of the children with post-traumatic seizures or impact seizures may present with altered mental status. So in that way, it's captured. But there has been a secondary analysis, because it was such a large cohort, of children with immediate seizures after head trauma. And I think the incidence of clinically important traumatic brain injury in that population was around 5%. So certainly neuroimaging would be often is undertaken and probably is a good idea in that case. That's an example of where clinical decision rules augment but don't replace your clinical decision making. But thank you, it's a great question.
Thank you very much.
Thank you very much, our guest speakers. Can you come back, please? And we will resume our activity for the next session. Group, please.
Yes.
No break. No rest. What?
We'll start again the session, and Dr. Lays today is almost, this is the third in a short time. So she will present us a very interesting topic, and we face it in a daily basis in our practice, tools to identify bacterial meningitis. Please, Dr. Please.
Okay, thank you. So welcome back, and we're going to talk about bacterial meningitis. So in the next 30 minutes, we're going to talk a little bit about the clinical presentation of meningitis in children, focus a little on bacterial and then aseptic or non-bacterial meningitis, and then again turn to clinical prediction rules to aid our decision making. So the case and single case to frame the discussion, who I hope rings a bell for a child that you've taken care of in your emergency department, and I'm not going to touch the computer again, is a 4-year-old boy who presents with 3 days of headache and photophobia with mild meningismus. Based on that examination, you're concerned for meningitis, so you get some peripheral labs, a white count that is maybe 12,000 and an ANC of 8,000. That you perform a lumbar puncture, and there's 1,000 cells. 40% of those are polys. The CSF protein and glucose are normal at 45, and you do a CSF gram stain, which is negative. And now you need to decide what to do. In particular, what is this patient's risk of bacterial meningitis? How should the patient be managed? Should you give parenteral antibiotics empirically? Should they be hospitalized? And then more globally, what threshold of risk, if any, should we accept for outpatient management for a patient with meningitis? So how do children with meningitis present? This is a medical illustrator's view of meningitis, which shows a cross section here. And just to remind you that meningitis is inflammation of the CSF and the meninges that surround the brain and spinal cord, versus encephalitis, which is inflammation of the brain itself. There's often a lot of crossover. So if you have meningitis or infection of the spinal fluid, you could have a little bit of associated encephalitis. But for the purposes of this talk today, we're really focusing on meningitis. All right, so in young infant, early, children with meningitis present with non-specific signs and symptoms, making the diagnosis harder. So as we know, fever, decreased oral intake or vomiting, irritability or lethargy. Late symptoms of meningitis include nuchal rigidity, full fontanelle, shock, or coma. And while it's easy to identify patients with late signs, clearly we want to identify those that present early when our therapies have the greatest impact. In older children, they may have more specific signs early on, like our case, where the child presents perhaps with irritability or meningeal signs on examination. Photophobia is a symptomatic sign of meningitis. Late signs can include lethargy or signs of shock. And Koenig and Brudzinski sign is shown here in the illustration. Koenig sign is when you bend the neck flexes up, and Brudzinski's is the flexion of the knee and the neck together. Our physical examination findings of meningitis, they have low sensitivity, but high sensitivity, but low specificity. What about bacterial meningitis? We've talked this morning about the conjugate vaccines, which have really changed the landscape of bacterial meningitis, particularly the pneumococcal vaccination, which in the US was licensed in the 2000s with similar dates here in the kingdom, as I've read. In addition, the Neisseria meningitidis conjugate vaccine with the various serotypes has dramatically decreased the number of bacterial meningitis cases. In the US, surveillance studies have shown over the last 2 decades that there's been a 50% decline in bacterial meningitis overall, which is substantial. However, we have to remember that the morbidity and mortality of those children who get bacterial meningitis is relatively unchanged. And in fact, 7% of those that develop bacterial meningitis die from their infection, and that has not been changed.
Here we look at the epidemiology of bacterial meningitis by age. The CDC does some surveillance. Now this is from 10 years ago, but I think it still is a good reflection of current epidemiology. So in the youngest children, children less than 2 months of age, group B strep is by far and away the most common cause of bacterial meningitis, shown in the yellow here. And then for older children, pneumococcus and Neisseria meningitidis become the most common pathogens, despite the vaccinations. What is the pneumococcal story? And again, this is older data, but reflects the current trends. So here we look by year, the total number of pneumococcal meningitis cases per 100,000 persons has been on the decline. But what you see is within the number of cases, the dark blue bar reflects those that are caused by serotypes covered by the vaccine. Now this is in the PCV7 era, has declined substantially, but there's been an increase in those serotypes that are caused by the non-vaccine serotypes. PCV13 covered many of the serotypes that were not included in PCV7 that was causing invasive infection. But now in the PCV13 era, we're seeing serotypes emerge that are not covered by that modified vaccine. So if the children don't have bacterial meningitis, what do they have? They have aseptic meningitis. The most common cause of aseptic meningitis are enteroviruses. They can be diagnosed by culture, but those are not very clinically useful. They take a long time to come back. They have low sensitivity. So if you want to definitively define an enterovirus, you need a polymerase chain reaction test. And we can talk more about the availability of those tests. They have excellent both sensitivity and specificity if they're available. And if it's not enterovirus, you have to think about other infections. And in this area, I think tuberculous meningitis, which is, I don't have on the list, is something that you might be considering. In my area of research is in Lyme disease, which you don't see here at all, which is a tick-borne infection carried by the Ixodes tick and caused by an infection by a spirochete called Borrelia. And we spent some time thinking about herpes, which causes more encephalitis than meningitis, but in the youngest patients can be a cause of meningitis as well. So we have a long list of other pathogens that can cause these infections. Enterovirus being the most common, testing for that virus can be very helpful at assuring us that we are not dealing with bacterial meningitis. And so if we have a positive enteroviral PCR test, we know the risk of having bacterial meningitis at the same time is quite low. In fact, in a cohort of 768 children who had a positive enteroviral PCR test, none of them had bacterial meningitis. The importance of the test is really related to the turnaround. So you need to get the test back in a few hours to have a clinical impact. If it takes many days to get the test result back, at that time, you would have your bacterial culture as well. And so the test is less impactful, because really what it allows you to do in the presence of a known enteroviral infection is to worry less about bacterial meningitis. And last, we're going to talk about clinical prediction rules. Most children with CSF gliocytosis or meningitis have aseptic, not bacterial meningitis. Bacterial meningitis is a serious infection. You want to identify it quickly and promptly start parenteral antibiotics. However, those with aseptic meningitis need only supportive care. And so the challenge, just like we framed for each of these emergency conditions for children, is to identify those children at risk for the serious condition, bacterial meningitis, without over-testing or treating those at low risk. So work that I did earlier in my career was to develop a clinical prediction rule for this scenario. And so we did a single center retrospective study of hospitalized patients. We initially included about 700 at a single institution where I work, Boston Children's Hospital. And we got rid of children that had comorbidities and critical illnesses or had been pretreated with antibiotics. And the result of that work is a score that I call the bacterial meningitis score. And it included 5 factors that are listed here. So a positive CSF gram stain, CSF ANC of greater than 1,000, CSF protein greater than 80, a peripheral ANC of greater than 10,000, and a history of seizure at the time of presentation. And children who had meningitis, who had none of those factors, were at low risk for having bacterial meningitis. Children who had one or more of the factors were not at low risk. The negative predictive value in that initial study was excellent, 100%, but because it was a relatively small study, the confidence interval around that negative predictive value was quite
was quite broad. In fact, up to 3% of those children could have bacterial meningitis. Subsequently, the epidemiology of bacterial meningitis changed due to the conjugate vaccines and the fact that that first study was done in a single-centered design. So we were able to collect 20 centers for a refinement, external validation of that rule. And here are the results in that larger study. So the rule remains sensitive at 98.3% with a 61% specificity. But now the negative predictive value, which was 99.9%, had a much tighter confidence interval because of the increased size of the study population. So the risk of having bacterial meningitis in the study population was 1 in 1,000, which much more confidence around that. All of these 20 centers in that study were in the US. Subsequently, other investigators have validated the rule in their settings. So in Europe, in South America, and in the United States, there have been 8 to 10 published studies of that bacterial meningitis rule, and it performed well in all of the settings. One study that I did with a faculty member in Boston was looking at how well that rule performs in the youngest infants. And unfortunately, although the rule identified all of these children less than 60 days of age who had bacterial meningitis, the specificity was really low, 1.6%. And so in that youngest group, it probably isn't the most effective tool at risk stratifying the infants. Recent work has evolved the bacterial meningitis score, which we again developed. We first published in 2000. The newer biomarkers are likely to be quite helpful in the risk stratification. Santi Metegi is a colleague from Spain who did this really amazing prospective study. It's really hard to enroll children with meningitis prospectively. And he worked over an 8-year period at 24 Spanish EDs to enroll 1,000 children. So truly heroic effort. And sort of modified the older bacterial meningitis score to propose procalcitonin of greater than 1.20, CRP of greater than 4, CSF A and C of greater than 1,000. So that's, and CSF protein of greater than 80. So 2 of the factors from the bacterial meningitis score plus 2 of the newer biomarkers. Again, this rule performed very well with the low risk group being defined with none of these predictors with a negative predictive value of 100%. But again, because bacterial meningitis is relatively rare, the confidence interval was as shown here. This rule needs to be externally validated, but really has promise for improving our sensitivity and specificity in diagnosing this very rare infection. One clinical scenario that we deal with a lot is antibiotic pretreatment. That is, a child's been on treatment for otitis or some other bacterial infection at the time they're being evaluated for bacterial meningitis. And so the concern is that the pretreatment with antibiotics may falsely render the bacterial cultures negative. In fact, we know that if a child has Neisseria meningitis infection, even a whiff of antibiotics orally can sterilize the culture, although not truly treat the infection. And how quickly the cultures are sterilized depends a bit on pathogen, as indicated here. We've done some work also that although the cultures may be negative, that the CSF glucose and protein may also be affected by antibiotic treatment. So these patients are clinically challenging if you identify meningitis in a pretreated patient, because you may not have your culture as a gold standard. And so you have to make a best clinical judgment about how long you're going to treat those children. And tools like the bacterial meningitis score or the meningitis score for emergencies, which was recently published, probably aren't effective because we know these antibiotics also affect the CSF profiles that you're looking at. So in summary, the bacterial meningitis score accurately identified low-risk children. Young children and those that are pretreated with antibiotics probably should not be included in the application population for implementation of the rule. I think the work from the Spanish group that looks at procalcitonin and CRP is really exciting and really may help refine the work further. And for those children that are identified at low risk by these clinical decision tools, outpatient treatment is an option. You can mitigate the risk by considering a long-acting antibiotic like ceftriaxone, a third-generation cephalosporin, which provides parental level treatment of bacterial infections while the patient is at home. And again, the children that you consider treating at home need to be well appearing with follow-up available. We started with this case, and now I ask you to think again about how the evidence that we talked about might impact the rule. So again, or impact the care. So this is a child with 1,000 white cells, ANC of 8,000, a normal glucose and protein. I have not provided the newer biomarkers. So this patient has none of the bacterial meningitis score predictors. So they're at low risk. And so their risk of actually having bacterial meningitis is approximately 1 in 1,000. How should they be managed? I think if they're well appearing and able to tolerate fluids and have available follow-up, outpatient management would be reasonable. In a setting where you could have a rapid enteroviral PCR test, that could be reassuring, it could be considered. And a long-acting antibiotic like ceftriaxone could help cover while you wait for the final culture results. And then the more global question as we think about all these low-risk, high morbidity, mortality conditions is, how low a risk do you need to tolerate outpatient management or reducing the intensity of the interventions? So in conclusion, clinical prediction rules assist, but do not replace clinical judgment in the management of our patients. The bacterial meningitis score has undergone broad validation in a variety of countries and clinical settings. Newer biomarkers like procalcitonin and CRP are likely to improve the performance, and more work is needed. But patients, as bacterial meningitis becomes rarer and rarer, we can really start thinking about outpatient management safely. Thank you.
Thank you, Dr. Liz. I would like to welcome again Dr. Manoj Mittal for the next talk about the BROE, the Brief Resolved Unexplained Event. So welcome, Dr. Manoj.
Hi, good morning, everybody. All right. So we're going to talk about this relatively new entity, BREW, or Brief Resolved Unexplained Events. Nothing to disclose. So we'll be discussing the AAP guideline about BREW, describe features of lower risk versus higher risk BREW, and outline an approach to manage an infant with BREW. So just to start with, since this is a relatively new condition, I'm going to offer you some cases and just as a way to start thinking about how you would manage them. We're not going to answer them. This is just to promote your thoughts. And then towards the end of the discussion, we'll come back to these cases and then we'll talk about how to process them. So 2-month-old, 34 weeks gestation with 30-second episode of slow and shallow breathing, color change. His tone remained normal, and possibly he had altered mental status. The infant appears well now with normal vital signs and exam. So do you think he meets the criteria for BREW? Does he meet the criteria for lower risk versus higher risk BREW? And how would you manage this infant? Those are the sort of things that we would review towards the end. Another case, 10-week-old with 30-second episode of slow to respond, shallow breathing, color change to pallor, and eyes seem staring. He had a similar event yesterday. The infant appears well now with normal vital signs and exam. Again, the same questions. And then a 4-month-old with 2 episodes over last 6 hours, each lasting about a minute. He had shallow or almost stopped breathing during the episodes. He seemed pale and he seemed slow to respond. So just going to the history of BREW, I'm sure all of you are familiar with this term ALTI, which stood for apparent life-threatening event. This was a term that was first established in 1986 by an NIH consensus statement. They had a consensus conference about it, and they issued their guideline, which was published in Pediatrics as well as many other journals. So an ALTI was defined as an episode that is frightening to the observer and characterized by some combination of apnea. And apnea can be central apnea, which is when we say the infant stopped breathing, so that's central apnea, or obstructive apnea, which is difficulty in breathing. The infant seemed to be struggling at breathing. You know, that's how often parents will tell you. So that those are both forms of apnea. Color change. Color change could be pallor, that is the infant became pale, bluish discoloration, but also in this definition, it included plethora. So that is infant appeared red in the face or congested in the face. Marked change in muscle tone. And notedly, you know, it also included this last concept of choking or gagging. The NIH definition, as we note, did not distinguish the majority of infants who appear well from after the event from those who were looking sick. So with the old concept, suppose an infant had these terms, but had a fever during presentation. So you could make two diagnoses. You could make he had an ALTI and he had a febrile illness. Even if later on he was found to have meningitis, still, you know, he could have ALTI at presentation. Later on, he developed meningitis. That didn't remove the label of ALTI. Cases with choking, gagging from those with central apnea. We know infants in the first month of life, almost 50% of infants can have some degree of gastroesophageal reflux. And if they have gastroesophageal reflux, sometimes they'll have a little choking episode, gagging episode. And these cases were not distinguished from those with apnea, you know, where you would be much more worried. The other issue was that there were a number of studies done about ALTI, both by, you know, I was involved in some of those studies, which established parameters for identifying infants who were safe to be discharged from the ED versus those who needed to be admitted. And we found that almost 80% of those infants could actually be discharged from the ED completely safely. And still we found that, you know, lots of people, including Manish earlier, talked about the gap in evidence generation with implementation. We found that the admission rate for ALTI across United States, you know, all learned physicians, still the admission rate stayed at almost 70 to 80%. So it was the exact opposite. And they realized that, you know, this definition needed to be changed, and maybe you invent a new term, apparent life-threatening event. Remember telling that to the patient? Already the term seems, just the term seems scary and frightening. So the AP established a clinical practice guidelines subcommittee in 2013 to revise this. And this committee did a really good job, I believe. And they changed the term to brief, resolved, unexplained event with a, you know, short form BREW, which really captures this entity well. So this is just to say, because should you call it brew or brew, or so just that it is pronounced as brew. All right, so brew. So what is brew? So the new definition for this new entity brew is an event occurring in an infant younger than 1 year. So it still should be an infant. When the observer reports a sudden, brief, as the definition involves, and now resolved episode with one or more of the following. So the color change now includes only cyanosis or pallor. Plethora is gone from this definition. Absent, decreased, or irregular breathing. So that is the same as the definition in ALTI, apnea, both central or obstructive. Marked change in tone, hyper or hypotonia, again, similar from ALTI. And then a new component called altered level of responsiveness. And we all knew from, you know, those who worked with kids with ALTI that many infants had this history of altered mental status, which was not captured in the definition of ALTI. A BREW is diagnosed when the history and physical examination do not lead to another diagnosis as an explanation for a qualifying event. And so that is very important. So if you find during your examination that the infant has fever, let's say, then it's a febrile illness. It is not Brew by definition. If an infant has features of congestive heart failure, say, his liver is enlarged, he's working hard at breathing, or has features of bronchiolitis, or has features of meningitis, then by definition, this is not Brew. It is that other condition. And sometimes we use this mnemonic BRIE that refers to brief, resolved, explained event. So all those, when we are able to make a diagnosis, then you can call it BRIE. So by definition, Brew, the episode should be resolved. So when you are examining the patient in the ED, he should have returned to his baseline. If he had underlying congenital heart disease, naturally he would have features of that, but otherwise it should be a baseline examination. He should not have any significant abnormal vital signs in the ED. So the term Brew is intended to better reflect the transient nature, so brief episode, lack of clear cause, unexplained, and removes the life-threatening label. So when you're discussing it with parents, when you're discussing it amongst yourselves, it really reflects the benign nature of this condition. The committee did another good job and classified Brew into lower risk and higher risk categories. And when we talk about lower risk, what does that mean? So what was the outcome related to which it was lower risk? And lower risk was related to a recurrent event. So if suppose an infant had an event today and he continues to keep having these events, tomorrow, day after, then naturally the parents would be more worried, they would be more scary. So they included that. And an undiagnosed serious condition that confers a risk of serious outcomes. So amongst Brew, there's a very small subgroup, but who are identified as having an underlying serious condition. So they wanted to know if we could identify some criteria that could distinguish these groups between lower risk and higher risk, because the management would be different for them. So the Brew guideline provided management recommendations for the lower risk infants, but not for the higher risk infants. Their recommendation for the higher risk infant was, we don't have good evidence-based guideline to really put my money on it, so continue to manage them based on your clinical expertise. So this is important, the low risk patients. So this is similar to what we talked about ALTI. People figured out long back that almost 80% of those infants could actually be discharged home completely safely without any adverse outcome. Even if they were admitted, they would receive very little significant intervention. So they said for these low risk patients, you do not need to do any testing in the ED other than 2 possible tests. And those 2 are also possible tests. The first one is you can obtain testing for pertussis if there is history of potential exposure, depending on the vaccine history, if there is pertussis activity in the community. And why is that? Because sometimes pertussis, before causing the coughing episodes, can cause an apnea. So in very young infants, in the sort of incipient stage of pertussis, they can just present with an apneic episode, and 1 or 2 days later, they'll start the coughing episodes as well. And the second test they said consider it was EKG. So again, if there is a strong family history of multiple deaths, a sibling has died before of unknown reasons, if there is history of congenital heart disease in siblings, then consider doing an EKG. But other than that, pretty much they said you don't need to do any other screening tests. And often people are concerned about cases of non-accidental injury or child abuse in this setting. So AP sort of a limited recommendation had earlier, a few years earlier suggested considering doing CT scans amongst all infants with ALTI. So this guideline with Brew sort of took back that statement, and they said a thorough history and physical exam to detect infant maltreatment nearly always created the index of suspicion to justify further testing. So consider further testing only if history or exam gives you some doubtful criteria, raises the doubt about child abuse. if the infant has, any of those altered mental status, etc., but then he wouldn't meet the criteria for BRU, right? So if he has any bruises, one of our speakers earlier talked about this rule, TENS rule, etc. So, if you have any concerning features, then consider it. So what about higher risk? So this was, remember, in 2013. In 2019, some of the authors of that original guideline came up with a framework for evaluation of the higher risk infant. So they published a new study. This did not reach the guideline status. And basically this framework again said, do it based on your clinical risk. If you're worried about an infant in the higher risk about any condition, about cardiac disease or GI disease or respiratory disease, then do the workup, but otherwise, he should be good. Now at CHOP, and this is a nice sort of segue to share this with you. We love working with pathways. So what are pathways? Pathways are, we set up a team of physicians and nurses and pharmacists as needed from multiple divisions. So for example, for BRU, we created a pathway involving ED physicians, neonatologists, hospital pediatricians, PICU staff, and the RT staff, etc. And, so we have 50 PEM physicians in our ED approximately. If everybody is managing this patient with BRU separately, then you're not going to figure out, what works and what not works. But if you create a pathway based on everybody's input and decide, okay, this is how we are going to manage the infants with BRU, then if you review your work, so again, it comes to quality and patient safety work that Manish talked about earlier. If you know what you've been doing and everybody has been doing that, you collect data about it, then you can relate, okay, this step seemed to work. It identified your outcomes well. So we need to continue with it, but this step was not needed or it didn't affect outcomes. So maybe we can leave that step out. So that's why clinical pathways are really important. And I would encourage all of you here, if in your institutions you don't use them already, consider developing these pathways. I know of CHOP pathways, the Children's Hospital of Pathways. They're available online, completely free. So all you have to Google is, CHOP ED pathway for BRU or CHOP BRU pathway, and it'll take you there. So feel free to access them and, feel free to customize them. Some of the resources, some of our, things may not be available to you. So feel free to customize them, but develop a pathway and, use it to improve your practice. So we had published the original version in March 2017, soon after the original guideline came, and then we revised it after the revised version came. So, basically it talks about, leads you into, if he meets BRU criteria. We've already talked about the BRU criteria. And then how do you divide them into lower risk versus higher risk? So a low risk patient is defined as somebody with age more than 60 days or more than 2 months, gestational age more than 32 weeks gestation, and post-conception age more than 45 weeks. So what do we mean by post-conception age? If suppose an infant was born at 30 weeks gestation and he's now 8 weeks old, his post-conception age would be 38 weeks, all right? So he would still meet the higher risk criteria. If he was born at 30 weeks gestation, but he's now 4 months old, which is about, let's say, 18 weeks, then 30 plus 18, 48 is more than 45. So now he would meet the lower risk criteria. There should be no history of CPR by a trained medical provider. So that's an important thing, that if the parents were afraid and they did some mouth-to-mouth breathing, that is not counted in it. But if EMS came and they also felt that the infant was not breathing or did not have a pulse rate, and they did a CPR, then that counts. The event lasted less than 1 minute. So duration of event less than 1 minute. That it was the first event. So no repeat events. If an infant had had multiple events during the prior 24 hours or during his prior life, then it was not a low risk event. That he did not have any concerning past history. The most common past history is prematurity, but if he has an underlying heart disease, if he needed to stay in the NICU for 5 days because of some concern, then that is considered a concerning history. And that his exam was baseline. I mean, that is needed just for the diagnosis of BRU anyway. So if he meets all these criteria, and all of those criteria have to be met, then he would be considered lower risk. But if he did not meet any of those criteria, then he would be considered higher risk. So how do we manage these infants? So we're going to focus first on the lower risk infant. And basically, as you see, review the nature of event with caregivers, reassurance, and shared decision-making. So nowadays, those days are past when the doctors could just tell the parents, okay, this is what we need to do, bye-bye. Now, and it's made life so much, actually, I believe it has made our life easier because now we can share our sort of, concerns and frustrations and all of that with the parents and make a decision jointly. It does not, so, I just want to reflect on this. Shared decision-making does not mean that, you do as the parents say. No, it doesn't mean that at all. It means you use your informed judgment. You're the expert. You bring the evidence to bear to the parents that, look, this is what the evidence says. This is what I would suggest to you, and let's do this. If, you can sort of change things at the margins where it does not harm the infant. But if, they're suggesting something that harms the infant or that's not good for the infant, and you agree to do that, then that's not shared decision-making. So you do that. You observe the infant in the ED for 1 to 2 hours, keep him on the heart rate monitor, saturation monitor, let the infant do a feeding trial. And if all of those go well, then you can safely discharge the infant home, all right? To follow up with his PMD in the next 1 to 2 days. If he comes in the higher risk criteria, it's essentially the same, but you just want to be a little bit extra cautious. And the AP guideline did not specify a time to watch, but we would usually watch the infant in the ED rather than 1 to 2 hours for 2 to 4 hours in the ED, just to give them extra time. And if there were any concerns, again, the factors in the higher risk criteria are different. So we would come and talk about those later, but then you make your decision again about whether that infant needs to be admitted to the hospital for watching versus discharge home. Sometimes admitting the infant for observation for a 12 to 24-hour period is not that bad. There are billing issues, there are, issues about the family's convenience. But if you are concerned, if the family is confirmed, bringing the infant in overnight, watching him, while you're not doing any significant interventions, is not the worst thing in the world. All right. So I just want to make a proviso with this slide that what I'm talking about, no testing, simple observation, et cetera, applies to infants that meet the criteria of BRU, where by definition, on examination, they are normal in the ED, all right? But if you see an infant who is sick looking in the ED, he's tachycardic, he's cold, he's warm, he has evidence of congestive heart failure, he has bruising, he still has altered mental status, that's not the infant we are talking about. Then you follow your ABC approach and manage accordingly, all right? So luckily, with this condition, again, as we have seen, people talk about lots of studies. When we do a study, what needs to follow is further studies to find out really if that guideline is changing outcomes or not. If what that guideline recommended can be implemented, so those would be the process measures that the guideline said, okay, take these historical elements into consideration. These are the lower risk criteria. Are they easy to catch from the record? Can you see, which of those lower risk criteria people are measuring? Like Dr. Shah said, the duration of the seizure event, it's very difficult to capture. So if you put those kinds of criteria, then they're not going to be that useful. So we set up a multi-center collaborative involving, I think, about 15 hospitals related to this. And we collected some baseline data before the guideline came out, and then after that to see how we were doing, which were the measures that we could easily collect. Did we really reduce testing in the lower risk infants population? Did we reduce their admission rates? What were the serious conditions that were missed by implementing this guideline, if any? So we set up this collaborative, and this has already started making changes. We've had multiple publications related to this. And I'm going to talk about just a couple of things that have started to emerge from this. As expected, we found that so one of the criteria for hospitalization, one of the things that we thought might happen is that amongst the infants with the who were hospitalized, perhaps lots of them will develop new symptoms and signs so that we might discover some underlying pathologies in them. So the studies have shown that most infants who are hospitalized with BRU actually did not receive any other explanation during hospitalization as well, and they continue to do well. And the majority of diagnoses, even if new diagnoses were made, were benign or self-limiting conditions like upper respiratory tract infection, like gastroesophageal reflux. And then this was the sort of main study that came out of it. And what we found was, so we identified 2,000 infants who met these criteria. This was like one of the biggest BRU studies, multi-center studies conducted about it since the guideline came out. And 87% met AP higher risk criteria. So this is, again, we expected, because if you are familiar with it, ALT, we found that the median age of infants with ALT use was about 40 days. Similarly, even in our population, we found that the median age of patients was about less than 2 months, and our cutoff one of our cutoff is age of less than 2 months for lower risk, for higher risk, for lower risk. So since majority of infants are lower than that, naturally most of them are going to be lower risk. 60% were hospitalized, so our hospitalization rate has already come down from the overall about 75 to 80% to 63%. No patient died during the initial encounter, whether lower risk or higher risk. So again, it continues to tell us that, especially with the narrowing of the definition of the BRU, overall, it is a benign entity. Serious diagnoses were made in 4% of cases. So in a small proportion of cases, but we were like very liberal in calling them serious and in defining a time window. So we included infants who were identified during any follow-up over till they achieved the age of 1 year. So suppose an infant was seen at 1 year, we conducted follow-up till 1 year. If at any time during that, they were identified with a serious disease, we said maybe it is linked to that initial encounter, and we included. And you can see 45% of these were actually made during the follow-up visits. What were the commonest serious diagnoses? Seizures. So we know seizures, sometimes they can present with altered mental status in infants, just because of the brain maturation. I'm sure you guys know that an infant who's like 1 month, 2 month old, just by definition cannot have a generalized tonic-clonic seizure. So what kind of seizures they have? They have focal seizures, just focus involving one focus, for example, some lip movements, or sometimes they can be multifocal. So there might be a little movement of the hand, little movement of the face. So they are more difficult to identify. And if they are very brief, they can very easily be lost. Infant is sleeping much of the time, mom is away, she catches a little bit, she might only see, some pallor or some altered mental status. Airway abnormalities, so, laryngomalacia and those kinds of things. Abusive head trauma, luckily, was seen in only 0.3% of cases. And of these 7, 6 were identified actually on follow-up. So we can't really say that they were linked to this event. So it was extremely rare. This slide lists the serious explanatory diagnosis. There's a whole list of them, but extremely rare. If you look at their population incidence, that's probably going to be similar to what we found here. So how did the rule do, the lower risk versus higher risk? So we found that, no, that's in the next slide. So in this, the risk factors that were associated with serious underlying condition were abnormal medical history, which was most often history of prematurity, which is sort of intuitive that if they were preterm, they are more likely to have underlying condition. History of similar event. So that was an important thing, that if they had history of multiple events, like 2 events in the last 6 hours, or an event, 2 events in the last 2 days or 1 week even prior, then they had a higher risk of something going on. If there was an associated history of altered responsiveness, that was mainly linked to those with seizures and color change, because now we don't have the plethora, it's only cyanosis or pallor. So these were the important factors. The performance of AAP higher risk criteria was pretty good. For serious underlying diagnosis, it had a 97% negative predictive value, which is the more important thing. We don't want to miss bad things. The positive predictive value, as expected, was very low, and we can do better on that. Some criteria that were not found to be associated with worse outcomes were age of less than 2 months and even duration of more than 1 minute. So again, similar to epilepsy, when somebody is having a seizure, parents are not taking out their watch or their phone and measuring the interval. The same thing with the Brew event. So it's difficult to capture, doesn't really tell you the exact thing. And so if we could remove these 2 criteria, for example, from those high-risk criteria, our positive predictive value will increase so much. So hopefully, in the next iteration of the guideline, these items may be removed. And then how about utility of diagnostic testing? Again, we found that, so because the guideline mentioned even consider doing an EKG, EKG was done in a lot of patients. Almost 15% of patients had EKG done, and it was similar proportion in lower risk and high risk, but not a single patient was identified having significant cardiac disease because of the EKG. So that tells you, pretty much you don't need to do EKG unless there is some other justification for it. Proportions that contributed to a final diagnosis, lab tests, 1%, less than 1% of all the tests came out abnormal and contributed to some new diagnosis. Imaging, again, mostly useless. Consults, 5%. So that was relevant to ENT, for example, where they diagnosed laryngomalacia or some other upper airway abnormality. The neurologists, where they were helpful in making the diagnosis of seizures. So those were the main consults that were useful. So overall, our work further supports the guidelines recommendation of limiting testing in this group of infants with Brew. How am I doing with time? Am I good? Yeah. Okay, awesome. So we'll briefly review the cases that we touched upon in the beginning. So 2-month-old, 34 weeks gestation with 30-second episode of slow and shallow breathing, color change, normal tone, possible altered mental status. The infant appears well now with normal vital signs and exam. So the first question is, does he meet criteria for Brew? Yes or no? You can shout out. So yes, right? So the event is brief, 30-second, most people would say is a brief episode. Brief, unresolved, R for resolved. So the infant appears well now with normal vital signs and exam. That means the event is resolved. Unexplained, at least by the history and exam, if the examination is normal, there's no other history, there's no other clear diagnosis coming to mind here. So he meets the criteria for Brew. Now about the lower risk versus the higher risk criteria. So again, if we see the infant was born preterm, 34 to 40 weeks. So based on the definition, it had to be less than 32 weeks. So it doesn't mean that criteria, but if you think about the post-conception age, there it had to be more than 45 weeks for him to be classed as a low risk. Here it will be 34 weeks plus 2 months, so about 9 weeks, which will be 4 and 9, 13, so 43 weeks. So it is still less than 45, so he would classify as a higher risk infant, right? So how do you proceed? Does that mean that we have to admit this infant to the ED necessarily? No. Remember, the guideline does not say that you have to, so what the guideline says is that you can discharge the lower risk infants. For the higher risk infants, use your clinical judgment. In this case, I don't see any sort of serious, dangerous issues cropping up here or confronting us. There are no like red marks or anything. So, do your shared decision making with the parents, explain the nature of the condition, observe the infant in the ED for 2 to 4 hours, keep him on the monitor. If he's feeding well, if his vital signs remain completely normal, it's completely safe to discharge the patient. How about this one? So this is a 10-week-old with 30-second episode of slow to respond. So that's basically, how people will say, but that means altered mental status, shallow breathing, color change to pallor, and eyes seemed staring. He had a similar event yesterday. The infant does appear well now with normal exams. So does he meet the criteria for BRU? Again, it seems to be a brief resolved event. He has a normal exam currently in the ED, so he meets that criteria. How about lower risk versus higher risk? So he's 10-week-old, so more than 8 weeks. So by age, he's lower risk. Had a similar event yesterday. So he's had a prior event, so therefore he does not meet the criteria for lower risk. Remember, if he meets, he has to meet all those criteria. Even if he does not meet one criteria, then he becomes higher risk. And the other thing potentially concerning about this infant is this story about eyes seem staring. So remember how I said that seizures in a young infant can be very subtle. They're not going to be, grand mal, generalized tonic-clonic seizures. So, and he's had 2 events. Could this represent seizures? Who knows? So again, talk to the parent. One option would be to admit the infant, involve your neurology team. They could watch him. They could do a video EEG or a regular EEG, or at least consult on him. If you have potentially you can make an early follow-up appointment with neurology. They can see him within the next week. The family is good with that. Everybody's good with that. Then that's a reasonable option as well. So again, you figure out what the resources are, what would make the parents comfortable, what would make you comfortable, and you decide about that. And then the final case, 4-month-old with 2 episodes over last hours, each lasting about 1 minute. And during the episodes, he had a shallow, stopped breathing, pallor, seemed slow to respond, some petechia on the face. And now he's back to normal, assume that. So again, how to proceed? Does he meet the criteria for BRU? So remember we said brief, resolved, explained event, and the examination should be normal. So you already have, on examination, you find this rash along his right upper eyelid and on the forehead. And I'll tell you, because, on an image, we can't press on it, that these lesions actually appear petechial. When you press on them, they're not going away from there. So what do you think? So it's, that's where you think about your rare conditions, but potentially dangerous conditions. So could this be non-accidental injury? Could he have been sort of, hit there? If he was hit superficially on the face, causing a petechial rash, could he have an underlying intracranial hemorrhage as well? So this would be an infant, certainly, where you would want to do a detailed social history, you would want to do a more detailed clinical examination, and then consider if further testing would be needed, right? And then based on that, you would decide your disposition, et cetera. So he would need to be in the ED for some more time, some more thinking. All right. So this scenario would be rare, but we always have to keep this in our mind. All right, so to summarize, use the AAP guideline. It's a very good resource to define and risk stratify BRU. And we found in our post-guideline studies that age and duration of event are not that useful to identify higher risk. Screening tests have no role in lower risk infants. Base testing and hospitalization decision on other risk criteria and individual patient characteristics. So I would avoid, admitting somebody just on the basis of age and duration of event. But if they have recurrent events, then that's certainly, you would consider in your making decision of hospitalization for the higher risk patients. History, physical exam, and non-invasive monitoring remain the most important aspects of initial management. Even if you're admitting these infants, keep them on the heart monitor, saturation monitor, and just watch them. You don't have to run a battery of tests on them. Don't have to start any treatments, just watch them and see how they do. And look out for an updated risk classification for BRU. Hopefully, we'll continue these studies and we can have a better version of this guideline. Thank you.
Thank you, Dr. Manish, for this excellent presentation. Next, Dr. Manish Shah will present us non-traumatic pediatric surgical emergencies. Welcome.
Okay, so non-traumatic surgical emergencies are quite frequent in pediatric emergency medicine, and it would really be impossible to cover all of them in 30 minutes. So I'm going to use a case-based format where I will share some common conditions that you're likely to encounter in your career. But given that many of you are already experts in pediatrics or emergency medicine, or both, I will also share some unusual presentations of several of these common conditions so that you also think of these conditions when they don't present in the usual manner that is described in the literature or textbooks. So, So the objectives of this lecture are to identify common non-traumatic surgical emergencies in children, to describe usual and subtle ways that they can present, and then to, and to name essential considerations in the diagnosis or of emergency management of these conditions. So case number 1. So a 14-year-old girl presents with vomiting and abdominal pain for 1 day. The vomit is non-bloody and non-bilious and has occurred 10 times in the past day. Her pain is aggravated by eating, but not alleviated by ibuprofen. She states her pain feels like pressure all over her abdomen, and she notes distension as well. Her pain has progressively worsened over the course of the day, and it is constant. The review of systems is noted here, with pertinent positives noted in red. These include a decreased appetite, and last bowel movement was 3 days ago. For the remainder of the cases that I will share, I'll only share the pertinent positives in the review of systems. You can assume that all of these, the rest of the questions here have been asked when age appropriate and are negative for the remaining of the cases. So in addition, the patient's medications, allergies, past medical and surgical history, immunizations, family and social history are noted here. And again, for the remainder of the cases, one can assume that all of these are unremarkable as well, unless otherwise stated. So for her, she had an appendectomy 1 year ago. Physical exam is noted here. I've noted the pertinent positives in red, which include that she is tachycardic to 120. She appears uncomfortable and has dry mucous membranes. Moving on further in the exam, specifically with her abdomen, she's diffusely tender. With guarding and distension, there's tympany to percussion, and she has absent bowel sounds. So for the rest of the cases, only the pertinent positives will be noted. and you can assume the remainder of the physical exam is normal unless otherwise stated. So what is the differential diagnosis? I've listed here potential differential diagnosis in alphabetical order, not to bias you, one way or the other. And so in most cases of medicine, the history and the physical exam can help assign a higher or lower likelihood to each of these. And so with her, specifically, with her presentation, several of these I think would be more common or top of my mind based on her presentation. But we did obtain blood and urine tests as well as diagnostic imaging. And the blood and urine tests included CBC, liver function tests, lipase, electrolytes. These were all normal. Urinalysis, urine pregnancy test, also normal, and pelvic ultrasound was normal. But here we see an upright abdominal X-ray, and you can see here that she has multiple air fluid levels. A supine abdominal X-ray is also shown here. And so when obtaining an abdominal X-ray in the setting of an acute abdomen, I think it's important to get two views, preferably an upright and a supine, because sometimes things can be missed if you only get a one view abdominal X-ray in the setting of an acute abdomen. So this is a case of a small bowel obstruction. The initial diagnosis of an intestinal obstruction is usually made on clinical exam with the help of plain abdominal films. Our patient had a history of vomiting. She also had decreased bowel movements and a prior history of an appendectomy, which puts her at risk of intestinal adhesions at any time in her life. Her abdomen was distended, tympanitic. She had absent bowel sounds. And these are common clinical findings with the bowel obstruction. Dilatation of the bowel is the usual sign of intestinal obstruction on plain films. And she did have multiple air fluid levels. The small intestine is dilated down to the point of obstruction, and the bowel beyond that point is either empty or of reduced caliber. Large bowel obstruction, the large bowel is dilated down to the level of obstruction. I do point out this X-ray though, because for me, in this case, this was specifically what's seen on this X-ray was a new finding for me that the pediatric surgeon that consulted on this case taught me that this finding of what's called valvulae conniventes, which is this appearance of stacked coins in the intestines. And so when you see that, that is a classic finding for a bowel obstruction. Typically, when we see bowel obstruction, we just see the air fluid levels, which was seen on the upright view. And so therefore, I highlight this as an example of the importance of getting the two-view abdominal X-ray. Some other learning points, I think, to reinforce are any prior history of abdominal surgery creates a lifetime risk for intestinal adhesions. And either the presence of an air fluid level, multiple air fluid levels, or a stacked coin appearance with the valvulae conniventes are diagnostic for a small bowel obstruction. So case number 2. This was a 2-week-old boy who presented with 2 episodes of grossly bloody stool in the past 2 hours, which had worsened in severity. The review of systems was significant for fatigue, poor feeding, crying, bloody stool, and pallor, and the remainder was normal. The remainder of the history, including the birth history, was unremarkable. And on physical exam, he was tachycardic, tachypnic, hypotensive, and hypoxic. He was drowsy, ill-appearing, and pale. He had delayed capillary refill, and his abdomen, he was diffusely tender with guarding, and he had altered mental status with a GCS of 10, and he had cool extremities. So to summarize, we have a 2-week-old with bloody stool, fatigue, poor feeding, crying, pallor. So clearly he's in shock based on the tachycardia, hypotension, signs of poor perfusion, altered mental status. Also, there's this diffuse abdominal tenderness and guarding on exam. And the differential diagnosis for bloody stool in a neonate is shown here. And I've differentiated it based on the well-appearing infant and the ill-appearing infant. Most neonates with bloody stool often are well-appearing. They present with streaks of blood in the diaper, and they typically look well. In this situation, we had a clearly ill-appearing child. And so of the things that are noted on the differential diagnosis in that ill-appearing neonate, certain things that are quite time sensitive to identify would be, I would say, the malrotation with midgut volvulus and the necrotizing enterocolitis. So in our case, we sent blood tests to determine the degree of anemia or coagulopathy, since he was clearly having grossly bloody stool. The hemoglobin was 5. The rest of the labs were normal. We sent a type-in screen in anticipation of the need for blood transfusion. We gave 20 milliliters per kilogram of isotonic fluid as a bolus with saline, and until we could initiate emergent packed red blood cell transfusion for hemorrhagic shock. We emergently consulted surgery. And though an upper GI with small bowel follow through is typically what's recommended for the evaluation of malrotation with midgut volvulus, the patient was in shock and was not stable enough to tolerate that procedure. And so an ultrasound can also be done to diagnose it. However, given that this patient was in extremis, our patient was actually taken emergently to the operating room where the diagnosis was made. And he had a malrotation with midgut volvulus. So this is the only case of malrotation that I had seen that presented with lower gastrointestinal bleeding and no vomiting. The typical cases that I have seen present with no bloody stool and they have bilious emesis. And so really bilious emesis in the first 4 weeks of life is a red flag for malrotation. In most cases, although it's still emergent, they are stable enough typically to tolerate getting an upper GI with small bowel follow through, or alternatively, an ultrasound can be utilized to diagnose this. But in this case, the patient was too unstable to tolerate any of that, and the surgeons took him to the operating room directly. So several learning points with this, I think, are that most cases of lower GI bleeding present with a well-appearing infant. And so the ill-appearing infant needs an emergent surgery consult. Our patient was in shock. And so although we did not immediately know the diagnosis, promptly treating that shock, first with isotonic fluid, and then seeing that he was bleeding, mobilizing, transfusion emergently was also important and life-saving. And then finally, midgut volvulus, although it usually presents with bilious emesis, it should still be kept on the differential when you see the ill-appearing infant with lower gastrointestinal bleeding in this age, in the less than 1 month old. So next case number 3. You have a 4-week-old girl who presents with vomiting after every feed, which has been getting progressively worse for the past 4 days. The parents state that for the first few weeks of life, she had only mild spitting up after feeding, and now she is vomiting forcefully every time she eats. The vomit is non-bloody and non-bilious. The review of systems is also significant for decreased urine output, and the remainder of the review of systems is normal. So the remainder of the history is noted here, and it is unremarkable. On exam, you see that she is breathing a bit slow for her age, respiratory rate of 16, with intermittent prolonged respiratory pauses. She has dry mucous membranes and 3-second capillary refill. And despite having vomiting, her abdominal exam appears normal. So in summary, we have a neonatal girl with progressively worsening vomiting after every feed, signs of dehydration based on history and exam, and respiratory pauses on exam. So the differential diagnosis of vomiting in the neonate is broad. I've listed those things here. And for this case, I've included several more plausible conditions to also consider given the patient's history and exam as well. So in our case, we obtained blood and urine tests to help narrow down our diagnosis, as well as some diagnostic imaging. The urine was normal, but the blood showed hyponatremia, hypokalemia, metabolic alkalosis, and hypoglycemia. So to treat the hypoglycemia, we gave 10% dextrose, 5 mLs per kilogram, and we ordered a diagnostic imaging test that made the diagnosis. What imaging test do you think we ordered? Say louder. Oh, I heard ultrasound, yes. So we ordered a pyloric ultrasound. So pyloric stenosis, this is a case of pyloric stenosis. It's best evaluated with the ultrasound. It's caused by hypertrophy of the muscular layer of the pylorus and failure of the pylorus to relax, leading to gastric outlet obstruction. It is present from birth, and typically we don't see the onset of a clinical manifestation of it until 2 to 8 weeks of life. And the reason for that is I think about it like when you exercise a muscle, it takes time for that hypertrophy to thicken. And so it takes several weeks for that already present pyloric stenosis to then get stenotic to the point that it becomes clinically significant. So it is the most common cause of vomiting requiring surgery in infants. It is more common in males by far, but I have seen several cases in females, and that's why I presented this case, because this was a case with a girl who presented with pyloric stenosis. On ultrasound, the muscular layer of the pylorus is measured both in longitudinal and transverse views. And in terms of the diagnosis, there's several things that can contribute to diagnostic criteria on ultrasound. One is having a greater than 3 millimeter thickness. That raises concern for hypertrophy. In addition, the length of the pyloric channel being greater than 14 millimeters. And so I remember that by thinking of pi. The mathematical term pi is 3.14. So 3 being the thickness of the pyloric muscular layer, and 14 millimeters being the length of the pyloric channel. So thickness or length. And then in addition, our ultrasound technologists and radiologists recommend a dynamic image where they are actually feeding to observe if there's passage of gastric contents through the open pylorus. And so if you see passage of gastric contents moving through a pylorus, then pyloric stenosis is much less likely. But if you see no passage of contents, then that too is diagnostic. So several learning points from this case to remember are, though most patients I have seen present fairly early and do not have metabolic derangement, one can see hyponatremia, hypokalemia, hypoglycemia, and metabolic alkalosis with pyloric stenosis. And though this condition is more common in boys, it can occur in girls. And so that just because it's a girl that presents with vomiting doesn't mean that it's not pyloric stenosis. And then at times, this metabolic alkalosis can be so severe that it leads to apnea. And so I've had this happen a couple of times where I've had to intubate the patient who presented with pyloric stenosis because they had such bad metabolic derangement that it led to central apnea. And so our patient presented with irregular breathing and eventually did require intubation in the emergency department because of the respiratory pauses. So case number 4. 9-month-old girl presents with fever and vomiting for 4 days. She's feeding less and she's vomiting 3 to 5 times per day, usually after eating. The fever has not been relieved by ibuprofen. The vomiting is non-bloody, non-bilious. The fever was initially low grade, but today is 40 degrees Celsius. The review of systems is significant for fever, fatigue, decreased appetite, rapid breathing, and vomiting. And the remainder of the review of systems is normal. The remainder of the history as well is unremarkable. And on physical exam, you see the vital signs here. They're all abnormal. She's febrile, tachycardic, tachypnic, hypotensive, and has a relative hypoxia. She's tired, crying, ill appearing, and she has delayed capillary refill. She's grunting. Her abdomen is rigid. She's diffusely tender with guarding. Her bowel sounds are decreased, and her GCS is 14. So in summary, we have a 9-month-old girl with fever, vomiting, and decreased appetite. She is in shock and has signs of peritonitis. Differential diagnosis is similar to one of our prior cases, but the presence of fever makes infectious etiologies more common. So in this case, we obtained blood and urine tests. You know, this is a 9-month-old, ill-appearing infant. So starting with evaluation for serious bacterial infections, but we also did diagnostic imaging with an abdominal ultrasound because of the abnormal abdominal exam, and considered even doing a lumbar puncture and obtaining a head CT because of the fussiness and signs of shock in this infant. Ultimately, it was the ultrasound that led to the diagnosis in this case. Now recall, this is a 9-month-old, and she had appendicitis. So this is the youngest case of appendicitis I've seen ever. And she actually had a ruptured appendix with peritonitis and septic shock. Appendicitis typically presents, as you know, with fever, vomiting, and abdominal pain that begins periumbilical and migrates to the right lower quadrant. Obviously, in this infant, you wouldn't be able to know where her pain had started and how, if it had migrated. Appendicitis is quite rare in infants. It does occur in toddlers, and the diagnosis can be frequently missed in the child less than 5 years old because of atypical presentations and because they cannot localize their pain well. So several learning points with this to remember are when you see septic shock, treat it until you identify what the underlying cause is, and consider appendicitis on the differential regardless of age when you have fever and vomiting without another explanation. So we do have some time for some extra cases. So I had actually prepared 7 cases, but I trimmed it down just in case, since I didn't want to go over time. So I'll do maybe 1 or 2 more since time allows for that. Okay, so case number 5. We have an 18-month-old girl who presents with altered mental status for the past 4 hours. The parents state that she was intermittently crying all day today. She vomited twice, and it was non-bloody and non-bilious. Now she appears very drowsy and is moaning. She only responds to painful stimuli. The review of systems is significant for fatigue, poor feeding, vomiting, and somnolence. And the remainder is otherwise normal, as well as the history. And on physical exam, we see a drowsy, ill-appearing infant. There is right-sided abdominal tenderness with involuntary guarding. She only opens her eyes to pain. She has an irritable cry and withdraws to pain. So in summary, you have this 18-month-old girl with altered mental status that was preceded by intermittent crying, poor feeding, and vomiting. She's ill-appearing, drowsy, and has right-sided abdominal tenderness on exam. Differential diagnosis of altered mental status is broad, but this presence of abdominal tenderness makes a neurologic or intracranial cause less likely. And so in this case, we did get a blood and urine test as well as an abdominal ultrasound, which led to the diagnosis. So she had, so all of that, those other tests were normal, and the abdominal ultrasound is what was diagnostic here. And so you see here transverse and longitudinal views, and she had a diagnosis of intussusception. So the target sign on ultrasound is seen. Intussusception is a common occurrence in infants and toddlers, typically presents with vomiting and intermittent crying. Altered mental status and bloody stool are uncommon presentations of intussusception. So I know that, you know, if you read the textbook, you'll see that current bloody stools are a sign or symptom of intussusception. I will say that I rarely see that in the numerous cases of intussusception that I've seen. Though abnormalities can sometimes be seen on abdominal X-ray, such as a paucity of gas in the colon or a donut or target sign in the right lower quadrant, really ultrasound is the better way to identify it. And so some learning points here are right-sided abdominal tenderness is often found with intussusception. Frequently, I'll try to examine these, frequently these children, if they come in and they're awake, they're usually of the age where they are fearful of a stranger and sometimes may start crying just when you approach them, and it can be difficult to differentiate the location of tenderness on exam. And so I try to catch them sometimes when they're asleep. And I've frequently found that in palpating the abdomen when they're asleep, if there is an involuntary guarding on the right side, I found that that's typically a good indicator that intussusception is present, and then we'll follow up with an ultrasound. With altered mental status, intussusception should be considered when no other explanation can be found as well. I'm going to not do case 6, and I'm just going to skip to case 7 instead, because I think you'll more likely encounter this condition. Okay, so case 7. An 11-year-old male presents with vomiting and right lower quadrant pain for the past 12 hours. The pain is worse with walking or moving. He tried ibuprofen, it did not help. Nothing makes it feel better. The pain is aching. The pain is only in the right lower quadrant. He denies any radiation to other locations. The pain is 10 out of 10 in severity and has been worsening since the morning. He vomited twice, and that vomit was non-bloody, non-bilious. The review of systems is also significant for decreased appetite, but is otherwise normal. His past medical history is unremarkable. And on physical exam, he is tachycardic, appears uncomfortable, and is tender in the right lower quadrant with guarding. And so this, I share this one because this was a patient that was transferred to us. Actually, he was discharged from another hospital, and then the parent brought his discharge paperwork with him, which included the ED notes. So I had the exam that they did, and this is what they had done. He presented to us a day later. So in summary, 11-year-old boy with what initially presented with 12 hours of worsening vomiting and right lower quadrant pain with mild tachycardia, focal guarding on exam. The differential diagnosis in a preteen boy with abdominal pain and vomiting is not as broad as it would be in a teenage girl, but still many things to consider here. And so based on the focality of the right lower quadrant pain and his age, the more plausible conditions on the differential diagnosis are here. And I think, a lot of times when we think right lower quadrant pain and vomiting, sometimes we hone in on appendicitis. This patient had some imaging done that ruled out appendicitis, and he was discharged from the hospital. What was missing in his evaluation? Say again? Genitalia exam. Exactly. So this patient had all this workup done, and he was sent home. And unfortunately, he then presented to us a day later, and we did a genitalia exam. He had an abnormal testicular exam, had a high riding testicle that was extremely tender, and got a testicular ultrasound that showed no flow. And urology was emergently consulted, and he had, unfortunately, testicular torsion. This patient was too embarrassed to mention that he was having testicular pain. I bring this up because this is important, that you may ask the boy, are you having testicular pain? And they might say no, because they're too embarrassed to talk about it. And so it's important to do the exam because they may not feel comfortable saying whether it hurts or not. And so nobody examined the genitalia on that initial presentation. Risk factors for testicular torsion based on history exam are the presence of nausea or vomiting, an abnormal cremasteric reflex, abnormal testicular lie such that it's either horizontal in lie or high riding in the inguinal canal, and age, so peri or post-pubertal, so ages 11 and up are higher risk ages. Most patients with acute testicular pain have either a non-infectious epididymoorchitis or they have torsion in the appendix testis. So I did a study where we enrolled 220 boys that came in with less than 72 hours of testicular pain. 60% of them had one of these diagnoses, epididymoorchitis or torsion in the appendix testis. Only 10% had actual testicular torsion. And the remaining had some undifferentiated cause. The testicle is usually viable within 12 hours of onset of pain, so really timely diagnosis is essential. Viability beyond 24 hours is unlikely unless the patient has been having intermittent torsion and detorsion. So several learning points from this case. Vomiting is a risk factor for testicular torsion, so it should be considered on the differential diagnosis for boys. Lower abdominal pain can also occur due to referred pain from the groin. Some patients may be too embarrassed to report that they have testicular pain, even if you ask them. So doing that genitalia exam in that situation with this clinical presentation is essential. It is unusual to have a normal testicular exam with testicular torsion. So, and so doing that exam is essential. And those abnormal findings that you will see sometimes are abnormal cremasteric reflex, horizontal lie, or a high riding testicle. So I will end there with those 6 cases. Thank you.
Thank you, Dr. Manish, for this nice presentation and case variation. I would like to welcome our next speaker, Dr. Todd Florin, and he will talk to us about approach to seizing child. So welcome, Dr. Todd.
Thank you very much. So this is going to be an extension of what Dr. Shah talked about earlier in his talk about developing a pre-hospital protocol on seizures and status epilepticus. And this will go into the emergency department evaluation and approach of the seizing child. A very common presentation for us in pediatric emergency medicine. So when we talk about pediatric status epilepticus, I'm going to spend about 2 slides just sort of setting a baseline so that we're talking about the same definitions and the same epidemiology. Pediatric status epilepticus, the incidence is highest in the first year of life, and the most common reason that a child will come to us in status is due to febrile seizure or febrile status. Most children who present to us in emergency are neurologically healthy before their first episode. They do not come to us with underlying neurological conditions. 10 to 20% of children with epilepsy will have at least 1 episode of status epilepticus in their lifetime. So up to 1 in 5, pretty not an insignificant number. And status epilepticus often presents as the first seizure in about 12% of kids. So 1 in 10 kids will present with epilepsy will present in status as their first presentation. And mortality is substantial. It can be substantial, 2.5 to 5% have mortality as a result of status. So this is truly an opportunity for us as emergency physicians to intervene and really save a life. So again, just to set some level setting and definitions, we're going to define status epilepticus as a single seizure that lasts continuously for 30 minutes or more, or a series of seizures where function is not regained in between seizure or ictal events over a 30-minute period of time. So this could be having a tonic-clonic episode for 5 minutes that stops, but the child does not regain normal consciousness or normal function. And then perhaps another 5 minutes later, another tonic-clonic episode occurs. And if that occurs over a 30-minute period, then we are defining that child as being in status epilepticus. And status epilepticus occurs for 2 reasons, pathophysiologically. First, is the failure of the mechanisms that are responsible to terminate seizures, or the initiation of mechanisms that can lead to abnormally prolonged seizures. So it's one of these two reasons that status occurs. We will define, generally in terms of timing, we think about 5 minutes as sort of the golden time for generalized convulsive status, and 10 minutes for focal or absence status, where we want to be able to intervene within that time period. And when we think about the long-term consequences of status epilepticus, of prolonged seizures, it's some severe things: neuronal death, neuronal injury, and alteration of neuronal networks. And these start to occur 30 minutes in for generalized status and 60 minutes for focal status. So why 5 minutes? We talk about 5 minutes all the time. We counsel parents, if a seizure is happening more than 5 minutes, that is when you give rectal diazepam. In the emergency department, we think about you need to at least give the first dose of benzodiazepine within 5 minutes. The reason 5 minutes is in these guidelines is that the likelihood of spontaneous cessation of seizure activity is much lower once seizure has occurred continuously for 5 minutes in duration. And there's delayed response to treatment. The earlier that you treat, the more likely the child is to respond to those effective treatments for status, and there's higher risks of morbidity and mortality at 5 minutes. So when we think about how these seizures are classified, they can be classified in largely 4 different ways. First is simple partial status, which is continuous or repeated focal, motor, or sensory seizures without impaired consciousness. We think about complex partial status, where we have continuous or repeated focal, motor, sensory, or cognitive symptoms with impaired consciousness. So this is what the level of consciousness is one of the key differentiators between simple partial status and complex partial status. We have generalized convulsive status, tonic-clonic, tonic alone, or clonic without loss of consciousness. And then we have absence status, which is generalized seizure activity with an altered awareness, but not always a full loss of consciousness. So the causes of status epilepticus are broad and many, and this list is not fully exhaustive, but really addresses the major causes. So new onset epilepsy or seizure disorder, always checking for central nervous system infection, meningitis, encephalitis, or sepsis. We always have to think about brain tumor or malignancy, some form of acute hypoxic ischemic insult or metabolic or electrolyte abnormality. Certainly traumatic brain injury is a first, can present with status epilepticus, certain drugs and toxins, cerebrovascular events or injuries, and NORS, which is new onset refractory status epilepticus. When we think about the complications of status, certainly hypoxemia. So this can result with reduced glucose to the brain that can lead to lactic acidosis. You can have impaired myocardial function, which leads to reduced cardiac output, ultimately leading to hypotension and impaired cellular function. Acidemia, alterations in glucose homeostasis, blood pressure disturbances, increased intracranial pressure, mortality, focal motor deficits. And when we start thinking about longer-term consequences and complications of status, we think about behavioral disorders, intellectual disorders, and recurrent seizures. So let's talk about the initial approach. ABCs, the first 1 to 2 minutes. Clearly, establishing airway is first priority in any child that arrives in status epilepticus. And one thing to consider, if there are signs of partial airway obstruction during status, are airway adjuncts, things like nasopharyngeal airways that can help to open and maintain the airway. Oxygen as necessary, monitors, so pulse oximetry and tidal carbon dioxide can be helpful in understanding how the child is ventilating. We want to obtain rapid IV or intraosseous access, do a brief neurological assessment, and then think about rapid labs. And Dr. Shah talked about fingerstick glucose in the pre-hospital setting, given the very low prevalence of hypoglycemia. That doesn't become a priority in the pre-hospital setting. In the emergency department setting, where we have the ability to multitask in a more resourced environment, we can oftentimes obtain labs rapidly. So in our system, we use an iStat device that can give us blood glucose, rapid blood gas, and electrolytes for the major reversible causes of status epilepticus, really within the first 2 to 3 minutes. Generally, when we're talking about prevalence of these abnormalities, about 3% of status is due to toxins, and up to 5 to 6% can be due to glucose or other electrolyte abnormalities. So small number, but if it's there, we want to know about it because we can actually treat that in a way that may be different than the standard approach to status epilepticus. You want to save a red top tube for anti-epileptic drug levels if applicable. So for kids who come in with known seizure disorder who are thought to be taking anti-epileptic medications, save a red top tube to send those levels, as frequently those levels are subtherapeutic. And that's the reason that the child is presenting in status. And don't forget the history. I think once you've spent the first 5 minutes doing this rapid assessment of airway, breathing, circulation, access, and rapid labs, going back to the parent or observer about the patient's history is critical to the next steps in treating status epilepticus. So a big question that we're often faced with, and this gets to some of the discussion yesterday, is when to intubate. And there always tends to be a bit of discussion in the resuscitation bay about when do we establish a definitive airway, when is the right time to intubate. And in my practice over the last more than a decade now, I've seen huge variation in sort of the timing of when are we going to intubate. And I think more and more in my experience, the ability to avoid intubation, as Dr. Auerbach discussed yesterday, and the complications that intubation brings is favorable than rushing to intubate and now adding additional complications. However, there are certain sort of key factors that we would consider when considering when to place a tube in this child's airway. First, if the airway is unprotected or unmaintainable, you need to establish a definitive airway. It's pretty rare in status that this is the case, but that is one of those characteristics. If there's apnea or inadequate ventilation, if they truly are not able to ventilate on their own, and we're not able to help them with bag valve or non-invasive means, it's something to consider. If there's hypoxemia that's not responsive to supplemental oxygen, or if we have refractory status epilepticus that's lasting for more than 30 minutes, because we will talk about this at the end of this talk. If that is the case, then now we're starting to talk about things like midazolam infusions or pentobarbital infusions, where we really have to intubate in order to maintain airway when you're infusing these medications. So there's a couple of things to think about when you're intubating a child in status. First is that propofol and midazolam both have anti-epileptic properties. So either of those medications, we do not use propofol in our emergency department. There are some emergency departments that do, we do not. I think the vast majority of centers, at least in the United States, do not use propofol in the emergency department. I would be curious to learn how things are here in the kingdom, but midazolam can be helpful as your intubation drug of choice because of its anti-epileptic properties. The second point here is critically important. Obviously, when we intubate, we lose our ability to perform a neurological exam. We're going to paralyze the child. And so we lose the ability to understand, is the child still seizing? What is the neurologic status of the child when we provide a paralytic to that child? So ideally, we want a short-acting paralytic that will allow us to safely intubate the child, but that will then wear off to allow for visual confirmation of continuous status after the meds abate. And so rocuronium, succinylcholine tend to work well for intubation of a child in status. Moving on to some of the laboratory considerations. So, and this gets to some of the causes of status that I presented just a few minutes ago. Once we obtain our rapid labs, our ISTAT, our rapid glucose, rapid sodium, rapid calcium, and a blood gas, we want to think about sending more definitive labs, things like serum electrolytes, calcium, magnesium, glucose, a complete blood count, a blood gas, anti-epileptic drug levels. And in certain special circumstances, you want to think about toxicology, knowing that toxins are in the differential diagnosis of status epilepticus, cultures in a febrile child where there's concern for CNS infection or sepsis as the inciting event, metabolic screens, or neuroimaging. And neuroimaging, you don't want to stick a needle in the back of a child who has increased ICP. And so, so having either a CT scan or if your center is able to get a rapid MRI, those are things that are helpful before putting the needle into the child's back for a lumbar puncture. So a key part of this initial assessment is correction of electrolyte abnormalities. Hypoglycemia, hypocalcemia, and hyponatremia are the three major electrolyte abnormalities that we think about as inciting events for status epilepticus. And so hypoglycemia we define as a blood glucose of less than 50 to 70 milligrams per deciliter. If a child's being maintained on the ketogenic diet, we tolerate lower levels of hypoglycemia. And the treatment is 2.5 to 5 cc's of 10% dextrose. A good rule of thumb that we use is the rule of 50s. So 5 cc's per kilogram of 10%, 5 times 10 equals 50. If you don't, alternatively, you could use 1 cc per kilo of D50 if you had that available. So it's really the rule of 50s to correct hypoglycemia. Hypocalcemia is defined as an ionized calcium of less than 4.3 milligrams per deciliter, or total calcium of less than 7 to 7.5 milligrams per deciliter. And we want to treat with 5 to 7 milligrams per kilogram of elemental calcium. And we can do that one of two ways. Most commonly, we use calcium gluconate. It's the easiest, it's 1 cc per kilo. You can use calcium chloride, but you need to be, calcium chloride can be irritating to peripheral vessels, and so usually needs to be given through a central line. Hyponatremia is defined as a blood glucose of less than 120 to 125, and I give a range for that because ultimately some children will seize at 123 and other children will not seize until they hit 115, 117. For hyponatremia, 3 to 5 cc's per kilo of 3% saline over 15 minutes is the treatment. And if they have this pattern of hyponatremia and hypoglycemia together, you want to consider adrenal insufficiency. Think about getting a cortisol level and IV hydrocortisone as a treatment. So this is a pathway that was drawn from my prior institution at Cincinnati Children's Hospital Medical Center. And you can find these at the website listed below. But in this case, this is a suggested treatment path for correction of hyponatremia in hyponatremic seizures, where you do a rapid push of 1 cc per kilo of 3% saline, which generally will raise the sodium concentration by 1 milliequivalent per liter. And if they're still seizing 1 minute after flush, you give another dose of 1 cc per kilo. If they're still seizing, another 1 per kilo to slowly raise the sodium to sort of the lowest minimum where seizures stop. And certainly you want to consider your etiologies: hypovolemia, renal or extrarenal losses, euvolemia, things like SIADH or hypothyroidism, Addison's disease, and hypervolemia, congestive heart failure, cirrhosis, renal failure, or nephrotic syndrome. So let's move on to the immediate pharmacological management of kids in status epilepticus. Benzodiazepines are really the hallmark of initial management to stop seizures. And we would recommend some benzodiazepine every 5 minutes times 2 if necessary before moving on to second line agents. And there's 2 major intravenous options that we have: lorazepam, 0.1 milligrams per kilogram to a max of 4 milligrams, or diazepam, 0.2 milligrams per kilogram IV, max of 8 milligrams. The duration of effect of lorazepam is longer, so this is something to keep in mind, 4 to 6 hours, as opposed to diazepam, where the duration of effect can be as short as under 20 minutes. And it's important to also remember when we talk about airway that respiratory depression really can start to come into play after 2 doses or more of a benzodiazepine. Now, this study by Jim Chamberlain, our colleague at Children's National Medical Center, was published in JAMA in 2014. And this was a comparative effectiveness study of lorazepam versus diazepam. And in 273 children aged 3 months to 18 years with convulsive status, they were randomly assigned to receive one of the 2 medications in a blinded fashion. And the primary outcome was the cessation of seizures by 10 minutes without recurrence in 30 minutes. And what you can appreciate in the last column, the overall column, is that seizures, status was successfully terminated in 72% of children with diazepam, 73% of children with lorazepam, and those differences were not statistically significant difference. And what you could also appreciate is that neither had increased need for assisted ventilation when compared with the other. And so really the efficacy is similar. There are benefits of lorazepam given it's a little less likely to provide lead to respiratory depression, and lorazepam has that longer duration of action. So really, I think if available, IV lorazepam, it really is our center's first preference for cessation of status. Oftentimes, IV and IO access is not readily available. And so what are the other options that we have for rapid cessation of seizures? So we have a few different routes. We can give intranasally, we can give intranasal midazolam, and the doses are here, or intranasal diazepam. Rectal diazepam or Diastat is certainly an option, 0.5 milligrams per kilogram to a maximum of 20 milligrams. You can give midazolam intramuscularly. You can give it buccally in the cheek. Generally, we have now, when I first started training, we were using a lot of rectal diazepam. Now we go to intranasal as our sort of first line when we do not have clear vascular access available to us early. So we've given our 2 doses of benzodiazepine, and we are now at our second line therapy because the child is still seizing and those were not effective. And we have several options here. Phenytoin was the traditional second line option, and then fosphenytoin was a newer derivative that has certain advantages. Generally, we want to avoid phenytoin or fosphenytoin in toxin or drugs because it can intensify seizures. The dose of phenytoin is 20 milligrams per kilogram. We do not want to give it fast. It can be toxic. It can cause a phlebitis. It can cause extravasation, it can lead to extravasation if given quickly. You do not want to give phenytoin with dextrose because that can lead to precipitation. And the consequences of rapid administration are things like venous thrombosis or purple glove syndrome, where you get a thrombosis and the hand turns purple, just like a glove. Fosphenytoin is a newer derivative that has become popular, which has an improved safety profile. You can give it more rapidly. It's less likely to precipitate. However, you generally want to avoid in sodium channelopathies, things like Dravet syndrome. So if you're working with it at a center, sort of similar to King Faisal, which is a tertiary advanced center, you might have children coming with sodium channelopathies, as underlying, and you generally do not want to give phenytoin or fosphenytoin in those channelopathies. Levetiracetam, which goes by the brand name of Keppra, 20 to 60 milligrams per kilogram per dose, has a pretty rapid onset of 15 to 20 minutes, a duration of 6 to 12 hours. Valproate is another option for a second line agent, 20 to 40 milligrams per kilogram over 5 to 10 minutes with a duration of 4 to 6 hours. And then phenobarbital is in the textbooks as a second line agent, but is usually reserved for use as a third line agent. You can have more sedation and respiratory depression with phenobarbital than some of these other agents. Generally, some prefer levetiracetam over phenytoin because of its ease of use. You can give it more rapidly, and it has a lower side effect profile compared to phenytoin or fosphenytoin. So there were 3 key studies that did comparative effectiveness of these 3 agents, these 3 second line agents, to try to discover if one was better than the other or if one was worse than the other. This trial was the ESET trial that was performed by the PCARN network and published in the New England Journal of Medicine. There was the CONCEPT trial, which was published by our colleagues in Australia and New Zealand through the PREDICT network. And then there was the ECLIPSE trial, which was published by our colleagues in the UK and Ireland, the PERUCI network. So we have 3 comparative effectiveness trials that fortunately showed similar results. And we'll go through these briefly. So the ESET trial, which was the trial in the United States through PCARN, enrolled 384 children, 2 to 17 years of age, with convulsive status that was refractory to 2 doses of benzodiazepine. Patients were randomly assigned to receive levetiracetam, fosphenytoin, or valproate. And the primary outcome was a cessation of status and improvement in level of consciousness at 60 minutes. And as you can see, it was fairly equally distributed across the three groups. The percent of patients with the outcome was 47% in levetiracetam, 45% in phosphenitoin, and 46% in valproate, and had similar levels of effectiveness. This is also shown here in this Bayesian diagram that showed the posterior probabilities of success. And you can see that the three curves are overlapping, suggesting that the posterior probability of success for each of these agents was largely equivalent. And then when we look at some of the adverse events, we can see that phosphenitoin had a slightly, though not statistically significant, increase in life-threatening hypotension within 30 minutes. There was a slight increased prevalence of endotracheal intubation after starting the infusion in phosphenitoin, and levetiracetam had a very slightly increased proportion of those who died. But what you can appreciate is the absolute numbers of all of these things are very small, and so we cannot draw major conclusions about adverse events for any of these three drugs. Concept: this randomly assigned 233 kids, 3 months to 16 years of age with convulsive status, failing benzodiazepine treatment, to either 20 milligrams per kilogram of phenytoin or 40 milligrams per kilogram of levetiracetam. And what you can appreciate here is in the intention to treat population, the risk difference was not statistically significant between phenytoin and levetiracetam. And similarly, the table at the bottom shows that adverse events were similar between the two groups. Eclipse basically shows us the same thing. This is a time to event Kaplan-Meier curve that shows the probability of seizure continuing with time on the horizontal axis. Levetiracetam is in blue, phenytoin is in red, and the curves basically look pretty similar. And then when we look at the need for further anticonvulsants, the need for rapid sequence intubation, admission to critical care or serious adverse events, you can appreciate that there were no significant differences in risk of these adverse outcomes between the two groups. So the bottom line and consideration for second-line agents is phosphenitoin, valproate, levetiracetam are equally effective with a similar adverse event rate. Phenytoin and phosphenitoin is less effective against toxins or drug-induced status. Phenytoin has more safety concerns and limitations. And certainly if we're going to give one of those agents, phosphenitoin at our center is what we will choose over phenytoin because of all of the things that we just discussed. And given the equal efficacy in these three well-performed trials, levetiracetam is really preferred if available because of ease of administration, more rapid administration, and a lower side effect profile. But an advantage of phosphenitoin, particularly if you do not have access, is that you can give phospheny intramuscularly, and is a good second choice. So what about refractory status epilepticus? So refractory status epilepticus are seizures that last more than 30 minutes despite giving 2 benzodiazepines and a dose of second-line therapy. Midazolam infusion is often first line for refractory status epilepticus, 0.2 milligram per kilogram bolus, followed by an infusion of 0.05 to 0.1 milligram per kilogram per hour. This results in seizure termination in 71% of kids with refractory status. If you have a child in refractory status, this is the child that you want to consult neurology on to basically get them set up for EEG. There are rapid EEG protocols that can happen in the emergency department, but most of the time this is happening in the intensive care unit while you're treating them to ensure cessation of status. Pentobarbital is a 5 to 15 milligram IV bolus, followed by an infusion of 0.5 to 5 milligrams per kilogram per hour. With pentobarbital, generally you lose airway, and so you really have to intubate if you're going to do a pentobarb infusion, because you can have respiratory depression, hypotension, and myocardial depression. And then propofol, small studies, but narrow therapeutic window. So you really have to pay attention to things like hypotension, apnea, and bradycardia, and really also need to avoid in patients that are being maintained on the ketogenic diet for their epilepsy. So this is the summary of the initial management of the seizing child: airway, breathing, circulation, access, rapid labs in the first 5 minutes, and at least that first dose of benzodiazepine in the first 5 minutes. Then in 5 to 10 minutes, you're going to maintain your monitors and your oxygen, If there's signs of infection, think about antibiotics, evaluate for other etiologies, fix the electrolyte abnormalities, and think about your second dose of benzodiazepine. And then at 10 to 15 minutes, you're reevaluating your vital signs, reevaluating your ABCs, placing a second IV for access, preparing for airway maneuvers, and giving a second line anti-epileptic drug. I can tell you at our center, it takes some time to draw up the second line agent. So if you are giving the second dose of benzo, you are asking for second line agent at that time so that you can allow for the time for that to be drawn up. And then 15 to 30 minutes, you're reevaluating and you're thinking about third line AED. We did not talk about pyridoxine, but you want to think of it for INH poisoning or children less than 1 year. With that, thank you very much.
Thank you, Dr. Todd. And I would ask our speakers to be in the podium, please. And we receive few questions. Have anyone?
Hello. My question for Dr. Mital, for cases of BRU, do you think the assurance of follow-up will make difference in your disposition? For example, if you are quite sure that there will be a pediatrician or emergency physician will see the patient in the next day, will make difference in your disposition plan. In our system here, we are developing the family physician or pediatrician for each child, but still not the standard of care. So we don't have a primary physician for each child.
Excellent question, and thank you for asking that. And this raises a very important point that when these guidelines are written, when the guidelines are written in America, they are mainly focused on American audience. So in America, most infants, most kids have a pediatrician. So it's relatively easy to arrange a follow-up. The guidelines actually say follow-up within 24 hours. I did not emphasize that in my talk. And in CHOP pathway, actually, we've removed that duration as well. We just say early follow-up. And why is that? Because overall, BRU is a benign condition. The chances of serious events being missed, the chances of recurrent events is extremely low. We did a follow-up study which has not been published, where we did a 6-month follow-up and about the recurrence rate. So just simple BRU, not a serious event, recurrence rate was about 10% over 6 months follow-up period. So it is still pretty low. So I think the guidelines also recommended teach the family or offer them resources about CPR guidance, how to perform CPR at home. I think both of those things send mixed messages. On the one hand, we are saying BRU is a benign condition. On the other hand, we want to teach them how to conduct CPR training, that you should follow up with the PMD tomorrow or with your pediatrician tomorrow. You have to remember that in medicine, we are very conservative. We want to avoid any serious outcome as much as possible. And that's why those recommendations. But I think it is completely safe if the infant is unable to follow up with the PMD next day. But you can say, if anything happens, follow up with the PMD or just come back to the ED. That would be safe.
Everyone, regarding the status epilepticus, is there any role for the ketamine in aborting status epilepticus to use it? This is the first question. Second question is regarding the surgical abdomen. One of the common things that we face is inguinal hernia in a newborn. So what's the incidence of developing that to a surgical abdomen or intestinal obstruction?
Okay, so for the first question, you were asking what's the role of ketamine in treatment of status epilepticus. So ketamine is also an acceptable third-line agent. So after, as Dr. Florin summarized, after you've given 2 doses of benzodiazepines, if you're going to a second-line agent, either levetiracetam, phosphonatoin, or valproic acid, if that fails, at times you can give a second-line agent, or you can just go straight to then the third-line agent. Third-line agents being the ones he summarized, midazolam, propofol, or pentobarbital drip. A fourth option is, as you suggested, ketamine, that is reported in the literature as well. Really, I think that there's very limited evidence comparing those 4 as third-line agents, because as you progress down the status epilepticus management pathway, the number of patients that need to go to second-line agent, then down to a third-line agent, it significantly decreases. Usually second-line agents are quite effective at stopping status epilepticus. So there's very limited evidence about comparative effectiveness among those fourth-line agents, but ketamine is absolutely an option. And then I missed your second question.
Hernia in newborn.
Yeah, that should also be on the differential for vomiting in the infant is incarcerated inguinal hernia. Typically with an inguinal hernia, it's, the other thing on the differential to differentiate inguinal hernia versus something else is hydrocele. I've been fooled myself on a physical exam by a very tense hydrocele, thinking that it was an incarcerated hernia, but and really that's where transillumination can be helpful, or ultrasound, to differentiate that. But yes, if you have an incarcerated inguinal hernia, that's also an important situation to emergently consult the surgeons.
My question, Dr. Manish, but maybe a little bit apart from emergency medicine. Regarding pyloric stenosis, I read in Nilsson textbook, they are trying for conservative treatment rather than surgical treatment by atropine, long course of atropine. I don't know if you have any idea about this.
For which condition?
Pyloric stenosis.
Oh, I'm actually not familiar with that as a treatment option. Any of the rest of the panelists are? No. So, I think I'm not, obviously any surgical intervention has risk. The surgery for pyloric stenosis is, I think, a lower risk surgery relative to other surgical procedures with a minimal complication rate. So I think that's why it's accepted practice, but I'm not familiar with that literature using alternative medical treatment rather than surgical.
So thank you for the enlightening talks. For the bacterial meningitis, one of the things we struggle here is to convince the family to get the LP. Is there any scoring system that help us or guide us to have more evidence so we can convince the families? And my second question is about the status epilepticus. I just recently finished residency, and from my experience in residency, what I learned that there is an age the age cut of using certain drugs for status epilepticus, especially with palaprate. What is your take on that?
Thanks for the thoughtful questions. I think we've all been there, and parents are reluctant to have their infant or their older child have a lumbar puncture performed. And interestingly, what we've seen is that the rates of performing lumbar puncture, at least in the United States, have gone down substantially as the risk of bacterial meningitis has gone. So, the number of LPs performed per unit patient volume are like half what they were a decade ago. I think in terms of a conversation with an individual patient, usually bacterial meningitis is sufficiently scary. And if you're clinically concerned some shared decision-making with the parent about what you're worried about can convince them to allow you to perform a potentially uncomfortable procedure. But I think it's hard, the pretest probability is going down. And so it's always a little bit of a decision-making. In terms of an evidence clinical decision rule to guide that decision, we use our signs and symptoms and maybe some peripheral labs, but the evidence is less definite in that area.
Dr. Florin and I just consulted with each other. So regarding so he said I could answer on behalf of the group. Regarding age differentiation for treatment of status epilepticus, the only situations where I've seen that an age differentiation should be considered is with second-line agents. Typically what Dr. Florin summarized was levetiracetam, valproic acid, and phosphonatoin. He had also included phenobarbital on that list. Phenobarbital is often the preferred second-line agent in the infant less than 6 months old by the pediatric neurologists. And so in a collaborative development of a clinical practice guideline with our Canadian colleagues, our pediatric neurologists that were part of that clinical practice guideline development group actually suggested that age differentiation of less than 6 months old second-line agent consider phenobarbital rather than those other medications. But over 6 months old, then what Dr. Florin had summarized is what I would agree with as well.
The one thing I would add to that is just remember the age groups that were included in those trials went down, in 2 of the trials went down to 3 months of age. So, while the sample size, is going to be potentially a little bit lower, and I don't remember if those studies did subgroup analysis by stratifying by age, but those studies would suggest effectiveness of these other agents as well.
Okay, we'll have some of the online audience that have some questions, so we'll try to make it as short and quick, so we could go all on lunch and enjoy some food. Some of the audience and the online ask the same question regarding the age differences and the neonate. And one of the audience asked, does that algorithm of status epilepticus change when the patient's known seizure and on anti-epileptic medications?
That's a great question. The fundamental algorithm and approach does not change. I think what changes is, as mentioned, is sort of the differential diagnosis. And if a patient has known seizures maintained on antiepileptics, it is critically important at that time to obtain antiepileptic drug levels, because up to 1 in 3 children with known epilepsy present in status because they have subtherapeutic drug levels. So that is a critical diagnostic piece, but the approach is really the same. The other thing that I will say about that very quickly is if they're maintained on levetiracetam, that's the second line agent that you should go with. You should go with the agent that they are being treated with as part of their anti-epileptic regimen. I don't know if Dr. Shah has other thoughts on that.
Yeah, I would agree with that. I think the other consideration is oftentimes I find that in these patients with known status epilepticus, they may have a prior history of adverse reactions to other anticonvulsant medications. So I think that's also an important question to ask the parent when you're giving the benzodiazepines is, what are their allergies? Because that might help me differentiate if I'm going to give levetiracetam, phosphonatoin, or valproic acid. My typical first choice, as Dr. Florin recommended, is levetiracetam, but there are times when I might choose something else.
Okay, the second question would regard the meningitis score. The audience is asking if my institute doesn't provide the CRP quick enough, and it will take 24 hours, or I don't have procalcitonin. So how would I adapt the score, or in which way I would modify it?
Sure. So the bacterial meningitis score, which is the older one, is routinely available lab. So that is always available. The newer one, which I think there's a little less evidence just that's newer, does include these biomarkers. So I think if they're not readily available, I would just rely on the bacterial meningitis score, the original version.
I think we'll wrap up by this time, and I would like to thank the the panel discussion and the doctors that participate with their time. And we'll go for break, Dr. Favi. I think it's a lunch break and time for prayer. Then we'll see you inshallah after that. And I hope you enjoy your time and food. Thank you very much.
After the break, please. The distribution will be the same like yesterday for the panel discussion. I think the discussion yesterday, there was like IT technical problems. It was solved. This hall will be for Dr. Al-Madi and Dr. Salih Al-Shehri. Dr. Salih Al-Shehri, yes. They will have this panel discussion, I think, knowledge. So you can come here, okay? The rest of the group, they can go to the classroom. There is 4 classrooms. You can enjoy the same topics of yesterday, okay? And if there is any question, there will, you can, or anyone of the faculty. Thank you very much. Yeah, at 1 o'clock we will start sharp, please. Thank you very much.
Okay. So for this patient, what you have to do, he's 12 years old. Okay. This is the high score. So for this patient, what you have to do, like this this hematoma, you have to drain this hematoma. Otherwise, will will cause complication for this one. If you not drain this is and release that pressure. No need for suturing for this patient. Just sometimes can be helpful to start antibiotic, but it's not as practical for any patient to go for antibiotic. Okay. Next.
So what's underlying etiology for this disorder? Is it autoimmune, or is it genetic, or is it idiopathic, or infectious? Okay. So four have been answered the right question. Is it genetic? It is genetic. What is this one? Been answered by that? So this incontinent pigmentosa, actually this inherited disease that can be inherited from birth to 2 weeks. Those patients who present to the emergency, you need to evaluate them. Also, you need to be evaluated by ophthalmology and also by the general pediatric, also for checking the eye also. So, Nova. Now, where is Hussein? Okay. Next question.
7 years old girl was cut on the broken glass table and sustained this patient sustained large laceration her right thigh. She has weight 20 kg. What's the maximum number of the milliliter for 1% lidocaine with epinephrine that could be safely to be injected intradermally on the time to repair this wound, the maximum?
How many cc the volume? This one, 8 cc, 14 cc, 10 cc, and 10 cc. Answer it.
Okay, only 5 of is right answer. Why select this is 14 cc? 1%. For this is 1% for this any patient present concentration 1% for this one. To be 1 ml for this 1% will be 10 for this one, 10 milligram for this one. So for any patient present with lidocaine and epinephrine, the maximum is 7 milligram per kg. This is the maximum. So if it's 20 kg, will be, what's the maximum? 140. So how can get this 140? If there is 1 ml can give 10 ml, 10 milligram. So the maximum is 14 cc. Okay.
So 17-year-old male present to you with the complaining of severe neck pain after being tickling in the football, so his bare back. So this is his pictures, and he's denying any history of loss of consciousness. This is her X-ray. So what's the most important here? The complication for this trauma that you see in the X-ray. Is it hypertension? Is it bradycardia? Is it hypothermia? Or narrow pulse pressure? Okay. Some issues here. For a second. Okay, so the answer is bradycardia. So this is what you call Hickson injury, because the patient already have anterior spinal cord injury. So you'll expect some complication like bradycardia with this patient. And you also mentioned about Hickson injury.
This is prediction for this one, and this is patient we present with a teardrop for this one. Can for this patient can present with like this one. Can present with this teardrop for this one. Will make compression for this, and will be present patient usually wide pulse, not narrow pulse, and patient usually bradycardia and hypotension.
Okay, is it clear? Any question for this? Bismillah. Next one. Can you see still no as number one? Okay, where is Hussein? Bismillah. Next question.
The 14 years old girl fell with snowboarding and is landed a prone position. And while attempting the new aerial jump, and she is continue to practice, she start to be feeling weak and dizzy and lightheaded, and she's heart rate is 75 and respiratory rate is 18, blood pressure is 110 over 60, saturation 98, room air. Physical examination, she is anxious, clear breath sound, normal heart sound, but is a regular heart rate. What do you think this one from the ECG? Obtain chest CT scan for this patient, good approach. Prepare for rapid sequence intubation, obtain echocardiogram, obtain muscle enzyme for the cardiac muscle. Okay. So the right one is just obtain echogram. Why this one? Because it can be secondary to contusion for the heart. So like this contusion can make rupture for the muscle, rupture for the valve, rupture for ventricle or atrium. So like this patient sometimes can present with arrhythmia. So it's better to go for echogram for this patient, especially for like this case scenario.
That we doing routinely cardiac enzyme patient who present with chest trauma or having cardiac manifestation like this. Is it going to be helpful in our decisions? Or?
You cannot rule out the muscle contusion or cardiac contusion by the muscle enzyme. It can be helped, but cannot be rule out the muscle contusion.
Is it cardiac enzyme going to be helpful also here, like CPK-NP?
Yeah, sometimes if troponin is high and also the muscle for patient abnormal ECG can be help to approaching the diagnosis, but it's not routinely for this one. You have to go for echo
so
as a standard.
Not do it routinely the cardiac enzymes because most of the time it will be high, false positive, and will lead to something clinical scenario other than what the patient is. So this is a 16-year-old female arrived to the emergency after motor vehicle collisions. She was unrestrained front seat passengers in the vehicles that was pulled by the stock and rolled over the once. She arrived to the ED, restraining of the seat collar. She wakes screaming from severe pain and ensuring the airway and breathing, and she had right side weakness. His strength normal on the left side, and she's complaining of the numbness on the left side. Based on this finding, what's the following diagnosis? Is it Brown square syndromes, central cord syndromes, anterior cord syndromes, or posterior cord syndrome? Okay, so 9, yes, it's Brown square syndromes. And actually, if you, oh, sorry, we don't have the pictures here because we need to talk about what's the difference between anterior cord syndromes and Brown square syndromes. And usually they will have the functioning in the ipsilateral side of the functionings, the motors, and but the other side, you will lose the pain sensations. The pain and sensation on the other side. So at the same side, yes. So you will lose at the same side of the trauma. You will have the side of functioning, weakness, numbness, and sometimes the temperature is feeling. But the other side, you will have losing of the pain sensations, maybe.
Central will be bilateral.
Yes.
So bilateral, so we're not going with this scenario. Anterior cord, for what?
As we mentioned before.
Corticospinal. Back for this one will be lost what? Motor and a pain. But the vibration and this one would be not lost, bilateral. Posterior, the motor is intact.
So let us see the result. MashaAllah, Nova is still number one. And we have two competitors, Yazid and Yunus is coming up. Okay, next one.
15 years old girl, this is struck by the fast moving car while she was walking. She's walking in the road, the emergency. The AMT placed the 2 IV access for this one, giving 20 ml and normal saline bolus with the profiling back for this one. But when he arrived to the GCS, it's around 3, heart rate 150, and respiratory rate is 20, and blood pressure 50/20, oxygen 85, oxygen with the 100. Physical examination, the physician is intubated that patient, and the exam after this intubation still trachea is intact, and in the midline she has diminished breath sound in one side, and there is obfuscation in the right side. What's the good approach for this patient? Advance it tube 1 centimeter more, perform brachydescentesis, perform thoracotomy, or perform the thoracostomy. Okay.
So that because this programming is fast, so we will compare the right and left side X-ray this after.
Okay, if there is obfuscation and there is obliteration of the right side, is going with there is something, make pressure for this one. What type of shock this one? This patient with obstructive shock with this one, and patient present with that massive hemothorax, and you have to tap for this patient to release the pressure and to improve the blood pressure and vital signs for this patient.
So next question. 16-year-old boy brought to the emergency because of persisting pain at the right wrist after falling yesterday. So almost like 24 hours. He had these pictures. Worse pain with under deviation of the wrist, to the left side, increased pain with axial compressions when he put his hand on the floor. Positive hook of hematopol test. Decreased sensation over the tenier ominous. What do you think? He was actually playing football or playing crypt. Okay. Two, one. Okay. So the answer is increasing the pain with axial compression of the thumb. 7, the answer is right. So what purpose?
The maximum damage where? The maximum damage in the scaphoid, this one, and will be pressure, and will be deviation to radial side, and is not an ulnar side. When you make pressure, axial pressure on the thumb, increase the severity of the pain. So the test can be rolled out if there is fracture in the skull.
So most of the time, you will not find fracture actually in the X-ray, especially in the first 24 hours, but there is a tenderness, a limitation of the movements. But maybe after 2 weeks, you will have some evidence because it's starting feeling around the scaphoids. So you will have some evidence after that. So it's mainly scaphoid fracture. Most of the time, there is no radiological manifestations. but only by the clinical. Bismillah. Okay. So Nofa and Jurayt, Toto Yazid and Yunus. Okay, next. Bismillah.
Mother bring this her 4-year boy with ear swelling. This patient present after playing outside in the backyard, and he's smiling, he's chatty, and he's alert, and he looks normal, vitally stable. And just present with this is presentation. What do you think is hypersensitivity for this one? Type 1 and type 4, or type 2 and type 3, and or type 2 and type 3 or 4, or cellulitis for this patient. By the way, this patient present with the insect bite yesterday. Yeah, the most of that's answer correct question. This one presented with the type 1 and type 4. Usually type 1 is present early at the time of the insect bite, and type 4 for this patient usually present late after 1 day or 3 or 4 days for this patient. Present just itching and redness in the same side as the late presentation. What about type 2? It is this is reaction between antigen and antibodies, so he's not going with this one. For this one, complement type 3. So type 1, type 4 is the correct answer for this presentation case scenario.
How long this type 4 can be present?
After 3 or 4 days for this patient.
You think this may be worse than type 1? Maybe
Will be same, like itchy and redness only. So don't worry about this one. You can send the patient on the antihistamine and reassure the parent.
So next question. So the ideal way to manage this splint is, what is this? Is this clear, the pictures? So there's something here. So how can we manage this one? Is it by digital block? I remove the whole nail, or digital block and wedge resection of the nail, or don't remove the splint, keep it there, and it will grow out by itself, or shave the nail down, يعني تقعد يعني shave it up حتى until you expose the these things, the splinters are exposed. Which one? Don't remove the splint until it grow out. No, it's painful, by the way. If you keep it long time, it will be painful. So we need to remove it. So why we choose this method?
Yeah, it's good for this one. If there is a splinter under the heel there, you have to just shaping this area to be exposed that foreign body and remove it. No need to remove the nerve.
So it will take a long time and it's painful and maybe source of infection. So you need to relieve the pain. Most of the time they will hit because this will cause pressure under the nail. So you need to remove it. How can we do that? Just do a splint and then we'll dress it.
At 26 days old, infant girl. He had worsening in the swelling of the left breast with several days. This patient present with this swelling, and he had mild milky white discharge, the right breast. Now he's appeared normal, and several days ago she developed fever and he became redness and swelling in the same side of the left one. What you have to do for this patient? You'll give IV antibiotic and admit the patient, or you have to begin the antibiotic as outpatient, out incise this patient and drain this swelling area. I would just reassure the mother and send home.
So IV antibiotic or oral antibiotic or reassure or just open it up.
So the right answer is 10 of this one correct, and you have to admit the patient and you have to admit the patient and to start the patient IV antibiotic. Like this myositis, this one you have to be manage patient seriously and have to start an IV antibiotic and to start the patient to be discussed with the surgeon if there is any collection for if you need to go for drain this one as inpatient, not as outpatient.
One answer here, because there is some few candidates they choose to send the patient when oral antibiotics, and he is less than 1 month.
Yeah. No, this patient can be going with the serious bacterial infection and sepsis, so it's not a good option to send the patient like this age with the oral antibiotics.
So we would like to prohibit using oral antibiotics even less than 3 months.
Yes, and you have to be admitted and to start an IV antibiotic.
What's the diagnosis here for blood film? This first blood film, you are on the periphery, and you did a peripheral film, and lab technician sent it to you. What is these pictures? Is it because iron deficiency anemia, B12 deficiency, sickle cell, there is any sickle here, or Wiskott-Aldrich syndrome? Wiskott-Aldrich syndrome, which one? So once you do the blood film, please, doctor, help me. What is this? Is it iron deficiency anemia, or B12, or sickler, or Wiskott-Aldrich syndromes? I'm sure all of you will answer the correct answer here. So no need for any explanation. Yes. Okay. Some of you answer iron deficiency anemia. No, when you look to the shape of the red blood cells, it looks normal, normocytic colors, looks normal shape. And this is hypersegment neutrophils, which is correlate with B12 deficiency. Dr. Hamid, any sickler here? Can we see any sickler? Because some answer of sickle cell.
For this patient. And also for this patient, usually neutrophil will be segmented around 5 to 6 segments in the megaloblastic anemia and the iron deficiency, B12 deficiency. A 4-year-old girl came to the emergency with history of nasal trauma. What would we do for this patient? Unilateral incision to be made to drain this hematoma, or discharge the patient with the otolaryngous evaluation after 12 to 36 hours, or nasal X-ray for this patient, or have to consult ENT immediately and for immediate intervention for this patient. correct answer. You have to be immediate intervention. Consult the ENT or otolaryngologist for this base case scenario. And also, when you see this patient is bilateral, so he cannot make one incision on one side and keep the other one. You have to be make bilateral and gently and done by the ENT, not by the ER, the physician, and to drain the pressure on the cartilage. Otherwise, will be make perforation and will make damage for the cartilage. So we have to release the pressure from both sides, bilateral for this one.
Can I give an appointment to the ENT after 1 week? The patient is stable and no pain.
No, we cannot this one. Otherwise, we'll lose the cartilage. So you have to immediate intervention for this patient to release the pressure. So it's not wise approach for this patient to keep the patient without any intervention.
Okay, next. This 13-year-old boy player with the right foot trauma present to the emergency because of refused to bear weight on the right foot. The Jones fractures, live fractures, extra or Smith fracture.
So some answered Smith and some answered that's Lisfranc. What's the Lisfranc fracture? Usually in the midfoot. It is the correct answer. And when you see this picture, there is a fracture in the midfoot, this one, and this placed one. And this is usually between the tarsal and metatarsal fracture. This, this is Jones fracture, usually in the fifth metatarsal bone. The fracture in the fifth metatarsal bone, usually with the inversion of the foot, will be make a clear fracture in the fifth metatarsal. What about Smith in the upper limb? Usually, which is not common in the pediatric. Is the opposite of the close fracture is the Smith. This displace of the distal part of the forearm anterior. What about extraclavian fracture? Usually in the fifth little finger. Okay. So the correct answer is Frank.
Okay. The most appropriate diagnosis for this patient is, so what do you think this patient had? It's having conjunctivitis, having corneal ulcers, having glaucoma, or lens dislocation. This is actually the patient seen in emergency 2 weeks and been having the rapid assist by general practice because of some trauma in the eye. This was actually penetrated eye trauma. Then after that, just give him lubricant, refresh tears, and send them home. So what's the answer here? Okay, so most of you said glaucoma. Why glaucoma? Actually, when you look to these pictures, actually the lens looks fine. It looks clear, the lens. But the problem is here when we send it to the ophthalmologist, it was clear there is a glaucoma there because having history of penetrating trauma 2 weeks back, and unfortunately didn't take care about it. And after that, these complications happened because of the penetration eye trauma to the globals. Those are the most important things when patient present with penetrating global eye or eye trauma to measure the eye acuity, visual acuity, careful looks to the eye. If there is almost all global eye injury, even the patient is okay, is fine, need to be also evaluated quickly by the ophthalmologist. So this is glaucoma, traumatic glaucoma as well.
A 10 years old, previously healthy boy. This is incurred for this isolated curved linear laceration over his left eyebrow. What you have for this patient to do? What type of the suture? You have to make fast absorbed gut percutaneous suture, and then you can do the strip, or you can use the size 4 gut buried dermal suture, then can go for fast gut percutaneous and suture interrupted. Or can use the 5-0 ficral and then go percutaneous ficral mattress suture. Or the last one, 5 ficral buried dermal suture followed by 6 nylon percutaneous suture. What's a good option for you for like this scenario? Will not make bad scar for this patient. Or ugly scar for this patient. Some answer 5, you have to use the ficral. Why not select this is 5-0 ficral with the percutaneous ficral vertical mattress suture? Vertical mattress suture is usually not used in the face. Okay, and also we are far away from the gut percutaneous, so it's not good option for us. Other, we can use ficral buried, then you can go for also absorbable ficral. Sometimes can be helpful, but it's better to be nylon to be good for approximated the edge of that side of the laceration.
Why not use the
glue?
The gut pipes or glue?
No, the gut sometimes can happen. The complication happen with this one is more than that's a ficral. So this one
can you use one layer only, like using this size, like 3 becquerel?
For like this scenario, it's better to be used this one 2 layer to be approximated to be after that later on it will be good cosmetic picture for this patient.
Most of the mattresses are used for thick skins and just not for the cosmetic. Okay. So this 14-year-old boy present after episode of the syncable in the school in the morning. He eat the breakfast and otherwise he feel ill. So what is this? Is it myocarditis? Is it prolonged QT syndromes? Is it MI? Could be. So T-wave change. Is it Burkitt syndromes? Burkitt syndromes, okay?
Yeah, Burkitt syndrome, usually what happened for if you want to go for ECG for the Burkitt syndrome, usually the chest lead will be P1 and P2 and P3 will be elevation for this one, ST elevation. You can see the ST elevation and you can right bundle branch block for this one. But when you see this is P1 and P2 and PST elevation, we can think about Brugada. Usually without any stress, Brugada can be, suddenly patient will be passed out for this one and no one figure what's the cause of this death for this patient. So it's very important to think about Brugada disease for this patient, Brugada for this patient syndrome, if the patient presents suddenly loss of the consciousness.
Many people can think about once they have some ST change, they think about the mind. It is completely different approach from that syndrome here.
This 18-month-old girl presented with the severe diaper rash, and her sister has same illness with the skin abscess with eosinophil count, high eosinophil count. What do you think this following consistent with this condition? Has decreased IG level, recurrent eczema, skin abscess, and eosinophilia as a part of the disease. Staphylococcus aureus, this one, and herpes simplex and herpes zoster is rarely just impacted, and the pneumococcal as rarely followed by lung infection. Okay, so this will be recurrent eczema and skin abscess. Why not select decrease? Usually increase for this one. Hyper IgE syndrome for this one, it will be increase the IgE and increase the eosinophil. What about the staph aureus? Is common, can present with this patient. What about pneumococcal for this patient? Usually can be present with a skin infection or chest infection, recurrent chest infection, present with pneumococcal. This is common to present with this patient with the hyper IgE syndrome.
But they're exposed mainly to the staph aureus. Pneumonia, pneumococcal. This is the last questions. Number 3, Yazid. Number 2, great. Number 1, there is no problem. No.
Right. Can you send Nofa send that email and a correct name to receive the certificate for this one.
Nofa, she answered 15 out of 20. Right, he answered 12. Yazid, 11. And we have, I think, 2% they answer, but they couldn't they answer all the questions. They answer only like it's like 12, but they write with like 90%. Okay, thank you very much. Any questions for this panel? Thank you so much.
It's our fellow. No. Yeah.
سلميها في نص كده سلميها في نص كده
So he's the winner of this Nof Jahtari. This is Pediatric Emergency Fellow F2.
No. Okay. Congratulations.
Thank you. Any questions?
جزاكم الله خير. Another sessions will be started here, like after 10 minutes.
you know, sort of involved with, not directly, thankfully. 9-year-old boy who was playing soccer. He was running down the field and seemed to bump into another player and fell down to his right. He had a brief generalized tonic-clonic seizure and then became post-ictal. Brought to ED. Slowly he got more alert, but it was noticed that he was moving his right arm less than usual. So you can see, you know, what are the differential diagnoses? It could have been traumatic brain injury with a impact seizure. As he fell, he had a seizure. So whether the seizure preceded the fall or did it happen outside, you know, who knows? It happened when nobody was carefully watching him. Could it have been Todd's paralysis? You know, he fell down and so he had a seizure. Maybe it was right upper limb involving seizure and so he has a weakness. Or could it be a stroke? And then his head CT was normal. So what is the significance of that? So if you look at the incidence, you know, the highest incidence of stroke is in the neonatal period, and especially in premature infants, where the incidence can be as high as 100 over 100,000. It reduces to 25 to 40 over that, and in older children, it is much more. But as our example case implied, you know, even a 10-year-old previously well, completely well, can potentially have a stroke. There's a mild male predominance, and this is a really important statement here. You know, its incidence is similar to that of brain tumors in children. And we always talk about brain tumors, right? We worry about how to diagnose them, how to treat them. We've seen cases, but we don't talk as much about pediatric stroke. So similar to adults, stroke in children also can be ischemic or hemorrhagic. And ischemic stroke can be arterial ischemic stroke, again, because of, you know, limitation of circulation by a developing clot or through an embolus, or it could be a venous sinus thrombosis, or it could be a hemorrhagic stroke where 50% would have vascular anomalies, and we'll talk about what kind of anomalies later on, or older children with sickle cell disease as well are prone to hemorrhagic stroke. So what are the possible underlying conditions? This, you know, slide gives you some of the examples. They can be arteriopathies, heart disease, and we're going to talk about many of it more. But as compare it to the adults, where we know what are the predisposing conditions for stroke: hypertension, smoking, diabetes, hyperlipidemia. Fortunately, none of those are present here, but in children, but they have other predisposing factors. Luckily, not as common as those in adults, but still they are there and they can predispose to stroke sometimes. So at the time of diagnosis of stroke, about 45% of children with stroke will have a known predisposing condition. But the remaining, so more than 50% will not have a known predisposing condition. They'll come, you know, just previously well child, but once you do the workup, you might be able to find a significant condition in the majority of them. For arterial ischemic stroke, as you see, only 10% remain cryptogenic. So in the vast majority, you'll find some risk factors. In hemorrhagic stroke, again, 90% will have at least one risk factor. So further investigation is very important to try to find the, if not the etiology, the risk factors predisposing to the stroke. So the most important, if one thing we need to take away from this lecture is recognition and high index of suspicion. Delay in diagnosis is common in this condition, as one might realize. So what are the clinical manifestations of stroke? The hallmark of stroke is sudden onset focal deficit. And what can that deficit be? It could be a deficit, you know, facial nerve palsy, some vision defect, weakness of upper extremity function, weakness of lower extremity function. They could be combined. There might be some voice defects, slurring of the speech. So any kind of sudden onset focal neurologic deficit, always think about the possibility of stroke. The other possible manifestations: altered mental status, Sudden onset severe headache. Everybody has heard about, hemorrhagic stroke can present with a sudden severe headache. Seizure sometimes can be a manifestation of stroke. Posterior circulation stroke is a little bit different in that, it may not present with a focal neurologic deficit. It may present with altered mental status, dizziness, vomiting, ataxia, and some eye findings. So anytime a patient presents with headache along with dizziness as a significant complaint, remember, think about the possibility of posterior circulation stroke. Do a good examination, make sure you don't have any positive findings. So we all know, in terms of our adult stroke, it could involve anterior cerebral artery, middle cerebral artery, posterior cerebral artery, and then there is the vertebral system. So the similar thing in children, if there is anterior cerebral artery, there will be mainly weakness of the contralateral leg. With middle cerebral artery, mainly contralateral arm. You can have contralateral leg as well, contralateral face as well. Depending on the left or the right side, you might have aphasia, dysarthria, or sensory defects. With posterior cerebral artery, that is the occipital cortex, so you might have visual field involvement mainly. And with the vertebrobasilar system, like we mentioned earlier, headache, ataxia, altered mental status, eye changes. Just to go over the associated conditions, because if already, we've been talking about that pretest probability, right? So if you have any of these conditions, your pretest probability of stroke goes up a little bit. So if a patient presents with those manifestations, then you will be a little bit more concerned. And what are these conditions for arterial ischemic stroke? Sickle cell disease. Remember, we'll talk about sickle cell disease for hemorrhagic stroke as well. So sickle cell disease predisposes both to ischemic stroke as well as to hemorrhagic stroke. And then other arteriopathies, Moya disease, I'm sure you've heard about it or read about it in textbooks. If you work at CHOP, you get to see those patients as well sometimes. Post-radiation therapy. So somebody who's had various kinds of brain tumors, they've had radiotherapy related to that, and that can predispose them to some arteriopathies. Children with Down syndrome can be prone to them. Various collagen vascular disorders, lupus, polyarthritis nodosa, those kinds of conditions. Prothrombotic conditions, we'll talk about them more a little bit. Cardiac disorders, so wherever there is a right to left shunt, and if it is not being corrected, then potentially a embolus can go from the right side into the left side and up the internal carotid artery into the brain. Trauma can cause dissection. Metabolic disorders, infection, vasospasm, severe meningitis, whether bacterial meningitis, tuberculous meningitis, or any of those things can ultimately be associated with thromboembolic events. And then prothrombotic disorders, like I mentioned, various things like protein C deficiency, protein S deficiency. I'll not go into detail. We've all sort of heard about them. How about for hemorrhagic stroke? So the conditions associated with that are the most common are the vascular anomalies, AV malformation. The point is, unless you do imaging, and it has to be like MRI, MRA, you're not going to know about it unless it bleeds. So the first bleed, luckily, in many cases, the first bleed does not cause the full-fledged stroke. It may cause some, what we call sentinel event. So you might have some symptoms, you might have some headache, you might have limited weakness, which may be transient. But if the patient gets a full workup, you're able to identify the AVM and treat it before it actually ruptures, then you might be able to prevent the stroke. With AVM, often there might be a recurrence of the event as well if it is not identified. So especially in children with a hemorrhagic stroke or a full workup is essential so that you can find the underlying cause, because you can prevent recurrence, you can prevent further damage. Various kinds of coagulation disorders. Right, so just like, for other conditions at CHOP, this is one of our relatively newer pathways, but still it has been there for the last 5 to 10 years, approach to diagnosis and treatment of stroke. Most of what I'm saying is derived from the information related to this pathway, so feel free to refer to it. You don't need to take a picture, just Google on, CHOP pathway for stroke and you'll get it. So what are the screening questions? Just as we mentioned, related to the exam findings, you want to know if there is any neurologic deficit. You want to know if the altered mental status, and the key thing is that it's a sudden onset event, right? So you want to know, did the problem begin or get worse suddenly? Has it gradually been, problem has been worsening over days or weeks, then it's probably not a stroke. It might be a brain tumor, it might be some other neurologic condition, but it's probably not stroke. But if it happens suddenly, then you're extremely worried. We're familiar with some of these sort of adult screening tools. There's a face, arm, speech test, as the name implies, face for facial drooping, A for arm weakness. You know how we tell them to keep it supine, and is there a pronator drift? Does the arm falls down? Speech difficulty. So similar tests can be used in children as well. And as you see, they have a sensitivity of about 75 to 80%. So reasonably good sensitivity. And we can certainly, if we encounter a patient, again, clinical decision rules have the advantage that if you're faced with a patient, you don't have to think as if it's a completely new problem and you're reinventing the wheel. Because if you do that mode of thinking, then there is more chance that we're going to miss some things. But if we already know some rule and apply that, then it becomes much easier. So, there's less cognitive load. So I would encourage everybody, if there is a load, even if it doesn't have a very high sensitivity, it is a useful practice to use those rules. So we've already covered that. So the other condition that we haven't talked about too much is the venous sinus thrombosis. So especially in younger infants and younger children, sometimes they can develop venous sinus thrombosis. And what happens with that, it may or may not be associated with conditions like gastroenteritis or other, even mild URI, viral infections, which lead to dehydration, reduced activity. And so the assumption is that the blood becomes more viscous and you might have a venous sinus thrombosis there. And what are the descriptions? So if it's a febrile child, you give them paracetamol or ibuprofen, the fever goes down, you've hydrated the child with an IV and still he remains lethargic. He's not wanting to be, wake up, give you a big smile. Then think about the possibility that maybe something is happening in the brain. So lethargy, persistent vomiting. So you have evidence of raised intracranial pressure. So basically symptoms and signs of that. So if he's old enough, he might complain of headache, otherwise lethargy, irritability, vomiting. We talked about hemorrhagic stroke, worst headache of my life. Suddenly the patient collapsed and then can't awaken, paralyzed on one side. So this is the history and physical. You want a detailed history with review of systems with past medical history to find out if there could be any underlying disorders. So there is a pediatric NIH stroke scale that has been developed, but it's not been very well studied by other investigators yet, so we're not going to go into detail. So initial approach to a child, high index of suspicion, recognition that this could be a stroke in this child or at adolescence. You want to do your ABCDs, make sure those things are okay. D for disability, remember, how is his mental status? And then if you remain suspicious about the possibility of stroke, it is very important to institute immediate neuroprotective treatment. Because what you're trying to do is, there is a obstruction, let's say to the anterior cerebral artery, and the distribution, anterior cerebral artery supplies, this part of the brain, then the areas at the periphery, if you do good neuroprotective treatment, then you can protect those areas at the margins of the circulation, right? But if the infant becomes hypoglycemic, he has a high fever, you're not caring for him very well, then that area can extend and the deficit can increase. You want to do neuroimaging, and we'll talk about what. If do you have a stroke response team? Because this is just as a myocardial infarction is an emergency, you want quick treatment. Stroke is a medical emergency. It's a brain emergency. Your brain is dying. So you want an immediate response team. Lytic or mechanical therapy, disposition. So like I said, in neuroprotective therapy, you want to protect the brain tissue, especially at the border. So that's the penumbra is the fancy name for that. You want to maximize cerebral perfusion, so bed rest. If suppose it's you're worried about ischemic stroke, then you want to keep the patient, flat. But if you're worried about hemorrhagic stroke or venous sinus thrombosis, where you're worried about raised ICP, then at 30-degree angle, so that hopefully the pressure will go down a little bit. You want to keep the blood pressure normal to higher limits of normal, so that there is good cerebral perfusion pressure. If there is any concern for hypovolemia, like if the patient has been having gastroenteritis, he's dehydrated, you want to correct that. Anemia, hypoxemia, you want the saturations to be more than 95%. If room air is not enough for that, then give him supplemental oxygen. Minimize metabolic demand. So if the patient has a fever, you want to bring it down. If the patient is having seizures, controlling the seizures is very important. And we know hyponatremia can sometimes cause altered mental status. Severe hyponatremia can cause seizures. Hypernatremia can also affect the brain. So it's very important to check sodium level, and if abnormal, then to try and correct it. What other things can we do to protect the brain? Keep him on the cardiorespiratory monitor, hourly, frequent vital signs. What fluids to use? So if the patient is well hydrated, well perfused, then you would just start normal saline at maintenance. If the patient is poorly perfused, then feel free to provide boluses till the patient gets into a state of normovolemia, and then continue normal saline bolus, normal saline infusion. So how about dextrose for maintenance? Should we use normal saline, or should we use, D5 normal saline? So this is sort of important. Studies have found that dextrose is not good for dying tissue. Somehow, if you go into the pathophysiology, et cetera, of dying tissue, whether it's in the brain or in the heart, if there is a lot of dextrose coming there, that can cause more apoptosis, more destruction, more problems. So as long as your blood sugar is on the normal level, you want to avoid dextrose-containing fluids in this situation. So just give normal saline infusion. But to make sure that the patient doesn't go into hypoglycemia, you can keep checking blood sugars, let's say hourly or something. And if it's dropping, then of course you will add it. And this is true for anybody more than 6 months. In young infants, they are more prone to get into hypoglycemia. Their glycogen reserves, et cetera, in the liver are not so good. So there, D5 is allowed. Supplemental oxygen, frequent checks, blood sugar, we talked about normothermia. So what are the initial lab investigations? The initial point of care blood sugar, whatever seems reasonable. CBC, you want to make sure the patient is not anemic. PT-PTT, in case there is a clotting disorder. Remember, hemorrhagic stroke can be predisposed to by these conditions. You want to check electrolytes, looking at the sodium, especially BUN, creatinine, glucose, calcium, ECG, just in case there is any cardiac disease. We mentioned right to left shunt predisposes to embolic stroke. In a girl who's crossed the menarchal age, who's having periods, you want to always check pregnancy test. And then further investigations, we don't need to do right away, but something to think about as we work up the patient. And then if you are worried about it, always alert the stroke team. If you don't have a stroke team, alert your neurologist so that they are aware and they can come and evaluate the patient. It might seem, it's somewhat like appendicitis. If you think about all all of us have seen appendicitis. I think 90 to 95% of patients of appendicitis are fairly clear-cut. You can diagnose them during your sleep even. But there is that, small category of patients of appendicitis where you can be fooled. And I'm sure all of us have seen those cases as well, where no, it doesn't look like appendicitis and da. But then if you do the workup for whatever reason, they turn out to have appendicitis, right? Like Manish presented this child of 9 months old who turned out to have appendicitis. And the same thing can happen in stroke, and I saw a patient myself. This was a patient with sickle cell disease, so we knew he was at high risk. This was like a 16, 17-year-old patient who was referred from a community hospital for the possibility of stroke, all right? So there wasn't even very high pretest probability. And still when the patient came to our ED, so I work at CHOP, which is the tertiary center. The neurology team were involved. Their neurology fellow was there to greet the patient pretty much. And over the next couple hours with multiple examinations, the patient's examination was so sort of waxing and waning. In between, he was able to get up, walk around the room. He was talking. He wanted the telephone from his mother so he can, chat with his friends. And in between, he would become a little bit confused. And we were just wondering what's going on. Ultimately, the neurologist decided we'll just admit him to neurology floor. It doesn't need an emergent MRI. This was getting into 10, 11 p.m. And then, we were still, from the ED side, we were a little bit worried. No, that doesn't seem like the case. We should do an MRI. But, at that time, the MRI tech had to be called in from home. And he had already had a CT, I think, which was normal from the referring hospital. And as he was going to the floor, the nurse said they were putting him in the wheelchair, that the nurse told me that he just peed on himself. So this was a 16-year-old boy who was supposed to be awake, and he peed on himself. That made us again concerned. No. We don't like this. That means his mental status is not normal if he did that. And he had an immediate MRI, and that showed a full middle cerebral artery stroke. So remember, even though anatomically he should have had complete weakness of half of the body, sometimes it just doesn't happen. So if you have, all of these symptom signs, they have limited sensitivity. None of them have the 100% sensitivity. So if you have some symptoms and signs, you're concerned about a really dangerous condition, go ahead and do the next test as well. So the advantage of CT is that it is quick. You can get it right away. It only takes a minute of exposure time. But remember that it'll exclude hemorrhage. If it's a hemorrhagic stroke, you will see it on the CT. But if it is an ischemic stroke, as those of you who practice with adults know, that actually if you have clinical features of a stroke and the CT is normal, that tells you that it is an ischemic stroke. Those of us who practice only with children sometimes forget this. And we might assume that if the CT is normal, that he's fine, which is not the case, right? In the first 3 to 4 hours after the stroke happens, in ischemic stroke, actually the CT may be normal because it takes that much of time for the tissues to develop the changes related to ischemia, etc. So don't be fooled by a normal CT in the first few hours after presentation. MRI, if you can get it, is naturally the preferred modality because it can show you the lesions in a much more sensitive manner. And even immediately after development of the ischemic stroke, you can see changes related to ischemic area. And then along with MRI, you can do MRA, which is magnetic resonance angiography. So you can see the arterial blood vessels as well, see if there is any obstruction. If you're worried about venous sinus thrombosis or any venous obstruction, you can do MRV. That will show you all the veins. So naturally it is advantageous. If you don't have that access to that, you can also do CT angio, which is next best after MRA, MRV. So of course, for every 10 patients that you worry about stroke, maybe only one will turn out to be stroke, just because the pretest probability is so low. So what are the mimics? What are the other conditions that they will be most of the time? Complicated migraine tops the list. Especially when you have features that tingling of the arm, some weakness of the face. But by the time the patient comes to you, it's completely recovered. So then more often than not, it's going to be complicated migraine rather than some other underlying condition. Of course, it needs full evaluation, possible workup, but that's a pretty common condition. It could be seizure post-ictal state, like we talked about, Tal's palsy, traumatic brain injury, infection, demyelinating conditions like Guillain-Barré syndrome. It's usually bilateral, but maybe the findings may be more prominent on one side. And then there's this condition called ADEM, demyelinating encephalomyelitis. And then, there's these somatoform disorders are functional or, so those are also an important category to remember. You remember it has to be a diagnosis of exclusion, and you have to have definite stress factors and all of those other things. But even if there is history of stress, history of depression, don't think that that tells you that this is a functional disorder. You still have to exclude organic conditions because a patient can have depression and can also have stroke. But important to keep in mind. And then treatment should be guided by stroke team, because as emergency medicine physicians or pediatricians, I'm sure you will agree that none of us has enough experience with managing this condition. So we would, if you're suspecting ischemic stroke, aspirin, systemic anticoagulation. So these are all possible treatments, which you will review with your neurologist. Heparin, anticonvulsants, if the patient is having a seizure. If it's a sickle cell patient, then you will consider exchange transfusion. And then thrombolysis, TPA. Those of you, again, who practice with adults know TPA is advocated if you identify stroke within the first 4 to 6 hours. In children, there is no very limited studies. So there was this study where they did a, investigational study to see how feasible it would be to do it. They identified 93 patients across 17 sites, and ultimately only 1 patient was enrolled and was eligible for treatment. So it is, still a relatively rare condition, and to diagnose it within 4 hours of onset so that you can institute the treatment, and then you randomize them into no treatment versus treatment, it's just extremely difficult. And then there are some contraindications to thrombolysis, similar to that in adults, that you have to refer to. Naturally, the main complication of thrombolysis is bleeding, because you're preventing thrombosis, whether it's in the brain, in the GI tract, or somewhere else, and some other complications. And then this is an emerging modality similar to adults, mechanical thrombectomy. So if you have a really big clot obstructing a major blood vessel, like, I don't know, I'm not a neurologist, so I don't know much about it, but large vessel, maybe in the internal carotid, probably not in the internal carotid, in the interior cerebral or middle cerebral, and you can reach it with your fancy devices, balloon, etc., then you can remove the thrombus. So our patient, as I implied, that 9-year-old soccer player, he was referred to, so at that time, he was first seen at a community hospital with that presentation. But since his mental status seemed to be, improve, waxing and waning, he was referred to the tertiary hospital, where also initially, it was not felt that he had a stroke, but again, about 12 hours later, he had an MRI that confirmed the stroke. So you can see how sometimes, just based on how you start thinking about the condition, when he was referred, it was framed as a Todd's palsy / TBI, / just related to a seizure disorder. That's how he was perceived, and that's how it, the momentum carried on for some time till people realized that no, he had a persistent weakness in his right upper extremity, and his mental status was not normal, and he had the MRI. I mean, I'm not sure if that would have altered outcome, but we talked about how, those neuroprotective strategies, at least it might have limited the weakness, et cetera. And you want to, do well by our patients and diagnose things if they are diagnosable at the earliest. So to summarize, remember, stroke is not, I mean, it is uncommon, but it's not extremely rare. Most of us will see patients of stroke in our careers, at least a few of them. There is often a delay in diagnosis, so a high index of suspicion is important. At presentation, the majority of the children would not have a known predisposing condition. So even in a previously well child, we need to be alert to the possibility of a stroke. A normal CT within the first 4 hours of onset of symptoms does not rule out an ischemic stroke. It rules out a hemorrhagic stroke, but not ischemic stroke. If you do it after 4 to 5 hours, then a normal CT would exclude it. If you want to be definitive about it in the earlier period, you have to do an MR. Neuroprotective therapy, pathophysiology is different than in adults. Diabetes, hypertension, those are not the main factors in children. Stroke team centers lead to, potentially improved outcomes. So consider, thinking about it, set up a pathway about it so that if you have a patient, you can deal with it on an expeditious basis. I want to take this opportunity to thank one of my colleagues, Dr. James Callahan from CHOP, for sharing his slides. All right, thank you.
Thank you so much, Dr. Mittal. Please welcome with me Dr. Mark Urbach. He's Associate Professor for Pediatric Emergency Medicine at Yale University, and he's going to talk about simulation training for emergency medicine.
Okay, I'll let them get the slides. Thank you so much for the kind introduction, Amani. Good morning, everyone, or good afternoon. Jesus, morning at home. I just texted my wife to say good. Good morning, so I'm confusing the times. This is actually my area of focus. So I'm very excited to be able to share a little bit about my perspectives on simulation training for pediatric emergency medicine. Happy to talk more. I know I've chatted with some of you about simulation-based research, but really sort of my thoughts are that there's a number of different applications for simulation, and one of those being simulation for training, the other using simulation to test and measure systems and conduct research. So this talk will be focused a bit more on simulation for training and simulation for medical education. So hopefully during this talk, we'll define some aspects of simulation and simulation-based training. We'll report 3 areas of focus within emergency care, particularly pediatric emergency care. We can apply simulation, and then describe some evidence-based practices. And if you enjoy this, you're welcome to join our workshop coming up, where we'll dive a little bit deeper into some of it. So excited to spend some time over simulation for the next hour and a half or so with these 2 groups. So one of the key things that I want to highlight is that simulation is a technique. Innovative and really neat to see a simulator and a mannequin that breathes, that blinks, that does many things that look like a robot. Many of those things actually do not enhance the education that we provide significantly. What does enhance that is actually this technique of simulation. So taking people through a experience, lived experience that you're guiding them through, and really being able to have that on demand. So in contrast to some of the clinical work where we don't know and it's unpredictable and we can't control that, we can control the content for our learners. It's immersive in nature. It replicates substantial aspects of the real world. It doesn't need to do that perfectly, but we can make an approximation of that. And really the beauty of this is the social aspect of learning, both the interaction during the simulation as well as the interaction during the debriefing. So simulation can look like a variety of different things. On the left of the slide here is simulation, some of our pediatric trauma and medical simulations. In the middle, some work that I've done using game-based learning to conduct screen-based simulations. And on the right side here are two examples of higher technology innovations. So one involving haptic simulation and virtual reality, the other involving more augmented reality, where you're actually seeing things progress and look at the mannequin that looks like a piece of plastic if you have the goggles off, but if you put the goggles on, even seeing chest movement, seeing a monitor and other resources. This concept of augmented reality is really a very exciting area for simulation, where I think we're going to be able to bring this to the masses, what I call democratized simulation, and not need a high cost piece of equipment in each center. So as I mentioned before, why simulate? I love to teach. I enjoy having bedside interactions with learners. I enjoy reflecting on my own experience as an adult learner and hopefully getting better over time. But unfortunately, those clinical experiences are few, unstructured, uncontrolled. Something like a stroke and having a diagnosis of a TODS paralysis, like we heard in the last case, might be a rare event. You might not have opportunities to reflect. You might have another patient come in after. Or you might have opportunities to reflect, but have some moral and ethical dilemmas that the harm that occurred to that patient might negatively impact you, and really don't want errors to happen on patients. In contrast, in simulation, there's many experiences, so I can really provide you almost a limitless number of experiences. Our simulation training has shifted now from a assessment standpoint and I'll talk about this more in the workshop, but more to what we call a mastery learning approach, where we actually have shifted from time-based training, where we say, I'm gonna have someone come to the session for an hour, but saying, I'm gonna have someone come to the session until they are proficient and hit a mastery standard. The experiences can be quite structured, quite controlled. The feedback can be quite frequent. There's a variety of different debriefing frameworks. Some reflect in real time, what we call reflection in action. Some are reflecting after. Some are actually even reflecting down the road with what we call a delayed debrief. And then really here, errors are, I call them a high five moment. If I go through a simulation with you and you've done perfectly, it's wasted both of our time. So hopefully we can have some errors happen, have some opportunities for improvement. One of the key elements of simulation that I think is really important with the change in the US, I'm not sure if you see the same here in Saudi, is with the changing clinical exposure of our trainees. So in the US, if we look at on the y-axis here is hours of practice, and on the x-axis is the trainee experience. So in the model when I trained, really when we were at a unlimited number of work hours and not having as many advanced practice providers or physician extenders, we were really getting to that 10,000 hours of experience in pediatric emergency medicine by the time we were done with residency, beginning fellowship. That changed and sort of progressed to happening at the end of fellowship. And now I would say for many of our US trainees, and perhaps those here in Saudi as well, that has progressed to really being something that doesn't occur until we are at the attending level. I think this gets at the fact that the uncontrolled nature of clinical experience makes it challenging. From a simulation-based training evidence standpoint, and I know I wasn't going to talk too much about simulation-based research here, but I think there's very compelling evidence and really a highlight. I've been doing simulation-based work for about 15 years now, but I think a highlight for our field was back in 2011 when we had our first major paper in JAMA. And this was a technology-enhanced simulation for health professionals, systematic review and meta-analysis. David Cook, who's the lead author of this, has published a series of medical education meta-analysis that are quite powerful. But this meta-analysis really looked at the breadth of simulation-based research and demonstrated that simulation led to large effects for provider outcomes. So if we look at the hierarchy of evidence, it did have people improving their knowledge, their skills, their behaviors, their clinical performance, but didn't show as substantive effect on patient outcomes. And over time, I think we've seen since 2011, more of this research that's demonstrated effects on patient outcomes, which I'll come back to later. I will say that the simulation-based research area now is at a point where we need to shift from if simulation works, that dichotomous yes/no, to why it works, how it works, whom it works for. So, in my trauma case, I talked about this this bicyclist that was struck and had a hyperacute injury requiring resuscitation for blunt abdominal and head injury. And really, how can simulation improve outcomes for this patient? So we have a patient that's going to have an outcome, and we can look at this across the Donabadian framework that we heard before about from my colleague, Dr. Shah, and really looking at the structure of care as we're going to focus today. We can also do work looking at processes of care by trying to redesign systems, but simulation for training is really in that structure of care. So getting a group of people together to function as a team, to train together, to work towards improvement. So what to simulate within this area, I think the strongest evidence relates to 3 elements. So probably the strongest simulation-based research has occurred through both the military, aviation, as well as now medicine. It's interesting, I have some colleagues in aviation simulation, and about 5 years ago, they mentioned that actually aviation, we always quote them, we always talk about them, say simulation was born and has its bearings in aviation, and we've actually surpassed them. They've actually now started to adapt some of our simulation-based techniques and theory within aviation. I still say that I've been to the Houston NASA Simulation Training Center, and I would say that they still have us quite beat, but they lock their trainees in the same center for over 30 days straight. If we could do that with our residents and trainees, we might have as good of an outcome with our simulation. So teamwork and communication, procedural skills, and clinical decision making. We spoke about the pit crew mentality. We saw at the beginning of this conference that group of individuals that were changing the tire while the car was moving, and repetitive practice, but also teamwork and communication are necessary to do that. So what is a team? Whether it's that team changing the tires, or your team in the ED, or your team on the football field, a group of 2 or more people working together with a common goal. And I think one of the things that I really like to highlight is the interdependency there. Many times people are conducting simulations and the focus is really on the team leader. And I think this interprofessional and sort of hierarchical approach to simulation involving interns, residents, fellows, attendings should go beyond just that leader and focus on the other members of the team and take opportunities to improve everyone's skill. So we've conducted a series of projects looking at the impact of simulation on trauma team training in our department. We've subsequently looked at, unfortunately, I sent a new version of these slides and they're not updated, but we subsequently looked at the impact of this on patient outcomes and have actually demonstrated improvements in processes of care. And then most recently, Erin Jensen, a mentee of mine, was able to demonstrate, looking at some ACS, American College of Surgeons trauma data, that centers that had more active simulation actually had improvements in survival rates. So from teamwork and communication, there are some constructs that we teach. If you have not seen the team steps curriculum or are not familiar with that, I would really implore you, even if you're not interested in simulation, to look at AHRQ team steps. This is a set of communication rubrics that's available for free through our Association for Healthcare Research and Quality, is really grounded in work by NASA as well as the aviation industry and some best practices that are quite commonplace in our departments. So things that prevent marital errors, like using closed loop communication, things like sharing your mental model or thinking aloud, and really setting a standard set of expectations for our team members. The effect of simulation, I think that I would say most stands out in terms of why simulation works from both a theoretical as well as an evidence framework, is really the application of adult learning theory and debriefing. So debriefing is a facilitated reflective discussion after an experience. It involves actually a bidirectional discussion with learners. So it's not that unidirectional feedback where I'm just going to tell you, you should improve this, you should improve that, but works towards improving concepts and actually having a dialogue and a discussion that is much better about embedding learning. And even looking at things like fMRI and other studies, this is grounded in a strong theory and evidence. So the Kolb's learning cycle is really a tried and true adult learning theory. This was developed by Kolb and adapted from really all of the psychologists that we learned about in undergrad, Dewey, Lewin, Piaget. This cycle really breaks down learning into the cyclic approach where you have an opportunity to have a concrete experience, be it a simulation or a real patient clinical experience. You have the opportunity to sit down, reflect, and discuss that experience and what we call deepen your understanding of what the events were, what went well, what could go better. Very importantly, then you need some time to conceptualize. So you need some time to reflect and think. I think one of the struggles that I have, I'm fortunate to be one of the editors for a major simulation journal. So two pet peeves I have with the articles that we receive is many are just saying we did a simulation, people liked it, which we're beyond that based on 2011 evidence now, so now over a decade old. The other piece that I think is really problematic is the one and done simulation, that this idea of we did one case and someone learned something after that, or even we did one case and it was innovative, I think is no longer the state of the art. We need to start looking at this over time and how that impacts people. So after that simulation and debriefing, and the deepening through abstract conceptualization and further learning, potentially reading more, having a repetitive experience. And because again, the repetitive experience is unpredictable in the clinical setting, as a fellow or even as an attendee or a medical student, you might see that bicycle struck today. You might not see that case again for ever. You might not see it for a year. You might not see it for a month. So the benefit of simulation is that it allows you to have that in a controlled setting and as well as a controlled cadence. And it also can be augmented and must be augmented by other curricular activities. So another key concept here is what we call curricular integration. Debriefing is a talk in and of itself. I'm going to have a talk in the next hour for an hour. I would say that many of us have worked in this for a year or 2 years doing some fellowships. We have Dr. Mani up here who's done that. But I really want to highlight a tool, and this is a tool that was created by a friend and colleague, Adam Chang, who's really the thought leader in debriefing nationally and internationally. And really there's 4 elements of debriefing. So this slide does not go into some of the full arc or what I would call the 3-act play of simulation. So we have a pre-briefing where you're setting the stage, having people understand what the expectations are, sort of laying out what that activity is going to be, whether it's a single case or a course, showing them that this is a safe place ideally, then moving on to the simulation and then the debriefing. So in the debriefing, that is also a Kolb's experience where you're allowing people to reflect, to describe the experience, to analyze that, and hopefully apply and summarize. And this is a really nice off-the-shelf. If you go to Pearl's debrieftolearn.com. This resource is available, but there's sample phrases. And what I want to highlight is this is actually available fully in Arabic. So a nice resource. There's a compendium. I know I said I wouldn't talk about it, but it is an area that I'm very passionate about, of simulation for research or system improvement. And I don't know if the systems-based simulation tool is translated into Arabic. So maybe it's an opportunity for someone to work on. Yeah. And then some of the pearls are translated into Arabic as well. My initial foray into simulation and pediatric simulation actually was quite different. So we heard a talk about airway before. So one of my initial interests, and we heard about lumbar puncture, was procedural simulation, so psychomotor skills. I still think this is an important modality for teaching those skills. And I think there's some different constructs from an educational standpoint that I would provide. But I would say that these constructs and these educational activities are probably more based on a longer body of evidence. I think people have been training since back. We went to see the fortress here and heard about military training, but since all the way back thousands of years ago, procedural simulation has been going on for a long, long time. But a procedural skill is a mental or motor activity required to execute a manual task. Many times this can be going on during a team-based simulation. Our work really tries to scaffold. So we layer the technical skills. When someone has those technical skills and has practiced, we would allow them to then perform those skills during an interprofessional simulation. So some independent learning followed by some group learning. Our group has tried to layer really thousands of years of evidence into a theoretical framework for skills-based training best practices. So this work by Taylor Sawyer, who's a neonatologist, and myself and a variety of others, really tried to put together this concept of psychomotor or procedural learning, coming from, again, even things like music, how people learn a procedural task. The first phase is the cognitive phase, and this is pre-learning. It's really critical to have someone show up to a suture workshop like you did yesterday. They've never seen a laceration before. They've never seen a Kelly. They've never seen a suture. That's not the appropriate place to start that journey. So hopefully some videos, pre-learnings, understanding what the steps are, what best practices are. And really the construct that we describe is the first phase is learn and see. So we know that see one, do one, teach one has moved on to see one, sim many, and then maybe teach some. But really here, moving on to observing that expert in the clinical space. And then after that occurs, and once someone is really understanding the procedure, then you move on and to this practice, prove, do, and then finally we'll get to maintain. So what we call the LSPPDM framework, which the Canadians did a really lovely podcast on this work. And the one problem they had with us was that we had a really not so great mnemonic. So if anyone has a way that you could have LSPPDM sound really nice, that will help our work and help to broaden this. But the psychomotor phase gets at what I was mentioning in terms of mastery learning and deliberate practice. If you have read or have heard of Malcolm Gladwell, he's famous for some of the 10,000 hours work. His work is really grounded in a large body of evidence by a giant of the field named Anders Ericsson. So Anders Ericsson and Malcolm have actually chatted about this, and the 10,000 hours was a way of sort of making this accessible to the lay public. And even Malcolm Gladwell would say 10,000 hours of crummy practice, you're still going to be a crummy violinist. And some people, 10,000 hours is not necessary. So that's a little bit different for everyone, was averaged over time. But I would say in medicine, just as in some of these other areas, this concept of simulation for learning, what we call formative simulation, where you're going through your practicing, you're getting coached, is vital. And I think we've understood that for a long time, but shifting to what we call a mastery learning model, where there's a minimum passing standard, is a real frame shift in medical education. So this is not saying you're an intern, you've now a second year, you can do this independently. It's saying you're an intern, well, maybe you can intubate as an intern if you can demonstrate mastery in intern year. Maybe you can't intubate as an attending if you haven't demonstrated mastery yet. There are some residencies, particularly within orthopedic surgery, that are trying to take this approach throughout residency and for promotion and layering this over things like entrustable professional activities. But the next phase would be summative assessment. So this is where you're proving that you can do something. So now that simulation is your test. And when you pass that test, then you're ready to go on and perform on a patient. But really before that, I would say that this is a little bit different for the different procedures. So for something like lumbar puncture, one of the classic examples that I give, and this was an area that I focused a lot of my early work on, is that with the appropriate supervisor, and a nurse said this to me once, she said, don't worry, that doctor, they don't really know what they're doing, but just tell them to hold the needle and I'll push the baby onto it. And that actually works, for that procedure. It's not going to work for intubation. So I think that, performance on patient can happen at different times. And I would slightly change this model to say that, it's a graduated level of what we call entrustment, and this whole field of entrustable professional activities is coming up. Now that I'm getting a little older and working less, one of the struggles that I have personally in reflecting is skill deterioration. So worrying about maintaining my skills and thinking through whether or not I am still proficient to do some of the things that my fellows are doing, particularly things like ultrasound. So remediation may be necessary and repetitive training is necessary. We know I'm lucky to serve with the American Heart Association on their education guidelines committee. And I think it's this balance. I know you're taking PALS and doing some of these life support courses here. It's not like AHA doesn't know that every 2 years is not the way to do this, but how do you come up with a model that allows people to train likely every 1 to 2 months is what's needed for some of these skills. And we're working on it. There are some distributed models in the US that are happening now. I don't know if anyone in the kingdom has moved towards any of these models, but there's carts that are on your unit that you sort of can train repetitively every 2 to 3 months and not need to go take a full day class. So, I know that American football is something that probably hasn't permeated as much over here, but I think my highlight for this last piece here that I want to just remind you of is that it's not about practice. It's not about how long you practice. It's about how well you practice. So deliberate practice should be hard. Frankly, it should be a little painful and stressful and uncomfortable. And just like practicing for a sport or going out for a run, if you are running at a very slow pace, you're probably not going to improve your times. If you're running at a nice pace and having a program for your schedule and training, that will help. So, moving to sort of where we want learners to end up, I just want to highlight that our goal within our department is not to get our trainees to expertise. And I think this is actually another challenge and struggle that I have within medicine, that really when we try to apply some of these procedural training adages, I don't want everyone to be a concert pianist or violinist. I want them to not frankly break the violin or have really bad notes or give me a headache, if I use the music analogy. So I want them to be competent. And I think within this paradigm, what I like to mention is that the most dangerous space for this individual to be, or these trainees to be, is in what I would call the unconscious incompetence, which we, my updated slides have this layered out, but this guided response is okay. If you know you don't know, you come grab me. I'm okay with that. But when you go in and you do something that perhaps you are unconsciously incompetent, you don't realize how much you don't know this procedure. Maybe you've seen someone else do this once, that's quite dangerous. So actually a frame shift that I aim for in our residents is move them to conscious competence in certain procedures like intubation, and then hopefully conscious incompetence, I'm sorry, and then hopefully get them consciously competent by the time they're a fellow, and really to become an expert where you're actually practicing what we call heuristics or taking some shortcuts or able to manage those difficult cases. You can't do that for everything as an attending. So I feel like I have some of those skills for ultrasound. For intubation. I do not have those skills for ultrasound. And I think you need to know what you know and what you don't know. Getting back to repetitive practice and trauma, this gets at some important skills-based training, as well as even overall education work that demonstrates that we not only need to think about learning curves, which are on the left side here, but actually forgetting curves, that we actually all have our own curves, and each procedure has this for how quickly and how often we forget things. So recognizing that if someone is only trained to competence, likely by the time that patient comes in again, they're going to actually be not competent or not proficient. So just having some repetition is not adequate in between, because if you train them back up in between, they're still going to fall below. So really what we want to do is overtrain or overlearn. I don't know if anyone has done any of the language duo apps. Some of these are very good at this, where it actually learns when you're forgetting the words of a new language that you're learning and starts to hit you more frequently with those words, and it's what we call adaptive learning. So where to conduct research simulation, and specifically resuscitation simulation. I don't know if you're doing any in situ simulation here, but I want to highlight that simulation for learning and simulation for improvement can be blended together by doing it in the workspace. It's something that I'm very passionate about. I think that a pillow or a doll in your workspace is actually probably better than my $150,000 simulator in the Sim Center. So I am a big proponent, particularly for our fellows, of doing this in situ. For my medical students that are very early on, doing it in the Sim Center, I think is reasonable. Lots of benefits of in situ. You get the real world teams, real equipment. You get really, I think, a much more robust experience. Getting back to the learner outcomes and looking at some of the evidence. So this is a summary of some of the evidence in trauma simulation. There's similar work that we've done in procedural training as well as resuscitation training. But climbing this pyramid, there's a variety of educational pyramids. But I would just encourage you to start considering, if you're looking at any simulation-based research or conducting these projects, moving from the bottom of this pyramid of this is a fun experience to procedural or process outcomes, getting back to that Donabadian framework. So things like intubation success rates, CT scan success rates, and then hopefully moving from that all the way up to what I call the holy grail of patient outcomes. So we have seen that in trauma, in cardiac arrest, we've seen that as well. There's a couple cardiac arrest studies that have showed demonstrated improvements in outcomes. Unfortunately, these are still at the association level. So if we mirror some of the research that we've heard about in the clinical setting, we have more of a need for randomized clinical trials. We haven't gotten there yet. So simulation to improve systems. I did want to highlight from my earlier talk, I talked about having tags up in our room with stickers. This is something that came out of our trauma simulation. So these system-based simulations allow you to identify issues, mitigate those issues, but also train people up. So our trauma simulations are the way that we get them to actually start using these stickers. This is the example of the PEARLS framework for systems improvement. So a slightly different way of debriefing. It not only includes, how did that go, but actually what factors within our system were barriers or facilitators, what safety threats are here, what can we do to make your work easy and make it more likely that the system will support you. So some take-home points here through this whirlwind talk is debriefing is by far the most impactful part of simulation-based learning. If done well, there's some great scripts out there. So while you can take a course, there's some off-the-shelf ways of doing this. I'm happy to share through COVID, and unfortunately these are the older slides, but through COVID, there's 3 or 4 different free open access medical education simulation-based resources that really have come out to fruition using things like like Google Slides and YouTube so that you can conduct simulation in a low or no cost way, and really with this goal of democratizing simulation. Mastery learning and evidence-based practices for procedural simulation are needed. And then again, I give you a little teaser here that simulation is evidence-based to improve care through training. If you want to talk further, I'm happy to talk about simulation as an evidence-based approach to improving systems. We've markedly demonstrated, whether you're building a new hospital or trying to improve your own environment, that simulation can be a very effective technique. We heard before about the VIPER study, and the VIPER study using video-based resuscitation actually came from a number of my colleagues that were recognizing the power of looking at video in simulated cases and then saying, wow, what if we could get the same video in real patient cases and use that to understand processes of care and where we want to improve. So thank you so much, and appreciate the opportunity to share with you, and happy to take some questions and share a little bit more on debriefing if anyone wants to join us for that after.
Thank you so much, Dr. Mark. I would like to invite the speaker to the podium for the question and answer. Sorry. Anyone have a question? Sure.
Thank you for the enlightening session. I have two questions. The first is about the stroke, and do we see more stroke now, or are we looking for more for them? The second question is about simulation training. How can we make it as safe as possible for learners and avoid judgment? Thank you again.
Thank you so much.
Thank you so much. For the stroke, I mean, I don't see any reason why it should be getting more common. I think it's always been there. It's just a question of recognition. You know, and this has happened in a number of conditions. If you look for it, only then are you going to find it. So I think just that. Yeah.
Yeah, so I think that you're asking a very timely question now. So there's a podcast called Simulcast, which is a big podcast within the simulation community. And I think that many of us have been trained in this concept of psychological safety. It's borrowed from the business world and military, and really that simulation is a safe place. And really this idea that's come up now is that there's a container that can open and close, and that you can have safety within that simulation, but letting people know that safety is something that's their own perspective. And I think that there's this frame shift from telling people this is a safe place. What happens in sim stays in sim. You will feel comfortable. You will not be stressed. You will not be threatened. We're moving a little bit to try to have a discussion about that in the pre-briefing. And I think that that's very much based on the relationship. So I'm very fortunate that I get to work with many of my learners at our institution over time many times, but I spend about half my educational work going out into community hospitals and working with community emergency departments. And I have one day to foster that relationship. And I think that I've changed that frame to say, this will be stressful. This might not feel safe at time. Are you okay with going on that journey with me? Because I think that for some people, they're not. And I think that, you know, it's not fair of us to force people into a situation that they're not comfortable with, or tell them that this will not be stressful and this will be safe. So then after that simulation, and this has occurred quite frequently in our community ED setting, if someone does have post-traumatic stress type symptoms or is really negatively impacted, helping them to understand where resources are available. And that's come up mostly actually with our pre-hospital simulations. a colleague of mine down in Texas was doing some work with death disclosure in the pre-hospital setting, and they actually had to stop the intervention and work to get a psychologist to be present with them during all the debriefing. So it was a wonderful lesson for a pediatric emergency medicine fellow, really challenging, but he had to stop the project, come back to the IRB, and basically is going to be restarting with a psychologist helping out to deal with some of the potential for secondary harm. Long answer, sorry about that.
And the other point is very important when you teach simulation, that beside the relationship, that the preparation pre and during the simulation and after the simulation, because sometimes it's when they feel they're safe, even if you say it like you maybe not be safe, but when they feel that you're genuine with that, they will be more engaged and they will not feel threatened. So it's going to be like safe environment, although it's for them to learn and experience their learning opportunity. Another questions? So I have a question regarding COVID and COOP. So is it
the word?
COVID? What is it?
COVID.
COVID. So is it the same treatment as in COOP, or there's a difference in management? It's like COVID and COOP. So is it mixed between both, or just only we can treat it? Because we have a lot of cases actually with COVID and COOP, like with the new Omicron viruses comparing to the Delta before.
Right. Yes, no, it's a great question. And the treatment is the same, because if you think about it, it's the mechanism of the pathophysiology is essentially the same, whether it's COVID, SARS-CoV-2 virus or para-influenza virus. You have a virus that's attacking, the airway mucosa, causing airway edema, and that airway edema is then leading to turbulent flow, causing, stridor and croup. And so pathophysiologically, these are similar, and so therefore the treatment approach is going to be similar. The goal of the dexamethasone, decrease inflammation, and inflammatory modulator. Goal of racemic epinephrine is topical to increase laminar flow through the upper airway. So the approach should be the same. Of course, the guidance around quarantine and contact and whatnot will be different.
And did you notice the difference between the incidence of admission for them comparing to the other with other viruses?
So I don't think that data has been fully elucidated, but that one study, that pre-publication study, there was an orange line that was on the bottom where you saw a little bit of a peak of hospitalization, but nowhere near the large peak of kids that just came to the emergency department. So I think there was definitely increase in hospitalization, but that was largely more due to the increased absolute number of cases rather than the fact that, COVID-induced stridor or COVID was somehow different or more severe.
Just to make a quick comment on that. So I think he alluded to this in his talk, but I think particularly for the students, so the fact that the trachea has a much wider diameter in these older patients and it's occurring in older patients, I think is why we haven't seen as much increased admission, because compared to para-influenza, I would say my experience and some of the evidence that was presented is that we're seeing an older population that can likely tolerate it a bit better.
Thank you so much. Any other questions? Sure.
I don't know if it is a notice, it is a comment, small comment. I don't know if it is important or not. I'm working in the ICU unit. Really, during the second surge of COVID-19, we saw many newborns with COVID confirmed positive came with apnea and cyanosis. And most of them on conservative treatment only just for oxygen, either on CPAP or free flow oxygen improved. Only during the second surge, Omicron. We did not notice this. Thank you.
It's fascinating. I don't know that data in particularly well. I think that it likely is related to the fact that, you know, we know that Omicron has had different transmissibility and different, you know, sort of pathophysiology of attack compared with Delta or Alpha earlier in the pandemic. But that's interesting, and I appreciate that comment. I can't say that I know the data all that well on that.
I think we can conclude. So thank you very much for the audience and for the speaker. Oh, there's another question, sorry. I think, yeah, we have time. So this is our last question.
My okay, working?
Yeah, it's working.
Case patient threatening, I mean, respiratory compromise. If the patient is respirating, but the patient is deteriorating, my question is early intubation is better than late intubation, especially that if delaying the intubation may cause some pressure on the treating physician.
So I'm going to repeat the question. So if we have a pediatric patient who's in respiratory distress and he needs to be intubated, is it early intubation better than late intubation?
So I think that to answer that question, it's really situational. And I think it depends on all the factors that we talked about, both during the respiratory failure, you know, lectures yesterday and the upper respiratory. It's a little bit of like Goldilocks. You know, the decision to intubate has to be just right. And so I think that in most situations, if you are able to oxygenate and ventilate using non-invasive means, that is almost always better than going through the process of intubation, you know, including the medications, paralyzing the patient, inserting the tube, and then having, you know, our critical care colleagues then manage and ventilate that patient if we didn't need to go that direction. That being said, if a patient is not oxygenating or ventilating, or they are truly, you know, have no reserve to be able to maintain that ventilation, even in a non-invasive, then I think you intubate as soon as you are starting to see those signs. I don't know if others have.
Yeah, I just wanted to come back to the resuscitate before you intubate and getting a bag valve mask. And I'm not sure what level of training you are, but I would say the #1 skill, connecting this to my talk, would be good BVM and understanding positioning, how to open the airway, how to use airway adjuncts. Because if you intubate a patient in respiratory failure without appropriately oxygenating them and ventilating them prior to that intubation, that's going to lead to an arrest. So I would say that, you know, delayed intubation is in the eye of the beholder probably. And if you want to do mechanical ventilation, which I think is what you're suggesting you want to move towards, that can be through a non-invasive technique like CPAP or BiPAP or high flow, but don't forget the basics. And I think that oftentimes we see that where when a patient has crashed, we haven't appropriately prepared for the intubation.
Just about the situational part, you know, again, it depends on the natural history of the condition. If a patient has just had a prolonged seizure and is apneic, then the likelihood is that in a few minutes he will, you know, the apnea will finish and he'll start to breathe again. So here you can take a pause and try not to intubate right away. But if it's a severe traumatic brain injury where the patient is deeply unconscious, on the AFBOO score, he's only responding to pain, moving towards unconsciousness, then you know that the patient is going to need intubation for further imaging, et cetera, stabilization. So you would not want to wait too long. So, you know. Yeah.
I will just add also one point. Pediatric by default is a difficult airway. So the expertise of the person who's going to intubate is very important. So if you think that you're not the expert one in the room, then probably ventilate, back valve ventilate, don't jump and intubate because this can make it a very chaotic and very difficult situation.
Yeah. And one of the first questions that many of us will ask is how long can you bag for? Pretty much forever.
Yeah.
That's what I was going to add, and you know, Manish is, as our EMS expert is not here right now, but there's been a real move away from having children intubated in the pre-hospital setting, because what has been shown is that the rates of error, esophageal intubations, airway edema secondary to traumatic intubation attempts in the pre-hospital setting in children has actually then made a difficult airway a near impossible airway by the time that they arrive to us on the scene. So there's a real, to Dr. Auerbach's point, there's a real move to basic bag valve mass ventilation, open the airway, and get the most experienced person to secure the airway if needed.
I would like to thank the respective speaker for their excellent presentation and also the audience. I think we have now a break and then we'll move to the workshop. Thank you so much, everyone.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, I am Rawabi Al-Biladi and my colleague Noura Al-Rifi. We are a sixth-year medical student from Taiba University, Al-Madina. At the first, we want to express our happiness and we are honored to have this opportunity to be presenter in this big conference and in front of your kind presences. We are here today to represent our research poster, which is about impact of COVID-19 lockdown on children with type 1 diabetes and their family in Al-Madina. In late December 2019, COVID-19 started from China and then spread throughout the world. On March 2020, this virus is declared as a pandemic by WHO. In our country, in KSA, there were many precautions were taken to control the spread of this virus. including national lockdown, which is applied on April 2020. Type 1 diabetes is one of the most common chronic disease, and it has a high prevalence in our country in Saudi Arabia. We found a lot of studies regarding the impact of COVID-19 lockdown regarding type 1 diabetic patient and their family in Al-Madinah, regarding the adherence to medication and lifestyle habit, and development of acute diabetic complication. The type of our research is a cross-sectional qualitative study. Our responses were 200 children whom on regular follow-up in diabetic educational outpatient clinic in Medina and Children's Hospital in Medina, using online questionnaire, which is filled out by their parent. Our result: we asked the families to assess the adherence of their children regarding taking medication on time and monitoring blood glucose, and notice the symptom of hyperglycemia and symptom of hypoglycemia, and also the lifestyle habit regarding the diet and exercise. We instructed them to choose one answer from always, most of the time, sometime, never, and rarely. As we shown in the figure 1, we display only the percentage of patients whom answer always in all answers. We found that the percentage of patients whom taking medication on time and monitoring blood glucose always during the lockdown is decreased during the lockdown in comparison to before. In contrast, the percentage of patients whom experiencing symptom of hyperglycemia was increased during the lockdown in comparison to before. For a lifestyle habit, diet, and exercise, almost according to our research result, it not changed, not affected by the lockdown. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am Noor Rifi and I will complete the result. Okay, in the first table, we are make a comparison between the participant and on the adherence in the medication and lifestyle score, as well as on the daily average blood glucose level during COVID lockdown period and before. And according to the BER-T test, we found a significant differences in both of them, as the p-value was less than 0.05. And in the second figure, it is talk about the effect of the COVID-19 lockdown period on the family of these children with type 1 diabetes. And as we see, 32 of them feel stress from the virus itself, and 34 of them feel increased responsibility of the children with type 1 diabetes, and 54.5 of them feel fear from this virus and effect of it on the children with type 1 diabetes, and 19 said that does not affect it. And in the second table, we calculated the differences of the average blood glucose of each patient in this study before and during a lockdown period, and in the different variables. Regarding these variables, which are complication of the diabetes and following the recommended diet and take the medication on time. All of this was a significant differences, as the p-value was less than 0.05. In conclusion, the closure of the COVID-19 was effect of the children with type 1 diabetes and have a major impact in form of increase the level of the blood glucose and decrease the compliance of the medication, lifestyle habit, as well as a healthy diet. Thank you for listening us and getting us this experience. And we hope you enjoyed with us, and we are really appreciate it. Thank you.
Good evening. My name is Ahmed Al Nawasra. I'm a PICU and emergency clinical nursing instructor. I'll be presenting the assessment of critically ill child. So at the end of this session, nurses will okay, just for some technical problem. Let me just have, give me 1 minute to have the control. Okay, so at the end of this session, nurses will be able to assess a critically ill child, use, evaluate, identify, intervene approach, determine life-threatening emergency, and re-evaluate treatment effectiveness. What I'll be using in this session, I'll be using the pulse systemic approach, which is the basic, advanced life, pediatric advanced life support. So I will be depending initially on something they call it the first look or the initial impression. The initial impression will be depending on something they call it ABC. So ABC, what's ABC? It is appearance, breathing, and circulation. And why ABC? Because ABC give me a quick reflect about my patient, how sick my patient, to make a quick decision, and how I need to assess this patient later on. So as I mentioned, ABC is appearance, breathing, and color or circulation. In appearance, I have to see if my patient is conscious, which is the normal thing, or he has decreased level of consciousness, lethargic, obtunded, or if he's unconscious. And in breathing, I will see if the patient breathing normally, or he has increased work of breathing, decreased work of breathing, or he's apneic. And in color, I will see if the patient is pink, normally, or normal color, pale, or he's cyanotic motile. I colored the ABC, in A in appearance unconscious, and in breathing apneic, and in color cyanotic motile in red, because this will tell me that I have to perceive my patient in a very quick way, which is what is the known to evaluate my patient and to assess my patient in a BLS setting. So always I will use evaluate or assess, then identify and intervene approach. And from the beginning, I always will have a 3 different thing or 4 different things, either life-threatening problem, respiratory distresses, respiratory failure, or possible shock. My possible intervention will be immediately oxygen saturation monitoring, monitoring vital sign. I might assess ventilation or bag a patient, and I might do a BLS sequences. So as I mentioned in the beginning, in ABC, if I find the patient is unconscious and or apneic and or motile cyanosed, I have to assess him using BLS approach, which is assessing consciousness. If he's unconscious, I will call for help. Then I will check the breathing and circulation. If patient is not breathing and he's having no pulse, then I have to activate code. But if there is no apnea and patient is having some level of consciousness and he's not cyanotic motile, then I have to assess my patient using the primary assessment, which is the ABCDE. So A stands for airway. I have to check the airway in 3 things: if the airway is patent, clear, and maintainable. Then I will go for B, which is breathing. I will, in breathing, always in a children, I have to expose his chest and see or assess his RR, for 30 to 60 seconds. Count the RR and check the breathing pattern. Check the symmetry of the chest rise. Check the effort if he's using accessory muscles. And check the saturation and auscultate the patient. In C, which is circulation, I will check initially blood pressure, then heart rate. I will check the perfusion, looking for Cabri feel, central and peripheral pulses, limb warmness, and color. And D, disability, I look for level of consciousness, pupils, and glucose. And in exposure, I will check the core temperature, rashes, and trauma. Again, I will, after each assessment or each evaluation, I have to do identification for my problem and intervention. So the assessment, what I did now is just the ABCDE. Identification could be respiratory distress or respiratory failure, hypotensive shock or compensated shock, or maybe rhythm disturbances. This is some of the possible findings. So possible intervention, if there is a problem with the airway, then I might do a maintenance of the airway and suctioning. I might maximize oxygenation. So patient like in low flow, I'll put him in a high flow or non-rebreather. I might assess ventilation. So initially, maybe I put patient on oxygen, but I find patient despite of high flow oxygen, he's still desating, then I might assess his ventilation or bag him. Fluid boluses, if patient is having hypotensive shock, then he might require a fluid boluses. And always when I do any of these intervention, I have to evaluate my patient using ABC plus level of consciousness. ABC is airway, breathing, circulation plus level of consciousness. So I will go on a next assessment. Remember, identify, intervene, and evaluate. Next assessment will be using sample, which is sign and symptom, looking for sign and symptom, what's happened to my patient recently, allergy, if he's having any allergy, if he's on any current medication. I look for the past medical history, and I will check when was his last meal for the patient if he's requiring some fluid or some energy, and I will look to the event led to this sickness. Again, evaluate, identify, intervene. So I did the evaluation, which is the sample. Identification will be a possible finding is the respiratory distress related to, let's say, upper airway obstruction manifested by a stridor, or respiratory distress related to lower airway obstruction manifested by expiratory wheeze, or respiratory failure related to lung tissue disease. Let's say patient aspirated, he vomited and aspirated, or respiratory failure related to disorder control of breathing. Patient had a convulsion, he had a head injury, or he received some sedation. Could be also a hypotensive compensated hypovolemic shock, or hypotensive compensated septic shock or distributive shock, or hypotensive compensated cardiogenic shock, or hypotensive compensated obstructive shock. Possible intervention could be racemic epinephrine if there is, like, I'm suspecting allergy and upper way obstruction. Albuterol if I'm suspecting like lower airway obstruction, and I'm using albuterol and Ventolin. I might do septic workup using antibiotic and antibiotic if I'm suspecting patients having like septic shock. Using antidote if I know that there is some toxins. Sometimes I need to intubate patient if he was prolongedly bagged, and sometimes I need to give and repeat the fluid boluses. Next assessment, again, I could do head-to-toe physical assessment, because there's sometimes in physical assessment, I find things which is not discovered during the previous assessment, which is I use in the head, nose, mouth, and mucous membrane. I check for the symmetry of the head, any trauma of the head, any nasal discharges. I'll check the mucous membrane if it is pale pink, if it is dry. In the neck, I will check if the trachea midline. I will check if there is jugular vein distension. In the chest, I will check the symmetry of the chest. I will auscultate lung and heart. And in the abdomen, I will auscultate abdomen, checking for peristalsis. Then I might palpate to check for tenderness and organomegaly. And extremity, I will check for fractures and trauma. Possible finding after, which could not be again found, hypotensive compensated hypovolemic shock manifested by a dry mucous membrane, hyperactive bowel signs due to, let's say, diarrhea, sunken eyes, or sunken fontanelles. Hypotensive compensated cardiogenic shock. So I find in my physical assessment, I find bibasal crackles, hepatomegaly, jugular vein distension. Or hypotensive compensated distributive shock. There is a bounding pulse, brisk cab refill, warm extremity, low blood pressure with a high heart rate. Or hypotensive compensated obstructive shock manifested by asymmetrical chest rise or asymmetrical neck or neck deviation. Again, possible intervention could be a fluid boluses, repeating fluid boluses, inotropic support, or using a needle decompression. Diagnostic assessment, when I stabilize my patient, or like if needed, I could do ABGs, VBGs, send for CBC renal profile and electrolytes, do chest X-ray and do ECG. And if I'm suspecting any trauma, I might send patient, like especially head trauma, I might send patient for immediate CT head. Any question? Khulud? So just one minute. Okay, I'm done with my session. If there is any question, so I could answer a question. Otherwise, there will be two more poster presentation, then we are done. Okay, thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. My voice is clear. Ms. Khaloud, hope that my voice is clear. Today, I'm going to introduce myself. This is Abdullah Al-Mansour, X-ray specialist. I would like to welcome all the attendants in this 7th International Conference in Pediatric Emergency Medicine. Today, I'm going to try my best to be briefing regarding tomography, computed tomography. This is an introduction. Computed tomography, it means the production of X-ray for patients in hospitals. And as we can see in the slides, Siemens introduced the first commercial CT scan system in May 1974 called the Seritom, and the first unit could only image a patient's head. These early units took several minutes to acquire imaging and data, and several minutes to reconstruct the data. This is the image of the Seritom in 1974. Next slide, Ms. Khulud. And the latest multi-slide CT scan system images the entire chest in less than 10 seconds and reconstructed the image in similar time period. The faster the system, the higher the volume of the patients, and the faster the system is the development of new techniques. Next slide. And radiation risk. Risk is proportional to absorbed dose. Risk is quantified by determining the effective dose and is expressed as millisievert. And this is the abbreviation. Atomic bomb survivors who experienced that were slightly higher the doses they encountered in CT demonstrated increased cancers from 5 to 10 to 20 millisievert versus 1 to 10 in hospitals. And the effective dose were from various diagnostic procedures. Next slide, Ms. Khulud. Yes, thank you. As we can see here, the head X-ray is 0.1 millisievert, and the chest X-ray, and the rest of the abdomen X-ray, upper GI exams, as we can see, 5 millisieverts. And what is exceeding that limits will be dangerous for the patient. Next slide, please. And this is why the new CT scans rules. The current ionization radiation rules 1974 released. The lack of rules at that time specifically regulating CT, and the patient dose from CT leads to irregular X-ray exams. And the higher the dose, the higher the risk of the cancer. And the other point is technological advances. As we can see, the revolution, increased use of CT scans. The use of CT scans is expected to continue to grow, and the last is 48%. All exposures comes from medical sources, and 49% comes from CT. Next slide, please. What rules are we proposing? We are proposing the first one is purpose and scope and exemptions, and personnel requirements, equipment requirements, quality control programs, facility design requirements, and surveys for any extra troubles regarding the CT scans. Next slide, please. The exemptions, purpose and scope specify that the rules apply to all registrants who use the CT system for the international exposure of humans for the purpose of diagnostic imaging. And the second point is this would exempt BT and CT and the SPECT unless the CT portion of the system is used for diagnostic imaging, and the other exemptions, specific exemptions for CT scan systems with power ratings of 5 kilowatts or less. Next slide, please. And the personnel requirements. Requirements for personnel to be protected against any harm from X-ray exposure is interpreting physicians, radiological technologists, and the medical physicists. Next slide, please. Quality control programs, which shall be established and implemented under the supervision of medical physicists. Medical physicists must perform an initial or acceptance test for each CT scan system prior to use on patients. Medical physicists must perform an annual evaluation of the CT system and quality control programs. And the last point is facility conducts a continuous quality control programs designed and overseen by the medical physicians. Next slide, please. The facility design requirements. Enclosure must be met with the requirements of rules 325, and the operator must be able to operate the equipment from a shield position, and the operator must be able to communicate with the patient from the control panel. Operator must be able to see the patient from the control panel. Electronic viewing systems must remain operational or must be repaid for before any further examinations are performed on patients. Next slide. Thank you for listening. Any further questions?
Assalamu alaikum. Good afternoon. My name is Abdullah Muhammad Al-Hasnawi, Senior Hospital Administration Specialist, MSD, Riyadh. I will talk about pediatric emergency care principle, abstract, the multiple disease, the physiological and anatomical change that occur in it, and the special physiological, emotional, and communicative features of the children make pediatric emergencies and a special challenge for emergency physician. Common non-traumatic pediatric emergency can come into 4 cardinal manifestations: respiratory distress, altered consciousness, seizure, and shock. Objectives to understand: number 1, to understand the significance of the special physiological and anatomy of child as they affected the performance of important emergency medical techniques. 2, to be able to classify pediatric emergencies by their major manifestations. 3, to become conversant into the basic strategy for dealing with the pediatric emergencies. Methodology: using the lectures review approach, this research focus on all the articles and paper published on the pediatric emergency care, such as PubMed, Science Direct, and MBase. About clinical assessment and measurement of the vital signs, aside from physiological examination, the initial evaluation include ECG and pulse and non-invasive manual measurement of the blood pressure. Therefore, the initial assessment of the child overall conditions of the crucial importance. Venous access. In the treatment of the pediatric emergencies, it is recommended the vascular access should be obtained by the intracis route after maximum of the 3 unsuccessful puncture attempt or 19 to 120 seconds of trying. Airway. The child airway has a number of special characters that need to be considered by the physician take care of the respiratory emergencies. High position of the lungs, large tongue, infants and toddlers should be presented in the minimal extensions. Medication, there are many special pharmacokinetic consideration in the childhood relating to, among other things, volumes of the distribution, protein binding, metabolic rates, and the degree of the permeability of the blood-brain barrier. Conclusion and recommendation: knowledge of the basic working techniques and typically clinical science enable to the physician to proceed with the confidence when the treating pediatric emergencies. Vascular access play a key role in the emergency medical care and is often relatively difficult when the patient is severely ill child. In the emergency situation, therefore, the options of intracis access should always be those of the early. Medication dose are usually calculated according to the child body weight, lasting the reference. And thank you for listening.